been developed in our simulation group. This group is ruled by the cardiothoracic anesthesiologist of our institution, and I want to introduce them. They are Juan Perdomo, the actor, Manuel Lopez, and Cristina Ibañez. And on behalf of them and on my own, we want to deeply thank Dr. Agomar that she was the starting spark of our simulation group, and she's a huge example of excellence and well done work. Thank you very much.
So I'm going to discuss, and just from here to save a little bit of time. Excellent. It was very neat to see it, and I think you've highlighted the issues of simulation, as the issues of cost and the issues of fidelity and reproducibility, as well as availability. And so it's a model that seems to speak to all of it. I have a few questions. My first is, what is the cost of the total cost of that model to put together?
The beginning version, it's 40 euros, but then it's even cheaper because when you have the silicone gun and the pumps, you don't have to buy it again.
Right.
So we use the empty bladder wash bags that we took it from urologist department. Yeah. We asked the nurses to take there, not to throw it. So we every week go to take them, and that's all. We don't need too much.
And you just have the Mercato right around the corner to get the. That's my second question comes to that is I think one of the the back part of the ribs and the chest wall is very doable, and that looks like you've got good fidelity. But did you get feedback from the students or from people who used it in terms of using the pigskin is a really wonderful way of doing that?
Yes, but there is a tip with the pig skin. We use belly pig skin. So at the beginning, we have to change the way that we use it because it is too thick. So it's important to slide it in the middle to have a thinner skin, just 1.5 centimeters more or less. So you have to have the skin, a little bit of fatty, and a muscle. Because when we do it only with the skin, it was not so realistic. But when we do it with all the belly skin, it was too difficult to perform the technique.
And my last question is, I didn't see it on there, but thinking of the actor sitting there with young trainees putting this here, what's in the back? Do you have what is the protection at the back?
I've been the actor many times. And you feel very, very safe because you have the acetate, so you feel that they are pushing, but you don't feel anything more.
Okay, so there's not a back wall to this.
No.
Okay, well done. That's very excellent. Thank you very much.
Thank you very much.
Next video is neuroplasty of the phrenic nerve for diaphragm paralysis secondary to Parsonage-Turner syndrome, presented by Audrey Pendleton.
The patient is a 64-year-old man who fell backwards and presented with dyspnea a few weeks later. An extensive workup revealed an elevated hemidiaphragm, a depressed FEV1, and an hourglass constriction of the right phrenic nerve on high-resolution ultrasonography. When conservative management failed, surgery was recommended. He was in the supine position with the SCM, sternal notch, and clavicle and acromion marked on this diagram. We performed a standard supraclavicular exposure of the right phrenic nerve that runs along the anterior scalene muscle. Once the nerve was exposed, we divided the transverse cervical arterial branches to increase the exposure. The neurosurgeon then incised the epineurium using an 11-blade scalpel and micro scissors under high magnification microscopic view. The fascicle gently begins to herniate out as the epineurium is opened. Once the epineurium is opened, the hourglass constriction is exposed. At this point, the perineurium is opened up, which is responsible for the hourglass constriction. In doing this, we see the fascicle contents herniate out, indicating that they were under pressure. The incisions of the epineurium and perineurium are extended longitudinally along the nerve to decompress the nerve fully. Once complete, the nerve plumps up and returns to its normal size. Hemostatic agents are placed in the wound to avoid any electrocautery near the nerve. The wound is closed in multiple layers. The patient did well postoperatively and was followed as an outpatient. By 1 year, his FEV1 is approved and the right hemidiaphragm is back to its original position. Phrenic neuropathy is a presentation of Parsonage-Turner syndrome, an autoimmune condition that attacks the peripheral nerves. When conservative treatment fails, surgery is indicated. Improvement in symptoms is often seen within 1 year, as are the diagnostic studies, including FEV1 and the X-ray indicating a resolved elevated hemidiaphragm.
Yep.
Doctor,
Well, the case is very interesting, really, and the unusual presentation, obviously. The ultrasound for diagnosis was a good choice, and in fact, I was able to locate the site of the injury, and the surgical approach was correct and allowed good exposure of the anatomical elements. And as you could see in the video, the surgery was performed with great precision, and the patient had no postoperative complication, which allowed for the patient management. And the long-term result was 100% recovery. In summary, good case, good diagnosis, good surgery, and good result. Congratulations.
Thank you.
Great, thank you very much.
Thank you.
We'll move on to the next video, which is the biportal robotic right S2 and S3 bisegmentectomy in a COPD patient with B1 anatomical variation, a complex and uncommon combined segmentectomy from the University of Bielefeld in Germany.
So we present a video from a 62-year-old patient with a gold stage 2 COPD, which had a suspicious lesion. Can we play the video? Between the S2 and S3 on the right side, which had grown up according to follow-up CTs performed to the patient pneumologist in a period of 3 months. The patient had also an anatomical variation of the B1, a separate origin, and we decided to perform a biportal combined S2, S3 segmentectomy with the robot. And in order to optimize the surgical planning, we did this 3D reconstruction with materialized software. We see where the lesion is located, very bad located, in order to spare some lung tissue. We confirmed the separate B1. And I think the Da Vinci robot is the best for these kinds of uncommon segmentectomies. The first step, we are performing this biportal. The first step was to try to locate where where the lesion was, make a mark with the electrocautery and prepare the structures. Here we see the venous vein, B3B. Important to identify the V1, and then we went for the artery on the front. And we saw the A1 and the common trunk for the A3 and the recurrent A2. Then we proceed for the division of arterial common trunk, and we use for the whole procedure robotic stapers. After that, we went to the fissure in order to locate the interlobar artery. And then we went to the posterior pleura to prepare the bronchus and take those lymph nodes out to make the dissection easier. Patient underwent an EBUS before the operation. Lymph node stations were negative, but we sent those lymph nodes also to frozen section, which was negative, of course. Then we saw this division of the common trunk B2, B3, with exposure of the A2, which was also divided. And then we went for the anterior fissure in order to expose the veins, which had been seen here, always taking care of the B1. Then we apply ICG, and lung revitalization in order to clearly define the segmental limits. And we complete the parenchyma using also robotic stapers. After that, we complete the lymphadenectomy, and then we send the piece to frozen section, which confirm an adenocarcinoma. And then we have the S1 preserved, and this view that correlates perfect with the 3D software reconstruction. We proceed to reinflate the lung with a good result. Patient was staged as 1A2 and was discharged on the 5 postoperative date, and this is the X-ray on the discharge date. Thank you very much.
I invite Dr. Bott to discuss this.
Great. Excellent video and a really nice case, and I think it sort of speaks to that idea of precision surgery that we were talking about earlier in the meeting, really just removing the part of the lung that needs to be removed and preserving the remainder. I have a few basic questions. It seemed like the bronchial anatomy in this case may have actually been helpful because you only had to divide one bronchus rather than taking each of the segmental ones. Can you comment on that a little bit?
Yes, that was one of the findings that make us choose the decision to perform the S2, S3 segmentectomy, because we knew that the V1 was there and it was going to be a little bit more easy to find it. Mm-hmm. So you're right, it was some finding that support the decision of making this procedure.
Mm-hmm. And then it seemed like sometimes when you leave that single S1 segment, it's a little mobile. I'm just wondering if you ever worry about it torsing or twisting. Do you think about pexying in any way, or it usually maintains that shape? Okay.
Yes, you're right. It was moving, but when the lung was completely inflated, and if you see the video, the patient has also in the CT scan emphysema in the superior part. So I think in this case that helps because the lung has no no empty hole. So the middle lobe and the lower lobe and the remaining S1, they fill up the cavity. Mm-hmm. And that was, after I see the lung being reinflated, I had no worries about that.
Mm-hmm. And you mentioned in the video localization. Do you ever think about using ICG or some sort of injection, beforehand to localize the lesion, just to make sure your margin is sufficient before you actually send it to PATH?
Yes, that's a very good alternative in this case. I try to palpate, and in case that I didn't palpate it, I will have some trouble. But in this case, the lesion, I could intuitively feel where the lesion was with the finger.
Great. Okay, I heard the timer ding. So very nice video. Excellent job. Thanks.
Thank you very much.
Next video will be robotic portal left main stem bronchus sleeve resection by left transthoracic approach, presented by Yusuke Sumiya.
Thank you for giving me the opportunity to present here. I submit the slide with a case presentation, but this is not allowed, so nobody tell me until morning in this unkind situation, so let me introduce the patient background shortly. Patient is a 70-year-old woman who had a past history of right upper lobectomy for lung cancer. And she was referred to our hospital to further investigation to bronchial tumor. Or we plan to robotic surgery, sleeve resection for the left main stem bronchus. So can you start the video, please? We started the operation using the Da Vinci Xi. First, to expose the left main bronchus, we performed the lymph node dissection for station 7. We dissected between esophagus and bronchus, and then station 7 lymph node dissection was completed. Next, we performed the PA isolation from around tissue. We dissected the seeds of PA using the electrocautery, and assist arm retract the lungs for head and the ventral side. So next, we perform the PA isolation. The assist arm holds the lymph node of station 10, and the left arm makes a good view, and the direction dissection of station 10 lymph node was completed. And the next step is bronchus isolation from PB inferior. This is main bronchus and the inferior PB. And the thoracic condom from assistant makes a good view for this scene. The PV inferior and the bronchus were isolated by electrocautery. After isolation of main bronchus and the isolation of PV, to define line of dissection, a 25-gauge needle was inserted from the thoracic cavity into the left main bronchus, and the tumor location and the puncture site were confirmed using bronchoscopy. In the scene, we could see colina and the right main stem bronchus, and one ring from the colina of the left main bronchus was dissected using robotic scissors. And the next scene, we can see a tumor in the left main stem bronchus. And we dissected the distal sides using robotic scissors. And the next step, the anterior side is slightly long, so we trimmed the distal bronchus using robotic scissors. After confirming negative margins, a bronchial end-to-end anastomosis was performed by running suture using a ligated one-ended RB1 protein which adjusted to 14 centimeters as a double-ended needle. Maybe next scene showing the knot of ligated protein. This is ligated point. The anastomosis was performed with running suture from the anterior side to posterior side using a robotic needle driver. We have some difficulties in each side. First, we have only small working space when we suture the anterior side, so assist arm is important to have a comfortable working space. So after the anastomosis for the anterior side, this is the posterior side anastomosis. This is showing the structure of posterior side, and the second difficulty is that we could not see an intrabronchus, so we think larger needle like SH1 needle is available, favorable in this scene. Finally, we ligated the strings. In this scene, we should confirm the condition of strings because the tactile sensations are not transmitted to the surgeon by robotic approach. This is most important side. Anastomosis is finished. And after that, we performed the sealing test. And the sealing test showed no evidence of air leakage. Okay, video is finished. Thank you.
Thank you for a nice and beautiful video of the sleeve resection of the left main bronchus. You demonstrated the full advantage of the robotic surgery. That is full great freedom of the instrument manipulation. As I have one question about suturing technique. As you mentioned, you used running suture is preferred, I think, instead of the interrupted single knot anastomosis, especially in bats or rats, to avoid the tangling of the thread. Yeah. But in the running suture method, it is rather difficult to eliminate or loosen the thread, especially, as you mentioned, the loss of the tactile sensation with robotic surgery. And sometimes the ligation is too tight to cut the cartilage. That is a great problem during surgery. how do you manage in this operation?
We usually use double-ended 4-0 proline adjusted to the 75 centimeter in the thoracotomy, but it is too long to use robotic surgery, so that we made a double-ended needle as, 14 centimeter adjusted the 3-0 proline and ligated and double-ended needle it used. So the length is the best situation for the robotic surgery, and the knot is the fix the tension, and it allows to the good anastomosis, I think.
I think that it's difficult to the anterior side of the anastomosis that is not seen in the after completion of the anastomosis.
So maybe anterior side have narrow spaces, so the RB1 needle is allow us to flexible anastomosis, but we cannot see intra-lumen of the left main bronchus for the posterior side, so that we have to use the mix of SH1 and RB1 needle is very useful, I think.
Thank you. I think, in my opinion, the surgeon who is fully expert at the robotic surgery has some kind of tactile sensation under the visual input.
Yes.
So, thank you.
Thank you so much.
Great. Thank you very much. Our next video is the UVAT's right upper lobe sleeve lobectomy in a difficult case, and coming from the Royal Infirmary in Bristol. Dr.
Morning.
Safdie.
Thank you for having me. Can we play the video, please?
The following video demonstrates a uniport VATS right upper sleeve lobectomy. The patient was a 68-year-old male with biopsy-proven endobronchial squamous cell carcinoma. He was a current smoker with COPD and high cholesterol. His DLCO was 60% and Thoracic score 2%. The CT scan demonstrated a right upper lobe endobronchial lesion causing right upper lobe collapse, AVID on PET CT. The positioning is right lateral following lung isolation, and the incision extends anteriorly from latissimus dorsi in the fourth intercostal space. On entry, dense adhesions were divided using a diathermy and harmonic scalpel. Once free, the lung was retracted posteriorly and the anterior superior hilum was exposed. First, we see the station 10 lymph node, which is carefully removed, bringing the truncus anterior into view. A posterior plane is then created with a right angle to allow circumnavigation and subsequent vision using an endo-GAA stapler with a vascular reload. Dividing the truncus anterior first enables room for the stapler to be used to divide the superior pulmonary vein, improving access to the main PA and revealing more branches. Development of the horizontal fissure enables this branch to be identified as the posterior ascending branch. Then, tunneling and dividing the lung parenchyma above the PA enables access for its subsequent division. Now, the vessels to the right upper lobe have been divided. The next step is to free the right lower lobe to enable the creation of a tension-free sleeve anastomosis. Chest wall adhesions were divided and the inferior pulmonary vein was taken down, harvesting station 9 en route. The mediastinal pleura was then opened to the secondary carina, and the right upper lobe bronchus and bronchus intermedius were identified posteriorly. Anteriorly, the bronchus intermedius is identified lying posterior to the PA. The posterior oblique fissure can now be completed safely, avoiding any important structures. A lymph node grasper tunnels above the bronchus intermedius, creating a plane for the passage of an endo-GI stapler with a purple reload. Completion of the posterior fissure enables access to the posterior part of the bronchus intermedius, which is then further developed by removing excess tissue and then creating a posterior plane behind the bronchus intermedius with a right angle. Following this, a scanning scissors was used to divide the bronchus intermedius, separating the lower and middle lobes from the right upper lobe. The fascia posterior to the bronchus intermedius is divided, and a large station 7 lymph node is removed. All of these steps are essential for reducing the tension on the subsequent sleeve anastomosis. The site for division of the right upper lobe bronchial tissue was marked using diathermy, and the right upper lobe bronchus was then divided again using scanline scissors. Once fully divided, the right upper lobectomy is complete and the sample is removed via an endocatch bag. Now, the sleeve anastomosis between the bronchus intermedius and the right main bronchus can be formed. The first step was to remove any uneven edges which may compromise the quality of the anastomosis. Now, the suturing begins using a continuous 3/0 proline double-ended suture, commencing at the most posterior part of the inferior wall. The first suture was taken passing into and out on the right main bronchus, and then out to in on the bronchus intermedius. After the first stitch, the suture is passed through the parietal pleura. This acts as a follow, prevents tangling, and will be used later when anastomosing the anterior wall. This is an example of how to manage the complication of cross sutures endoscopically. They can easily be brought back with a hook and the previous stitch reattempted. It is important to remember there is diameter discrepancy between the right main bronchus and the bronchus intermedius. Hence, in order to form a pneumostatic anastomosis, the suturing must allow for this discrepancy. Taking slightly smaller bites on the bronchus intermedius. The posterior wall of the bronchus is anastomosed first, with a stitch running towards the operator. Every stitch is performed forehand. This improves the ergonomics of the procedure, as well as the overall quality of the anastomosis. Once the posterior wall was completed, the previously suspended suture was retrieved. The anastomosis was then continued on the anterior wall, this time going out to in on the right main bronchus and in to out on the bronchus intermedius. Suturing the anterior wall is far more enjoyable than suturing the posterior wall, but also has to take into account the conjugate discrepancy between the right main bronchus and the bronchus intermedius. Remembering to take slightly smaller bites on the bronchus intermedius. Again, the operator is always stitching towards themselves and forehand, improving the ergonomics of the procedure, reducing the time taken, and improving the overall quality of the anastomosis. To ensure a pneumostatic seal, the stitches are pulled through with a hook, and the anastomosis is then secured with multiple endoscopic ties. We took the approach of securing knots on 3 different sites on the anterior wall of the bronchus, theoretically distributing the tension within the anastomosis. Once secured, water inflation tests confirmed there was no air leak from the bronchial anastomosis, so the final retraction suture was cut, station 4R was taken, closure followed paravertebral and intercostal blockade, and citation of an intercostal drain.
Thank you.
Dr. Ismail from Potsdam.
So thank you for this nice video. I have some questions for you. Did this case receive any neoadjuvant therapy or not?
No. So this patient had a clinical stage of T1C and 0, and pathological stage of P, T2A, and 1. So he actually upstaged to what we thought, so he didn't receive any neoadjuvant.
Okay, because in the CT scan we see that this is like with maybe mediastinal infiltration or something like that. So all adhesions were just post-inflammatory.
Yeah.
Okay, good. And the other question, do you use here the fifth intercostal space,
So
as I see?
So I typically don't count. So it's either fifth or fourth, whatever gives me better access. So I would say in sleeves, it's both of the spaces can work. It's with fourth, it's harder to divide. It's easier to suture, but it's harder to divide the vessels, especially the trunk and the vein. So depends on I would say depends on a patient. Depends on how large the chest is.
Yeah, I think for the sleeve resection for uniportal, I think it's much better to get the fourth intercostal because you will not be having problems with the suturing and every time put the pulmonary artery on risk, you know. So I think the fourth intercostal is much better for sleeve resection than the fifth intercostal. And you use Prolene or you use PDS, and how long?
So I would, in a male larger patient, I would use Prolene 3.0 just because I like the needle more than a PDS 3.0. If we have a smaller patient or a smaller sleeve, then I use a PDS 4.0.
So you use usually Prolene, no?
Both. Depends on a patient, depends on a type of sleeve. In this case, the sleeve is quite large, and so I use a 3.0 Prolene.
Okay.
But sometimes I use PDS, yes.
And how long?
It's double-ended, so it's 70 centimeters, I think. I don't know.
79,
Yeah.
because for imported the 90 centimeters is much better, and that's why a lot are using Prolene instead of PDS for that, unfortunately.
It's usually quite enough, I mean, to tie the sutures.
And you never cover your anastomosis, is it right?
No, so I cover anastomosis only in a very high-risk patient. Let's say if it's a sleeve bilobectomy or a patient is diabetic, then I would take a muscle and wrap it around, but not routinely. In this case, no.
Okay, thank you.
Thank you.
The last video will be uniportal thoracoscopic resection for the spindle cell tumor of esophagus, presented by Haining Su. No, it's not here. He's not here.
He's only sent the video, so he's not here, but we're going to see the video.
Okay.
Okay.
So,
Great. Let's play Dr. Joe's video.
Okay.
Yeah.
So, Dr. Good, you have, yeah.
A one-way discussion, perhaps?
Well, it makes it a little difficult to have an intelligent discussion, but you might have said that that was going to be true anyway, right, Dr. Cerfolio, making the point. So this is described as a spindle cell tumor. I guess I'd make a couple of points. A leiomyoma is a spindle cell tumor, but not all spindle cell tumors are leiomyomas. And I'm not going to use my slides. I over-prepared for this. And because spindle cell tumors include a group of malignant tumors as well, as I think we're all aware of. But this was by the resection, I can tell it's a leiomyoma that's being resected. And I think the issues would be in terms of questions of which ones are worth observing, small, asymptomatic, and which ones should be treated. Those that are larger and or symptomatic. I'm not going to show the slides. No. And so this is obviously a fairly large leiomyoma being resected nicely. I would point out that there are techniques to try to avoid a mucosal disruption that we saw, a variety of techniques, including some inject the submucosa endoscopically ahead of time, and others do a combination of endoscopic viewing and dissect. So to avoid this aspect of entering the mucosa, which in larger series only occurs about 7% of the time. So I think a goal is certainly to do it without entering the mucosa. This was entered and was well repaired. And then a key point in the surgical approach is repairing the muscular layer to avoid a diverticulum, which can occur. But I guess the last point I would make, and a question I would have had, is the indications of a surgical approach versus an endoscopic approach, now with endoscopic submucosal dissection being one of the options for at least small esophageal leiomyomas that can be really resected completely endoscopically, and with excellent results. On the other hand, leiomyosarcoma, spindle cell carcinoma, really better resected with an esophagectomy.
Well done. Thank you. So we have a few minutes, I think, for a general discussion, and Dr. Cerfolio, why don't you lead us off?
So I'm very impressed with the talent of the surgeon and what you did, but I want to know why you made it all so hard. So Igor, I'll start with you. Why the hell do you do this from the front with the PA in the way of every stitch? Why don't you just do the anastomosis, like when you came to New York and watched us a few weeks ago, from the back, where my grandmother, my 2-year-old grandson can do it. The PA's never in the way. The anastomosis is done posteriorly when you do a sleeve. And then you never took the azygos, took the 2 or 4 and freed the airway up. You know, we make a big point to make a tensionless anastomosis. You got to free the trachea underneath the innominate artery, which you can do with the robot. You can drive the robot up to the guy's forehead. You can free the whole trachea up in a mediastinoscopy plane. We used to do MEADS. Now you don't have to do mediastinoscopy anymore because the robot can do that from you in the chest. And you got to free up where the right middle and right lower lobe bifurcate to bring that up. I didn't see that. So multiple questions here for you.
Yeah, no problem. Thank you. So first of all, for the front, because this was a VATS procedure, not a robotic one.
But VATS can be done from the back too.
Yes, but it would be harder. The reason why not robotically is because it's done 6 months ago-ish. So back then, I kind of started with the robot, and I consider myself still to be more skilled VATS surgeon than a robotic surgeon. So that's one. Secondly, I did release, it's just it wasn't really shown in a video, so it's quite important to release all the hilum when doing a sleeve. And I go all around it, it's circular. I just don't do it at the same time. I start with dissection and the division of the blood vessels. Then I do the fissure to leave the bronchus for the last bit. And just before that, I would release the ligament and the posterior part of the...
but I invite you to do the trachea too. Take the azygos, take the 2 and 4s, and free the trachea up as well.
That can be done. I think this is a decision which I make intraoperatively. If I have a large sleeve on a bigger segment of a bronchus, then I do a lot more of the freeing up the hilum.
But
yes.
You got to take the 2 and the 4 lymph nodes.
Yeah, absolutely.
Anyhow,
I did it after because it was tension free. So
I would say again, think about the conduct of your operation and how we can get better and faster. Why would you take the 2 and 4s after you do the anastomosis? Take the 2 and 4s before you cut the airway. Once you cut the airway, you lose your rigidity. Take the 2 and 4s, free the trachea, then cut the airway, then do the anastomosis.
It makes absolute sense. Just in this patient, it was really tension-free, so I just decided to do it later. But it makes sense, I do it, yes.
And then one quick question for our colleague about the left mainstem, Raizuki. It was a fantastic video. But why not put a big Penrose around the aorta and pull it out of the way, and a Penrose around the PA and pull it out of the way? Instead of working in a tiny hole, you work in a nice, beautiful space. Or do it from the right chest. Did you not go in the right chest because the patient had a right upper lobectomy? Is that why you went in the left?
Yes, thank you for your questions. And maybe this is the first case of the left main sleeve resection by a left transthoracic approach. But Dr. Iriarte from the Fox Cancer Chase Center reported a light thoracic approach, but maybe he used 6 millimeter lumen for the ventilation for the right side, left side lung, and but that is a bit disturbed from the anastomotic side. So maybe a left thoracic approach by robotic is very suitable because third arm can retract for the dorsal side to aorta, and we can see a good view on the anastomotic side.
Yeah, you did a beautiful job. It just was so hard. You could have made it so much easier with just a few tricks. Just pull the aorta out of your way with a large Penrose, and the same thing with the pulmonary artery. Get around it and pull it out of your way. Then it doesn't matter what size needle, and then you can let the resident do it because it's all set up. That's all. And the recurrent laryngeal nerve with a bipolar, with a unipolar. We saw a video. I would recommend a bipolar, not a unipolar, when you're near the recurrent laryngeal nerve.
Okay, thank you.
Thanks. Dr. Ishmael.
So I have just one comment to Serv's comments. I agree and disagree. So I agree that it's much better to make the lymphadenectomy prior to your sleeve. But I disagree to do it from behind, because if you do it from in front, like the usual uniportal and the anterior axillary line, and you take the fourth intercostal space, you go really exactly towards the anastomosis, and you have no difficulties with the artery, with the vein, with anything. If you do it from the posterior, you have problems with other structures, but in front, it is just go straight forward, and it is easy.
Okay, are you going to be at a video session later today? I'll show 4 or 5 movies. There's nothing in the back. Air. The only thing there is air. There's nothing unless the anesthesiologist sticks their hand in the room.
With a robotic, okay, I agree. With
there's
a robotic,
nothing
I
there.
agree.
It's much easier.
Dr. Remy?
Thank you very much. All the presentations were really challenging and extraordinary. I have a comment for the first presentation by Dr. Bicharila. I really enjoyed this double video comparing one situation with the other, but from your presentation I want to emphasize an issue that you briefly mentioned, and I would just want to highlight it. You did lymphadenectomy first. In 1996, when systematic nodal dissection doing lymphadenectomy first was the main recommendation. First, I think that you are all experts in this, but it helps you to dissect the elements of the pedicle, so the lung resection may be easier if you have already dissected the mediastinum. And in the occasional patient, if you find a suspicious lymph node and you have frozen section, if it is positive, that finding may prompt you to change the extent of the resection that you had planned before. So this is something I wanted to emphasize. I've seen beautifully made lung resections first, and then no lymph node removed from the mediastinum because the surgeon is already tired. These operations are more demanding than when you do a long, big thoracotomy. And I think that, we are human beings and we get tired after several hours of operation, and that important part of the operation sometimes is not done. So thank you very much for mentioning that.
Thank you for the comment. Just it's a thing I want to comment too, because we have this habit, because I can agree that sometimes we leave it for the final part of the surgery, but I think here at the robot, when we introduce the program, we normally start by the lymphadenectomy. In this case, it wouldn't affect because we knew that it was an N2 affection, so it wouldn't normally it wouldn't change our planned surgery, but it's, the important reason is that helps us to make the posterior resection easier. Having all the posterior pleural dissection before all the anterior helium, it helps us. So it's a habit we have.
Excellent. Perhaps I just want to go back to one of the points that that Dr. Bott brought up in your presentation. If you were fortunate enough to have your situation after reinflation, that your S1 was being nicely nestled by the lower lobe and the middle lobe. If that wasn't the case, what was your strategy for pexing or for securing and avoiding the torsion of what looked like quite a mobile segment?
Yes, that's a very good question, and to the matter of fact, this anatomical variation was an advantage for the planning of the surgery and to perform the surgery, but was a disadvantage for this situation, and that was my worry. So I was prepared to make a fixation between the ES1 and the segment 6 on the dorsal part of the lung. That was going to be my strategy in case to see that the empty place in the remaining hole was big, or if I see that there was a minor possibility of torsion, that was going to be my strategy. I wanted also to comment something because I answered that before, but I didn't realize in one point. You, Dr. Bolt, asked me about applying ICG to mark the tumor. And I was thinking, yes, I can palpate the tumor, but I understand now your question because probably you are thinking about multiportal RATs. And in case I was performing multiportal RATs, of course, you have to do that because you don't have the possibility to try to palpate the lung. You have to do the ports on the lower side of the chest, and you could not palpate the lung in order to identify a lesion like this one. But with biportal RATs, uniportal RATs, you can palpate the lung, convert to BATs anytime you need, or go there and take the lung out and palpate. And that's the reason. In case I was doing multiportal RATs, I will do that, try to locate.
Yeah. I think it demonstrates that I think the English idiom was used yesterday in here about having many different ways to skin a cat. There's many different ways to do things. And I think, you know, the different discussions we've had, and Surf's often the first one to get up to say these things, you just have to be adaptable and see the picture from a different angle, and maybe it might make it easier. So seeing all of these different videos and seeing how people do things, I mean, that's one of the great things about traveling. I always ask permission to watch someone in their operating room to see how they do it. You learn a lot. Being open to learning and seeing how someone else does it can sometimes help the patients at home. So this has been a great session. Thank you very much.
I have a question for Dr. Valdivia too.
Yes.
Are you using the 3D reconstruction software in every case? Or
No,
only...
no, it's a matter of cost and license. It's depending on the cost. In Germany, you become the license in different ways. You can become it for single cases. You can become it for 40 cases in years. So we were using only for, in our hospital, we are using that only for special cases, complex segmentectomies, anatomical variations, but we can not use it for every case. Okay. But I recommend it to use. I think with 3D reconstruction, together with the robot, you are able to do everything.
Okay. Yes.
Good morning. Thank you for all your excellent presentation. I have a question to Dr. Igor. So I was wondering if you always perform a frozen section on all your sleeve resections.
Yes.
Okay, thank you.
Yeah, I think it's mandatory because you wouldn't do a sleeve resection then come back afterwards. And I had one instance where the frozen section was negative, only to come back as a positive marginal pathology. It was a carcinoid, so I had to go back in. That was difficult.
Thank you.
Cheers.
I think we've discussed this fully, and it'll give us some time for the next session to get going. Thank you very much, and putting together such a great meeting. This is wonderful.
Yeah. Thank you for having us.
Yeah, well done. It was great.
It was a pleasure for
Yeah,
me, sir,
yeah.
to be with you here.
Yeah.
Thank you so much.
Thank you. Wonderful.
el micro activado.
Hi, hello, good morning again. Hello. Okay, here we are. So we're going to begin this, for me, very interesting session regarding screening, a top topic now in thoracic malignancies. And I have the privilege to co-share this session with Dr. Luis Eijo. Luis Eijo is a pneumologist at the Universidad de Navarra in Pamplona and in Madrid now, both as well. And he has the most experienced physician in Spain regarding screening, more than 20 years with the international ELCAP program after Claudia Hinsky. And I want to thank him to come here, and we have many and good professionals to join us. Luis.
Good morning, everyone. It's very exciting to be here, see a full room discussing lung cancer screening. It's not too long ago that my fellows that I trained with at Penn used to say, you know, that, are you still working with that crazy lady, Claudia Henschke, on screening? And it's really encouraging to see everybody and the paradigm shift that screening represents for our lung cancer patients, to go from 80% mortality in symptomatic patients to 80% survival in lung cancer screening detected cancer. So without further ado, I'd like to remind the speakers that we have 10 minutes each, except for Harry. Harry has 15 minutes, so he's going to update us on what's going on with lung cancer screening presently. And then we'll have very exciting talks about different aspects of screening and a discussion at the very end that I welcome all questions from the audience. Again, Harry is a pioneer in Europe of screening. It's a pleasure to have you here and hear you speak about what's going on in screening presently.
Thank you so much. Thank you so much for inviting me in this lovely audience. Yes, updates in lung cancer screening, that of course takes 3 days, but I will try in 15 minutes to learn you something. Let's see whether it all works. Yes, so these are my conflicts of interest, nothing peculiar. So these are the two results from the Nelson trial and the NLST, the National Lung Screening Trial in the US and the Nelson trial in Europe. And here you see the point estimates in year 8. They are comparable, these two trials in year 8, that's why I put them there. And it's a 0.76 and a 0.41 lung cancer mortality reduction in the Nelson trial for males and females, huge, huge effect. And in the NLST, 0.92 and 0.73. Again, a huge effect in this devastating disease, of course, but it does show that the Nelson trial even did a little bit better. And that's not to say that the Nelson was so good, it's just to say that indeed, if you're thinking about the effects that we estimated from NLST data, we think we can even do better. In 2021, the US Preventive Services Task Force in the US made this recommendation now, everyone between 50 to 80, 50 because the Nelson trial started at 50 to 80 who have 20 PEC years of a smoking history and are unfortunately either still smoking or quit in the last 15 years, you should get a CT scan. And this new guideline basically gave more high-risk individuals and more black individuals the chance to get a CT scan in the US. Presently, there's quite some debate. Should we, those that are initially eligible, just keep in the program? Probably yes. There's debate whether we should look at the remaining life expectancy, for instance, at the end of the screening program. And there's certainly much debate in whether this is all a bit too difficult and just quit the quit years, for instance. This I will not go in detail, but in the Annals of Internal Medicine, when we for the first time informed the US Preventive Services Task Force about harms and benefits, this table is in that paper, and it shows you on the top, let's see whether it works. Yeah, in the top, on the top it says, in a certain cohort of 100,000 people, there are about 497, so about 500 individuals not dying from the disease anymore, not having advanced disease anymore. And on the bottom of that slide, it says 190 or so. There are about 200 individuals who unfortunately now get the diagnosis and would never have had that diagnosis, so-called overdiagnosed cases. But again, this balance between 500 and 190 or so is a relatively very good balance, let's say. At the moment, you could say the UK is leading. The UK is not the EU anymore, but they are leading. Why? Because they have now 23 locations where they basically roll out targeted lung health checks. And that means that people between 55 and 74, I would say you have to be broader than that actually, registered with a GP, ever smoked, or they are basically, let's say, caught up by trained nurses to get a lung health check. And the results are, to some extent, astonishing. Now, up till June 2024, you see here on the top, they have already invited 1.8 million individuals and about 800,000 individuals that basically said yes, and was this interaction about, are you at risk or not? So almost 50% or so. And then out of those 800,000 or so, 362,000 got an initial baseline scan. So again, about 44% of those who are being attended, or let's say 20% of the individuals that got an invite. And again, if you scroll down a little bit, I hope it works. Here you see stage 1, 62%. So 62% of the lung cancers are now in stage 1. They do find a lot of incidental findings also, but I'll come back to that a little bit later. Fortunately, in September 2022, there was a big turning point, I think. There was a report of which I was a co-chair about improving cancer screening, and a sort of independent EU committee, the chief scientific officers, they are called, they made a recommendation to the European Council, and they basically said, yes, we have strong scientific basis for member states to start implementing lung cancer screening. and why? Again, maybe a little bit difficult slide, but I'll just give the summary of that. Quite recently, we tried to estimate in individuals between 60 and 79, so rather old, you could say, but nevertheless, many of the individuals that are at risk are in that age range now, basically in Europe. 60 to 79. What should a man or a woman at risk do? Should he or she get additional smoking cessation advices? Yes, of course. Or should he immediately go, or he or she, to a CT scanning? And here, the bottom of this slide shows all the effects in life years gained of going to the CT scan. On top, the smaller bars here on the top are all the best evidence we have of adding smoking cessation in these individuals. Some effect, of course, but yes, this is much, much, and much more. So yes, if these individuals are at risk, they have to, of course, think about the pros and cons, but then they should get this CT scanning. And surely we want to add smoking cessation, but it's not that, okay, that has to be done first or something like that. And these are then in the same paper in eClinical Medicine, where we basically try to estimate what would be the result then of all this effect of CT scanning in the Netherlands in this case. And on the top, those are the two lines by time of current smokers. On the top, the blue line is without a screening program, and the orange line is with a screening program. And it basically means we have about 18 million individuals in the Netherlands. And then it basically means there are at least 1,000 people not dying from lung cancer anymore if they come to a lung cancer screening program. At least 1,000 or so, in the order of the breast cancer screening programs, let's say. And that's probably, let's say, a conservative estimate. The 2 lines on the bottom, they are for those who have stopped smoking. Of course, their risk is lower. The number of individuals is maybe even a bit lower. And you would say the curves are a bit, of course, the absolute effect is smaller, but nevertheless, even there, in those who had quit smoking, there is an effect, an important effect. And that's, of course, all due to you. On the left-hand side, you see the radiologist getting these early stages in the NLST, 62%, in the Nelson, 71% in stage 1A and 1B. On the right-hand side, we try to estimate what would be the proportion of screening curability, let's say. So if you are detected in stage 1A, so that's the first 2 columns for the Nelson and NLST, if you are detected in stage 1A, what does treatment do? And it basically means that in about more than 80% or 80% or so, these individuals with treatment will not die from the disease anymore. And you see the same for 1B, and surely, of course, in the later stages, is not happening anymore. So that is why this is so effective. So what are the main challenges? There's a lot to debate today, of course, but some are quite crucial for, on the first hand, how to get these individuals in, how to recruit, how to risk assess. Should we not have a personalized screening interval? And of course, still, how do we add these smoking cessation interventions? And there's much more fully, but I want to address especially the first 2. Because indeed, you have to define on the left-hand side, you have to define a sort of age range first, and then basically think about how to get these individuals in, these ever smokers. Can they go online? Do they get a questionnaire? Whatever. And you have to then have a certain cutoff and say, okay, above this risk, I invite them, I give them the pros and cons, and I invite them. Below a certain risk level, you unfortunately have to say, okay, I explained to you harms and benefits, and we think for you now we don't have a CT basically for you. A difficult decision, but we have to have cutoffs anywhere in any screening program. That's, of course, different from the individual decision from a patient coming in your clinic, but at a population level, you have to make some choices. In a paper in the Thoracic from the UK, they basically found, yeah, we can use health records. This paper just shows that if we look at average smokers, for instance, from the records, we will be able, with a certain cutoff, to really identify quite some individuals. We will probably not select everyone, but a lot. Unfortunately, we tried to look at this here in the region Catalonia, and maybe to the right-hand side. Here you unfortunately see the right-hand side. Does it work? Yeah, here, so you see, unfortunately, there is so many individuals where we have missing data, for instance, on PEC years. So it is not that easy. It is certainly not that easy to get all the information from, for instance, electronic health records. Another example in this trial, let's see whether it works. I don't get it forward anymore, it seems. Can someone help? Okay.
The batteries, I think. Somebody advance the slides, please.
Yeah, doesn't. I just go on a little bit, I think, and you'll get some slides in a minute, I think. So this is the electronic records. It's quite difficult. Another thing is just to send out material to the population. What we did, for instance, in the German setting in Germany. Yeah, I think it works. The green one. Yeah. No, don't need to. Just. Mm-hmm.
Esperi, que no funciona. No funciona. Un momentito. No funciona.
¿Nos podrían avanzar las diapositivas, por favor?
Oh, I can imagine that you.
Stop and go.
Yeah, I can imagine that you want to see Catalonia, so I fully understand that. I'll try to talk a little bit further. So electronic records, crucial but difficult. In Germany, we send out to the whole populations, in Mannheim, in Heidelberg, and then we basically get something like 1, 2, or maybe 3% back. So only 1, 2, or 3%. A lot of cost, and unfortunately limited. Yeah, thank you so much. So I'll let's see whether it works. Yeah, thank you. So this is so this is here recruitment on general population. On the right-hand side, you see 1, 2, 3, about a couple of percent. Again, important numbers, but limited. What we did in the Netherlands, we did a randomized controlled trial in recruiting. It may seem boring to you, I fully realize that, but it is so crucial to get these individuals in that this, you could say, is as crucial as your treatment. But what we try to do is basically send out a standard letter with all the information to individuals, that is standard paper on the top, either just a letter and to say, please go online and find all the information and say, yes, I want to participate. And the third one is also to go online and help them in a sort of tailored way to go online. And if you look at the third or the fourth column, you see the percentage response, 13, 9, or 8.6, 8.4%. So that's much more already than the 1, 2, 3% or so. A lot of, quite a reasonable response. And if we then look at this, for instance, we use online a sort of self-test, whether you would be eligible. You only have to fill in about 10 questions, and then it says, okay, your risk is for lung cancer in the next like 6 years or so is that high that you should, let's say, that you should get a CT scanning. Going online is really, really possible. That's what we want to address. Here you see on the right-hand side, finally, the number of people that were eligible for our trial, and you see it was 4.5%, 3.5%, and 3.4%. Still huge numbers, but it's, you're right, standard paper gives you even a little bit more response, but again, it's a lot of cost to really get all the paperwork sent out to individuals. So basically what we see here on the, let's look on the bottom, it shows you the numbers that were recruited by socioeconomic status, and the big bar, the big blue bars, is low socioeconomic classes. Those are at least the people that we want to get in, and here you see the huge numbers with the standard approach, but also the two other ones going online is quite good. So we actually think we can do something online. People can go and try to estimate themselves whether they are at risk. Again, you would say, okay, recruitment, yes, it is so crucial. If we don't get the individuals in, we don't get the effect we want. The other important thing is personalized screening interval. Is it not possible that if you had your first-line baseline scan, your first scan is negative, let's say there's nothing suspicious, maybe you can go for a longer interval, 2 years, maybe even longer. Unfortunately, lung cancer is such a rapidly growing disease that normally we would say we would need annual screens. And that's a lot of CT scans, a lot of cost, a lot of false positives. So what we're doing at the moment is a trial in which indeed individuals that have a baseline scan negative, whether they want to be randomized between a 2-year interval and a 1-year interval. And here you see roughly what the difference makes. On the left-hand side, on the top, it says that we may need 140 million screens in Europe. And if we do a risk-based interval, maybe up to 78 or 80. So if this is safe enough, it would be a huge difference in numbers, in cost, in false positives. But we don't know. At the recent World Lung Cancer Conference, people from the International Lung Screening Trial showed something, and I was a discussant. I will go a little bit quicker than now. And a so-called PAN-CAN protocol in which they indeed said, okay, if your risk is low, you get a 2-year interval. And so indeed, they were able to find that maybe 3/4 of individuals are at very low risk after the baseline scan and could maybe go for a longer interval. But the issue is that in this paper, or in this presentation, on the right-hand side, if you look at the bold numbers, it is only about 8 cases and 10 cases that they could find this evidence. That is the amount of individuals, because they are at very low risk. But the issue is, yeah, that's not good enough to come up with a nationwide program or a European program based on these 18 cases. We really need a randomized controlled trial for that. And that's what we are doing. So as I said, I have a little bit of conflict of interest. We are doing such a trial in Europe. But again, I think it is crucial to have that information and the final results in a couple of years so that we can all benefit. But basically what we're doing in different centers, in different countries, either do a 2-year interval or a 1-year interval. And here you see who's participating. The Institute of Catalan Oncologia is participating on this one. Germany, Italy, the Netherlands, France, and we hope to basically show, I'll skip this one, whether it's safe, less morbid, more accepted if we do it this way. And here you see the recruitment by time, not going into detail. Why is it a bit, why are these colors on the left-hand side? Because it took a long time to get started, to get all the legal things. And on the right-hand side, the question, where are we now? And are we having enough numbers? And we do think we have enough numbers. And this is basically that we're going up till in the order of 20,000 individuals, maybe add summit data from St. James, from UCL, and then we probably have enough power to show whether it's safe enough. Actually, here you see if we look at the 4 in the long run, so it's the 3rd or 4th column, we also had 77% of individuals at very low risk at baseline scan. So yes, for maybe 3/4 of individuals, we could maybe have longer intervals, and it would be important to have that. Indeed, 2.7% is at high risk, and there's an intermediate group of about 20% that needs additional CT scanning. I'm almost done, so sorry for delay a little bit. As said, we need randomized controlled trial evidence. I'll skip this. But before I end, the cardiovascular risk stratification. These are the early numbers in our trial. Of course, ILCUP has shown already these kind of data. But the crucial thing is these individuals that we get in, probably at least 1/3 are at very high risk for cardiovascular disease too. Maybe even half of them need preventive treatment. Some may already have that, but many not. So here basically we see males, females, and overall about 1/3 or so are at high risk for cardiovascular disease. In our trial, in the same low-dose CT scanning, we do the same thing with a dual source system that we have the calcium scoring and the lung nodules. I will not go into much detail because we will debate this, but I try to estimate a bit what is going on in the EU. So Croatia is, I think, leading. Poland, the Netherlands, as said, Italy has about 10,000 individuals. And here you see now, fortunately, many countries are working on this. So 2 last slides. Where are we heading? This is the first risk-based cancer screening program we are having. Before, it was all about age. This is the first risk-based. We will narrow the gap between socioeconomic classes. You can recruit with a short questionnaire and some kind of threshold. We have to have a threshold. And we will increase smoking cessation in individuals. I'm convinced about that too. Cardiovascular risk assessment is an integral part, and then we will really have major health benefits, also, of course, due to you, due to this audience. So we should be, indeed, I should quit talking and begin doing. Thank you so much.
Thank you very much, Harry. Well, we continue with the risk models, and we have Sonia Baeza from the Respiratory Medical Department of Hospital Germán Trias y Pujol in Badalona, quite near from Barcelona. And she was going to talk about the risk prediction models, which is, as you said, a big topic as well. Sonia?
Good morning, and thank you very much for the invitation to this meeting. These are the key points that I will address today. There are no doubts about the evidence that support lung cancer screening with low-dose CT. Following the NLST and Nelson trial, this systematic review of Cochrane published in 2022 confirm and support this reduction in lung cancer mortality. But when we think about lung cancer screening, it's really important to determine the people that we want to select for the lung cancer screening program. For this reason, we need to ask what is high risk in relation to lung cancer, and how do we select this high-risk population? Regarding the first question, we know that there are multiple avoidable risk factors for lung cancer beyond smoking, like radon, asbestos, and pollution, and also many non-avoidable risk factors for lung cancer that we must consider in each individual. Regarding the second question, how do we select these high-risk people? We have two ways to do it: categorical criteria and risk models. Categorical criteria are widely accepted. We have Nelson's criteria, NLST criteria, and the guideline Task Force 2013, and then Task Force 2021 that was updated to include more women and Black people that was less represented in the first guideline. But the problem with this is that, for example, in US, with this update, we need to screen almost the double of people, as you could see here. And on the other hand, risk models could give you individualized risk in each patient. We have more than 10 risk models, and most of them validated, and for this reason could be an option. The correct selection of people at risk is decisive for the efficacy, the effectiveness, and equal access to lung cancer screening program. And for this, risk models could play a key role in the selection process. In this table, it's possible to see different risk models and the question that they do. No? For example, more than 8 and smoking status. You could ask about education, COPD, pneumonia, personal history of lung cancer, and family history of lung cancer, and occupational exposure like asbestos. One of the first studies that compare risk model with categorical criteria is this one. That is a retrospective validation, but they compare different risk models with NLST criteria. In this study, the risk models had a better sensitivity than NLST criteria. This other study is really interesting because it's a comparative study evaluating the long-term pros and cons of using different risk models. And in this study had the risk models reduce lung cancer mortality more effectively than Task Force 2013 categorical criteria, and with an increased risk of overdiagnosis if older people are selected. But this could be adjusted based on the threshold, and the age at which screening is complete. This other study is really interesting too because it's really new, published only 2 months ago in September, and it's with population from 9 European countries. And in this study compared the performance of 10 risk models with categorical criteria. In this study, fewer individuals were selected by Task Force 2013 and Nelson criteria, and after applying the selection threshold equivalent to Task Force 2021, PLCO and these other risk models identify between 77 to 79 of future cases of lung cancer, although they selected slightly older people compared to the Task Force 2021. Another important point is cost effectiveness. These 2 studies compare PLCO with categorical criteria. The first one compared PLCO with Task Force 2013, and the other one, PLCO with Task Force 2021. As a summary, in these studies, PLCO selected more women, more individuals with less education, and more people with respiratory disease. PLCO save cost and improve results, and risk models-based strategies are more cost-effective than categorical criteria, and also reduce socioeconomic and gender disparities in lung cancer screening access. And if we think about the future, maybe the future will be the association of biomarkers with risk models. This study, published in 2022, is really it's a good study because it's a panel of circulating protein plus the PLCO model. In this study, this combination improves lung cancer risk assessment for lung cancer screening. And we have to think about it because maybe it will be the future in lung cancer screening selection patients. If we want to do pros and cons about risk models, in pros, we could say that it's greater personalization and patient empowerment, reduce disparities, is cost-effective, that is really important, and better selection at-risk individuals. In cons, we could say that could be difficult to use or to take the information, but there are only a few questions, and the patient could find the question in a website or in an app. Maybe it could be difficult to select the most representative model in each population, and potential overdiagnosis in older people. Finally, risk models are more effective selecting individuals at high risk for lung cancer. Risk models help to reduce disparities and improve cost effectiveness. And lung cancer screening program to consider using risk model adapted to their population to optimize efficiency, more effectiveness, and promote equal access. Thank you.
That was a great talk. Speaking of overdiagnosis, we have Luis Gorospe, a radiologist who's been involved in lung cancer screening in Spain for some time now, and the national pilot. He's going to talk to us about subsolid nodules and how to approach them.
Okay, thank you, Luis. Good morning, everyone. It's a pleasure to be here. Thank you for the organization of the Congress for inviting me to give this lecture entitled Radiologic Assessment of Subsolid Lung Nodules. I think I'm the only radiologist in the Congress, so don't be too harsh on me, please. So I'm going to talk about first about the different guidelines for managing subsolid lung nodules, and also about the role of that thoracic radiologists play both in the diagnostic and therapeutic management of ground glass nodules. And we will also discuss some controversies and challenges regarding the management of these type of nodules. So we know that with the increasing use of chest CTs and the expansion of lung cancer screening programs, there is in the last decade, have led to the detection of a growing number of ground glass nodules. And preparing this presentation, I was actually a little bit shocked by the fact that some series have reported that up to 45% of patients undergoing lung cancer screening and having at least one ground glass nodule have at least an additional ground glass nodule. So that really makes the management of these patients more difficult. And we know that ground glass nodules exhibit some particular features that make their management a little bit more tricky. First of all, there is a suboptimal definition on how to measure these lesions regarding their attenuation, their size, their volume. It's not so easy as solid nodules. Also, there is a suboptimal performance of volumetric tools compared to solid nodules. And also, PET-CT provides limited information regarding the metastatic potential of ground glass nodules, and we know that. And there is also controversies regarding imaging workup and also the role of preoperative biopsy. Regarding the guidelines, there is an excessive disparity in the management of ground glass nodules by different guidelines. For instance, BTS and ACCP, they recommend the same approach of GGNs, no matter if they're incidental or screen detected. On the other hand, the National Cancer Comprehensive Network and the American College of Radiology LANGRAD systems, they do have specific guidelines for subsolid nodules. Although small, these differences there are differences regarding follow-up recommendations and also size thresholds above which additional studies or interventions have to be done. This table compares the management of subsolid nodules by different guidelines. So in orange, we have the incidental ground glass nodules management guidelines by ACCP, BTS, Asian countries, and Flight Society. And the blue ones are the screen detected GGNs guidelines by Landrats and NCCN. And well, there are differences regarding population eligibility and also the interval imaging and also the threshold for performing additional studies. So what do we do with ground glass nodules? Well, we first have to measure them in our reports, and for that we measure diameters. And also I want to stress the importance of addressing heterogeneous ground glass nodules. We will discuss them. We are also starting to use artificial intelligence and radiomics for the management of these type of nodules. And we also perform 3D reconstructions and percutaneous interventions, both for diagnostic purposes and also for therapeutic management. Regarding measurement, current guidelines share essential CT acquisition and reporting considerations like slice thickness or reconstruction algorithms or value of multiplanar reformatted images. Diameters, screen-detected guidelines for GGNs recommend using mean diameters both for the overall size of the nodule, but also, and more importantly, for the solid component of the GGN, since we know that they have prognostic implications. Heterogeneous GGNs, I just want to stress a little bit about this. So these are GGNs whose solid component is not detected, is not visible on mediastinal window, okay? But on the lung window, we can appreciate that there is the density, the attenuation, the texture is heterogeneous, okay? And these nodules, they behave more than pure ground glass nodules and not like part solid ground glass nodules, which do have a solid component visible on the mediastinal window, okay? But the guidelines are not really specific on on which windows we have to read the solid component. I think this is important. Regarding volumetry, recent versions of both BTS and also Landrats, they address volumetry as an additional parameter. But we know that volumetric measurements of ground glass nodules doesn't really work as well as for solid nodules, okay? And this is a drawback. The Nelson trial manages screen-detected nodules based on volume doubling time, but also this is only done for the solid component, not for the ground glass component. Yeah. And also, paradoxically, we need to know that the volume of ground glass component can actually decrease when a ground nodule becomes more solid or more aggressive, and that's because there is a desmoplastic reaction that actually contracts and reduces the overall diameter of ground glass nodules. That's why some guidelines like the BTS have recommended using the concept of mass instead of volume. So with mass, we incorporate both attenuation and volume, and actually is associated with less intra and inter-observer variability. Also, we're starting to use AI and radiomic tools. Radiomics evaluates the texture characteristics of GGNs and surrounding lung parenchyma, the microenvironment, and may help actually in evaluating the malignancy risk of ground glass nodules. AI, deep learning with convolutional neural networks, has also shown potential in estimating the malignancy risk of GGNs. Radiologists, we also like to perform 3D reconstructions for you when you go to, like this case from my institution. This is a patient with a heterogeneous ground glass nodule in the left upper lobe, and the surgeons asked us to, make 3D reconstruction of the arterial vessels, the venous vessels, also of the bronchial tree. And we can actually also delineate the intersegmental surfaces quite nicely. And also this helps the surgeons to decide whether or not to resect more than one segment. Okay. There are many, also we perform interventional procedures. So for localization techniques, there are many different methods. I think the one that is most used worldwide is the hook wire localization technique. At our institution, we usually do perform marking technique with iodine-125 seeds, radioactive seeds. And we do this because the main advantage is that surgeons can actually schedule the surgery days or even weeks after the marking of the nodule. There are also a growing number of societies endorsing the usefulness of performing image-guided thermal ablation, whether it's microwave or radiofrequency, or more recently, probably cryoablation is the way to go. And actually, these techniques compete with other established therapeutic managements like surgery or SBRT. These are two examples from the literature. In the upper images, we have an example of a pure ground glass nodule in the right lung upper lobe, and we can see that it's being treated with microwave ablation. In the lower images, we have a patient with two small lung cancers. The one in the left upper lobe was treated with SBRT, and the one in the left lower lobe was treated with cryoablation. We have seen some of the controversies. We have discussed some of them, but what about the imaging workup of GGNs? It's very controversial. Are whole body PET-CT and brain MRI necessary? My personal opinion is that if not for pure GGNs or heterogeneous GGNs, we could discuss for part solid GGNs with a solid component greater than 5 millimeters. What about, what's the role of preoperative biopsy? I don't perform biopsy of ground glass nodules anymore. Maybe I used to do this maybe 10, 15 years ago, but surgeons do not usually ask now for percutaneous biopsy of GGNs at my institution. I don't think pathologists are able to provide reliable diagnosis on very small specimens obtained percutaneously. So I don't think, maybe this is another controversial issue. Thoracic surgeons, there's also controversy regarding the extent and timing of surgical resection. There is also difficulty in palpating and visualizing GGNs during surgery. What about the management of multiple ground glass nodules or centrally located ground glass nodules? This is a more complex issue. And also, it's very controversial, the management of patients who have been treated in the past for lung cancer and they develop a new ground glass lesion. How are we going to treat these patients? And also, when you compare literature from Asian countries and non-Asian countries, there's also different perspectives regarding the management of subsolid nodules. Many papers have addressed these issues. So the take-home point, I think, is the growing use of CTs and the progressive implementation of lung cancer screening programs are detecting an increasing number of GGNs, which remain probably one of the main causes of overdiagnosis and overtreatment in lung cancer screening programs. Data from several trials, especially European trials, have demonstrated an indolent behavior of lung cancer originated in ground glass nodules and favor a conservative approach. Although several guidelines are available, many controversies remain regarding optimal measurement, imaging workup, management of multiple GGNs, and timing and extent of surgical resection. Radiologists play a pivotal role in the diagnostic and therapeutic management of GGNs. And I don't know if you've noticed, but this is one of the logos of the meeting, of the Congress, and these are the sentinels by Gaudí, and they are found in the roof of La Pedrera building here in Barcelona. And I think they reflect well the main conclusion of this presentation is let's follow up. Let's do it conservatively. Let's follow up ground glass nodules on lung cancer screening programs. Thank you so much.
Thank you very much, Luis. Down. So as we have seen, some countries in Europe began their, yes, Juan Carlos, wait. I was telling that some countries in Europe are beginning not beginning, but continuing their screening program. And Poland is one of them. So we have Witold Szyman, which is the leadership of the medical thoracic department in Gdańsk, in Poland, and let's see what you call talking about your program in Poland.
Good morning, everyone. First of all, thank you very much for inviting me. I'm privileged, really, to present here, and I will talk about lung cancer screening in Poland and its current status. But I will start with something else. If you, or if anybody don't know if lung cancer screening is worth implementing, here is the answer. This is the stage distribution of lung cancer in the United States between 2010 and 2018, prepared by colleagues from Boston. You see these two lines. This is USPSTF recommendations for lung cancer screening implementations. The second, 2016, this is implementation of lung cancer screening in USA. And you can clearly see that number of stage 3 and stage 4 decline after that, while stage 1 is rising. So this is a good answer to the question if lung cancer screening is worth implementing from real-world data from the United States. But let's go to Poland. Here in the bottom line, you can see the most important facts and the most important publications that led to implementation of lung cancer screening. So ILCAP publication in 2006 in NAME, then NLST, then implementation in the United States, 2016. EU position statement, so the guidelines how to implement lung cancer screening in Europe. Nelson trial, 2020, and the mentioned before EU Commission statement that Harry showed you in the beginning. During this time in Poland, more than 70,000 people were screened in 4 independent centers. What is important for this conference, all were designed and run by thoracic surgeons. And that led us to gather the people, the most influential people in Poland in 2018, and we prepared the consensus statement, so the guidelines how to implement lung cancer screening in Poland. And then we started to negotiate with Ministry of Health, and we decided that we will do this stepwise. So first we will do the pilot program and then implement lung cancer screening nationwide based on this experience. So the program started in 2020, and it was addressed to Polish citizens, 55 to 74, with more than 25 years smoking history. Or younger if they had other risk factors, like for example, family history. All of them had 3 rounds of screening. We planned initially to screen 15,000 volunteers. Finally, we did nearly 20,000. Poland is divided into 6 macro regions. In each macro region, the leading institution was chosen. And the idea was such that the CT could be performed in any radiological department that meet the criteria, the radiological criteria, but the decision-making should be undertaken in these leading institutions. That was universal, the same protocol in all centers. So solid nodules were assessed with volumetry according to BTS protocol. GGO by diameter, so Lang-Gratz protocol. Each patient or each volunteer met 3 times white personnel, first during recruitment, secondly during CT performance, and thirdly with the result visit. In each step of this contact, each year, the smoking cessation intervention was applied. What was very important, we prepared the lung cancer screening platform based on the VA Pulse platform. And that was not only the database, but that was also the support for radiologists by built-in study aids, guidelines, risk calculators, and that helped a lot for decision-making, not only for radiologists, but also for the team that were involved in lung cancer screening. So that gave us 2 things very important, because this program was obligatory in all centers that perform lung cancer screening. So standardization of radiology assessment, first of all, and then standardization of the report for the patient or volunteer, what is also very important. So these are initial results. Nearly 20,000 volunteers, 37,000 scans. We found 43%, in 43% of them nodules were found. Recall rate was pretty high, 23%. Lung cancer diagnosed in 1.8% of cases. Surgery performed in 66% of all, so that was first stage 1 or stage 2. I don't have yet the stage distribution here. Adherence to the program was 66, but varied widely between 10 and 95%. Nationwide implementation was scheduled for 2025, 1st January, but it is postponed because I'm struggling now with Ministry of Health to prepare it better. Ministry of Health wanted just to add it to the healthcare basket, but this is not a good idea. It only will make a chaos. It must be much better prepared. So I hope that we will start implementation in middle of the year. Just before I came here, I received the modeling study that was prepared by Bruce Pyenson and other actuaries from Milliman Incorporation in the United States. For us, with the, of course, support of our team, we provided all the data for this analysis. So briefly, I want to point three most important things. They calculated that in 15 years perspective, that will be nearly 4 extra life years for each cancer case. It will cost 1.1 million euro per year if 100% of all volunteers will be eligible population will be screened. But the most important is the stage shift, because this modeling showed that in 10 years, in 15 years, we will have 78% of stage 1 and 4.1% of stage 4. So this is really the stage shift which can occur. But is it possible to have 100% uptake? Probably not, but this is the data that was shown by Michael Giske. He showed the very good prepared and conducted lung cancer screening program in Kentucky region, where he analyzed here is the timeline between 2015 and 2023. And you can see that the red line, this is late stages. At the beginning, 72 versus 27%. This 27%, this is stage 1 and 2. And you see that in 2022, the stage 1 and stage 2 dominated over the late stages, and it's still rising. So this is possible to have a good lung cancer screening program. At the end, I want to show you the data that we did in Poland. We have unique opportunity to do such analysis because 93% of all posts are in the National Health Fund, covered by National Health Fund, and they have all medical records of all people in Poland. So we get back to our population from 2009, screened, that were nearly 9,000 people screened. And they make a very meticulous matching for this population in terms of taking into consideration all most important comorbidities, CVD, COPD, cancers, and diabetes, so the main reason of death in the world. And this analysis shown here that 10-year survival is 87% in our population, in screened population, and 81 in the general population. So people who are screened lives longer. Why? Don't ask me. This is point to discussion. But the favorable 10-year survival was 5.6% higher in the population screened, 3.7 for females and 7.5 for men. So it is worth to implement lung cancer screening again. This is the status, what is going on now. In 6 countries we have lung cancer screening. This is United States, this is Korea, this is Taiwan, Croatia. Great Britain and Australia actually starting implementation in 25, but this is decided yet. In Poland as well, so we will join this committee, but in Europe there are several pilot studies and few other countries will join in the next 3-4 years. Thank you.
Thank you, Vitul, and congratulations on this tremendous achievement in Poland. I think it's really encouraging to see that you're getting those numbers and moving to implementation. I think it's very responsible that you want to do it right, and I think a lot of people are weary of doing it wrong. So congratulations again. And we now have Juan Carlos Trujillo, who's going to talk about the Spanish pilot and the progress here in Spain with regard to lung cancer screening. Thank you, Juan Carlos.
Thank you, Luis. Thank you, Lore. It's a pleasure to be in this session with these colleagues. I'm trying to explain the situation about our pilot in Spain. It's not so good than in Poland. I want to start with a brief introduction. This is my disclosure, with a brief introduction about the lung cancer in Spain. We have a horrible situation with more than 30,000 new cases every year. And the 70% of mortality accounts for 70% of the incidence. So we need to do something to reduce this higher mortality. And what about the cost? We spent a lot of money in lung cancer every year, 15% of lung cancers related costs. So it's more than breast, colorectal, and prostate cost altogether. When we think about lung cancer, we always think about tobacco consumption, and Europe is one of the world's regions with the highest prevalence of smoking, and Spain, in football, we are winners too, but in smoking, we have a bad situation. Primary prevention, I think it's crucial to combine primary prevention with secondary prevention. Are we smoking less in Spain? Well, in general numbers, we smoke a little, but if we analyze the range between different ages, we are a little bit worried about the young people because they smoke daily, 30% of our population. And I think it's not possible to discuss about the fighting between primary or secondary. We have to combine both. As we see in the first lecture, I think it's possible to combine them, and I think if we combine lung cancer screening with tobacco consumption, with tobacco cessation, the strategies can improve. And I think we have enough evidence to defend lung cancer screening, actually. We have the impact of 3 big trials, Nelson trial, NLC trial, and MILE trial. With this, I'm trying to summarize the effects of this evidence: overall mortality and lung cancer mortality between 18 and 39%, depending on the trial. The size is important, but in that case, smaller is better. So we need to detect more stages 1 and 2 to offer the possibility to cure the disease. What Europe says about the lung cancer screening, so they recommend different European parliaments, APEA document, European Commission, they recommend to start different pilots to analyze not the evidence about lung cancer screening. We need to analyze the feasibility to start different pilots around Europe. As you see in the previous lecture, we have different pilots, we have different programs established in Europe, and we are trying to start with our program. What has been done in Spain regarding lung cancer screening, we have different groups collaborating with different lung cancer screening programs, ELCAP, the PRECAP, ILC, for in the land run. So we have enough experience to develop a good pilot. So, but we need the government give us the possibility to start. Because of Spain's position, the national health strategy, they recommend to start, but the overdiagnosis is estimated at maximum 10%. So we need to start with different pilots. And the Spanish network of agencies, they said that cost-effectiveness analysis is not recommended, but we need more information, and this more information has to be collected in a pilot project scenario. This is why we started with a Cassandra project. Cassandra is not a myth, it's acronyms of cancer screening, smoking cessation, and respiratory assessment. And this is the things that we need to mix: tobacco cessation, the detection of nodule of lung cancer, but also detect other diseases related with tobacco consumption, cardiac diseases, interstitial diseases, and others. It's necessary to define the objectives. I think the most important is to center the screening in the patient, promote respiratory health. It's a good opportunity to promote that, screen beyond cancer, and define which we have to use to screen low dose CT scan, and we add a spirometry. The challenges, feasibility of implementation, additional tests that we need to do to improve the quality of the screening, the correct selection of cases, because it's too difficult to collect the information to select correctly, improvements in primary prevention, we need pilot projects. It's a pleasure to collaborate with my friend, Dr. Seijo, trying to develop this project. Actually, it's a national project with a high number of autonomous communities are represented. It's difficult to collect all the communities. Inclusion criteria have been defined. It has unified patient database and registry, and it has quality control, external quality control to get a good database. Inclusion criteria. I think we can criticize inclusion criteria because we decided to choose between the age and tobacco consumption. We know that it's not perfect, but actually it's not possible to select following a risk model, because it's not possible in Spain to collect this enough data to select correctly the patient. It's easier to start with age selection and with tobacco consumption selection. Maybe after the data that we collect with the program, we can define the risk model that we have to follow in our country. The case flow, primary care center and hospital, we select the patient according to the criteria, PI of each health center, and then we select the patient. And we do different actions. If they are smokers, tobacco cessation consultation, it's crucial to start with them, if they want or if they don't want to start. And we do low-dose CT scan and spirometry. Case inclusion during 5 years, total study follow-up 10 years. If the CT scan with no pathological findings, we prefer to do a frequency year by year of the CT scan with a follow-up of 5 years. If pathological findings, we follow the rapid diagnosis pathway. We have a website trying to inform the PIs and the rest of society about the evolution of the project and the quality of the data. And we have, I think it's important to define I think the quality of the project is because we have a unified database, we have an audit and quality control, we have an homogeneous image reading. I want to thank to the radiologists that they are collaborating with the project, a serum bank and image bank. Audit and quality control, I think it's crucial to implement a good project. Here we collaborate with this company. And homogeneous image reading, thank you to Siemens because they created an AI hub to do the first reading, and the center radiologists compare with the image read by AI. And I think it's an opportunity, the big three. I think we are always thinking about cancer, but I think we have the opportunity to detect other diseases related to tobacco consumption, emphysema, cardiovascular diseases. This is our conference that we celebrated. I had the privilege to participate in this conference in Madrid. And this is, I think, a differential point of our study. Mortality in LST screening should not be a missed opportunity to detect other diseases. The actual recruitment, only 266 patients. I think it's not too much, the real situation, but little by little, we are increasing the number of patients recruited, and we are increasing the number of centers that they are active centers in the project. I think the questions, trying to summarize the questions that Cassandra could answer, is our healthcare system truly prepared to do the implementation of lung cancer screening? Is lung cancer screening cost effectiveness? I think we need more data in our country to analyze and to have the answer of this question. How should we select cases for screening? In my opinion, we have to create a risk model in each country, because it could be different depending on tobacco consumption and depending other risk factors. And are we doing everything possible to combat smoking in Spain? Actually, the answer is not. So if we create a good project, we can combine strategies and improve the quality of tobacco consumption in our country. Thank you for your attention.
Thank you very much, Juan Carlos. Last but not least, Doug Good from the University of Washington, Seattle, good friend, and he is going to do his critical appraisal. Doug.
Thank you, Laurie. And this is a great panel. It's hard to follow all these great talks. And I'm going to, there's so many topics to talk about in lung cancer screening. I'm going to limit it. I do have a lot of conflicts, and they all relate to lung cancer screening nearly, but unfortunately none of them amount to any money. And maybe my most important conflict is that my wife is a thoracic radiologist. So I'll start with just some exciting news. So in the United States, we've been setting year-over-year records in annual decreases in cancer mortality. It's been a massive improvement in cancer mortality in the United States, and largely driven by lung cancer. So the two issues I'm going to talk about are implementation and inclusion. So we're all familiar with the data, and this is the NLST, and obviously Dr. de Koning talked about Nelson as well. And the National Comprehensive Cancer Network, of which I lead the lung cancer screening guidelines, published the first guidelines after the NLST about 5 months after the publication of the NLST. And in that, I had clear recommendations for patients to be considered for lung cancer screening. And I'm going to point out, in 2012, NCCN recommended screening for a group of patients age greater than 50 and smoking exposure greater than 20 pack years, 2012. It turns out that implementation is about politics. It's not about science. So we have the science. And what I learned, regrettably, was it requires now politics to move it forward to actually implement. And this is politics in Washington, D.C., actually working with Congress and testifying at a Senate briefing in Washington, D.C., really bringing pressure to bear, which led to the USPSTF, our national guideline group that recommends preventive services, finally recommending lung cancer screening in 2013, that under force of law became a requirement for private insurers in the United States to cover lung cancer screening starting January 1, 2015, so almost exactly 10 years ago. It turns out, however, ironically, and this will be confusing to Europeans and, well, I guess all non-Americans, our healthcare system of private insurers does not correspond to Medicare, our public insurer, which is the dominant insurer for those that are going to be diagnosed with lung cancer. So they still were not insuring or covering patients that were eligible for lung cancer screening. This led to a different set of political agenda, political advocacy, working with the public, working with Congress, and ultimately working with Medicare administrators to result in what's called a national coverage decision in the United States that led to a coverage decision that both privately insured and publicly insured patients would be eligible for lung cancer screening. And that was about 1 month later, February 5th of 2015, that Medicare also joined on board. And so I think we can summarize this aspect that lung cancer screening has a significant mortality benefit. We now have coverage decisions in the United States, and I'm going to be bold enough to say this is the biggest impact on lung cancer management and outcomes in a generation. Our meeting covers a lot of topics, lung cancer being the dominant one. This is the biggest topic in lung cancer in terms of potential of lives saved. And with all due respect to those that treat other cancers because of the dominance of lung cancer, this is actually the largest impact in cancer mortality, period, in a generation. But what are the concerns? The concerns are the benefit may be overestimated and the harms may be underestimated in a clinical trial or in our clinical trials. And that, along with other things, have led to a very slow uptake of lung cancer screening in the United States, only about 6%. It's maybe a little bit higher now. But in spite of a very low uptake, you saw earlier the curves bending the stage 1 curve upward and the stage 4 curve downward, even with a low rate of lung cancer screening uptake. So that gets into inclusion, the second part of what I want to talk about, which is who should we screen? Should we use a categorical, simplified inclusion criteria, or as you've heard here, the improvements that we can have with risk calculators? So a simplified criteria, categorical criteria that we're used to, uses age, smoking exposure, and years since quit. Risk calculators use a number of other variables. I'm going to simplify the simplified criteria and say, let's get rid of an upper age limit. All of us operate on patients over age 75 or 80. Let's talk about smoking duration instead of smoke intensity, and completely eliminate the years since quit. So what are the reasons for that? Well, the American Cancer Society updated their lung cancer screening guidelines last year, and I'm going to emphasize just one major point from that, which is the elimination of the 15-year quit date. That elimination increases the number of individuals who would be eligible for screening in the United States by 5 million, and increases the potential lives saved by 21%. And the reason for that is there's actually not any data to support a 15-year quit date. The risk of cancer does not substantially decrease for another decade or two after lung cancer cessation. The second thing, and I'm not going to put a lot of data on this, I'm just going to put this one slide from Alexandra Potter and Jeff Yang, Jeff Yang's group at Mass General, looking at smoking duration instead of pack years. And looking at smoking duration from this study identified that it more accurately detected individuals who were going to get lung cancer and decreased disparities relating to gender and race. So this is a benefit of decreasing the disparities and further simplifying categorical criteria. So which should we pick, a categorical or a risk calculator? Well, I'd say it depends on what you're talking about. Are you talking about policy, meaning inclusion criteria for entry into screening, or are you talking about individual decision making? Because that's personalized and that's based upon all the accessible data that you have for that individual. So if we ask the question, which is better, we need to ask, is it better for eligibility and coverage, that is policy, or is it better for individual decision-making at the individual level? So here are the variables that are involved in most of the risk calculators, and I've estimated what the availability and reliability are of those variables. Because age and smoking duration are pretty reasonably available. So is race, ethnicity, and BMI. But most of the others are variably available and also not very reliable, which makes risk calculators difficult to apply. They're very good, but difficult to apply. So for eligibility and coverage, I would make a strong case that a categorical inclusion criteria is better because it's readily available, it's accessible, it's simple for primary care physicians, it's inclusive, it also improves health equity and accelerates uptake. On the other hand, for accuracy, a risk calculator is better. It's more selective for high-risk individuals, fewer low-risk individuals get screened. It's also good for health equity and cost effectiveness. So when we're talking about harms in lung cancer screening, most of the time we talk about harms of screening low-risk individuals. We don't want to expose them to the consequences of downstream testing. However, we can't ignore the harms of limited access. That is, using population policy or coverage policy to override shared decision-making in individual patients that may be eligible for lung cancer screening, and to make it more complicated and delay lung cancer screening, and that by itself exacerbates healthcare disparities. So if we're weighing this balance in the current world of screening lower-risk individuals and those harms, or not screening high-risk individuals and those harms, it is pretty clear that right now, our biggest problem is not screening high-risk individuals. Our problem isn't that we're screening low-risk individuals, it's that we're not screening high-risk individuals. And this is what the NCCN has been doing to simplify our guidelines for lung cancer screening. This is 2012, the first guidelines that did have 50 years of age and 20-pack year smoking. That subsequently in 2021 further simplified to only be 50-20 with no 15-year quit date. And I will point out that it just was published about 2 weeks ago. Our updated guidelines now have further refined this to use smoking duration and not smoking pack years for further simplification. So in terms of simplified inclusion criteria, I think we should not use a risk calculator for policy. We should remove the upper age limit, remove the quit date restriction, and use smoking duration rather than pack years. The new NCCN criteria, age greater than 50, smoking duration greater than 20. And the reason for that is if we use airport level security to get into a football match, this is what the stands look like. Few people got there, the match is over before they got through the gates. The difference in lung cancer screening is a lost opportunity to save a life. On the other hand, if we create broad gates to at least create better access, we can fill the stands, we can get people in the stadium. They're in the right seats because they had a ticket, but they got in the stadium so at least they had access to lung cancer screening. And the reason we want them to have access is what's already been talked here. The curve on the left is our traditional lung cancer outcomes of about 22% 5-year survival. The curve on the right is the lung cancer survival from the International Early Lung Cancer Action Project, a screening project, 84% 5-year survival. There are few things that we can do in cancer care that actually completely invert a survival curve like this. So lung cancer screening is our best opportunity to take individuals who are going to be lung cancer victims and make them lung cancer survivors. Thank you.
Thank you very much, Doug. Well, in this panel, there is not enough room for, but I want that Luis Seijo, who is our real expert, bring some ideas on how you think that we have to share. We have been at the Minister of Health, we have been in with autonomy governments, and how we, because we have seen that in Poland, it began in 2008, the pilot study, and arrived for a national 2020. That's right. So, which is the spectrum in your view in Spain?
So my biggest concern is implementation. I agree that as we move along, few people question the evidence, at least of the efficacy of screening, but a lot of people question the implementation. So the resources, the cost effectiveness of screening, and it's striking how, especially politicians, and we've heard this, it's really very political how cancer screening gets implemented. And we haven't talked about this in this session, but I do think that the stigma of smoking, not just in the public health authorities, but in society at large, and even in the patients who suffer from its consequences, is a major concern in lung cancer that we don't see in breast cancer screening, we don't see in other cancers that are screened. And I think that's a hidden obstacle that very few people talk about, but that is probably very significant, and it's certainly an issue in Spain. I've heard people at medical meetings say, you know, why should I pay for somebody to get lung cancer screening? You know, they smoke voluntarily. And I think we should remember that the World Health Organization calls smoking a disease, not a choice. And I think that's a major concern. We're struggling here with the public health authorities and the institutionalized inertia against screening, and I think we're moving forward, but it's certainly a challenge.
Okay, so somebody from the floor? Yes, there, and also, of course, our faculty here. Okay, say a name, and I can.
Yes, my name is Ilyes Boabdallah. I'm from France. I would like to first thank you very much, all the speakers. A big hurrah, because you are our hero. As you said, we were going to change the face of the lung cancer thanks to the screening. So one more time, thank you very much for all your job you did. I have just a question. Maybe you can give us some tricks to convince our public health institution to do now, because we have enough data. It's enough. We can continue some pilot trial, but we have enough data, much more than other cancer with screening program. Can you have some tricks? Maybe we can ask our patient to sue the politician, maybe. So please let me know your point of view.
Yeah, that's does it work?
Yeah.
Yeah. Yeah. Thanks. Yeah, it is a difficult question, unfortunately. I mean, even the Netherlands is the example where we have had the Nelson trial and we still not have a national advice at the moment. We have a Population Screening Act. We are very exceptional to that, and so it means you're not allowed to screen unless the Minister of Health has said yes to that, and we are in that process now. But anyhow, unfortunately, you have to realize these things do take time. So both in the breast cancer and the colorectal cancer screening programs, before there was good implementation, it did take 10 to 15 years. It is unfortunately what it is. So to some extent, you have to take that into account. I think indeed the evidence is clear cut. Indeed, the issue of that there are individuals who have smoked or are still smoking is a crucial question, is a crucial issue in people's minds, in politicians. But again, at the moment, at least more than half of the individuals who are at risk and that have to go to the screening program have stopped smoking. So let's be clear about that. It's almost maybe in the future more than like 60%, 60 of individuals still at such high risk that they should get the CT scanning, but they have done their utmost best and they do not smoke anymore. So I think that is still good to realize. So that is important. I think to really make the quantification and to say what is the absolute benefits, I think so is first crucial. So again, I think the numbers of deaths prevented is in the order or even more than the breast cancer screening programs in your country. So you could say any good lung cancer screening program in your country gives more benefits in absolute terms than what we are already running. I think that those are a couple of things. And now, of course, I mean, we also had those letters, I don't know how to implement, etc. There is now, again, enough evidence that implementation is possible. I think going online and an online risk calculator, or indeed online and say, okay, it's just 20 years or so, and I'm 51, but is an option. Of course, again, maybe I'm saying too much now, but it would be good probably in Europe to start a bit stringent, to first really high risk and show it's working. I think that, and then expand to more individuals. So we, for instance, now start quite at a high risk, 60, 79, and a PUCM risk of 2.6% and more. That's high. But if that works, you can expand. Okay. So, yeah, I should stop there.
Can I add? I would like to add, I would recruit patient associations. And this is difficult because patients with lung cancer die. The people in Spain who lead patient associations are relatives of patients who died from lung cancer, sons, daughters, husbands. And the politicians listen more to patients. They think we're biased as experts, and they will listen to patients. We had a meeting with the public health director in Spain. It was very disappointing. A press release from a patient association changed everything around in terms of a new meeting with a different attitude. So they do listen more to patients than to us. Yeah.
That's true. Juan Carlos?
Yeah, another issue in our country, I think that another key point is try to speak the same language with the epidemiologists and prevention medicine. In our case, it's a little bit difficult because they are focused trying to fight against tobacco consumption. And I'm absolutely convinced that we need to combine both strategies. But, well, I think it's, I don't know if in Poland it was easy to talk with the epidemiologists, try to define the implementation, the criteria that we have to follow to select. What's your opinion about
it? It wasn't difficult because they are on board. Our epidemiologists are on board with us. But what I want to, the most important sentence here was what Doug said, that this is that implementation, this is political problem. And the most important thing to have on board the politicians, at least 2 or 3 leading politicians that will fight for it. I think so. We had such a person, and he helped a lot. He opened the door to, you know, that we didn't know, and that was very important.
Okay. Any other questions from the floor? Just last one. Yeah.
Philippe Leroux from Belgium. I'm part of the team in Belgium of the task force who is trying to implement the lung cancer screening in Belgium. The problem we face is perhaps it's useful to emphasize that for the first time in a screening where we compare it to a breast and to colon is that we have a CT scan, which means radiation, and which means that we are going to see things, other things than we would have done with breast or with colon. So that makes you have incidental findings and you have the overdiagnosis. So those are the 2 biggest problems we're facing at this point. The next problem is you need to find the smokers, because for breast and for colon it's very easy. You just write out a letter to a man or a female of that age and you start a screening program. Whereas here we have the stigma to find those smokers and to make them realize that they can benefit from a screening program, whereas we all know that smokers are not so fond of screening and medicine at all. So that's a difficult population. And in trying to convince the government, our biggest problem is our general practitioners. They are not behind the screening program. So they are saying we should make all the effort in quit smoking and a quit smoking program rather than to go into the lung cancer screening. So what they are doing is ignoring 20 years or a population of 20 or 30 years that will have lung cancer in the future. So the problem with politicians is that it's very difficult to convince them that a screening program is useful, and in all those overdiagnosis and incidental findings makes it that the cost becomes too high. And what we're definitely not allowed to do in Belgium is to look at cardiovascular risk and emphysema, but because that would rocket the costs enormously. Those are the problems we're facing in Belgium.
So thank you for your comment. Any other
final words?
Burning issue?
Lung cancer screening is very difficult. It's more difficult than any other screening, but it brings also additional value, what you mentioned, CVDs and emphysema, and it will bring a lot more because we are working on it. And this is very important to realize as well. So not only lung cancer.
Okay, I want to thank everybody and for this. Molt bé.
Well, dear participants, now I can see the doors closed, so we can start the next session. It's about relevant aspects of minimal invasive surgical resections of thoracic tumors. My name is Henrik Jessen Hansen. I'm from Rigshospitalet Copenhagen and head of the minimal invasive program there. And my co-chair is Karim Ubeols, consultant from the University Clinic in Thoracic here in Spain. So each speaker has 10 minutes and we will have a discussion at the end.
So let's start with the first speaker, Dr. David Gomez de Antonio. He will speak about thoracotomy versus VATS for lung cancer resection, the impact on survival, and these are the results from the Spanish video-assisted thoracic surgery group.
Thank you, Chairman. Good morning. It's a great pleasure for me to be here participating in the event of the year on thoracic surgery. And I would like to thank to the organizers committee to their kind invitation to share with you the results from the Spanish video-assisted thoracic surgery group comparing thoracotomy versus VATS for lung cancer resection. I have no conflicts of interest disclosed relative to this presentation. And this is the script I will follow up during my talk. There is an important body of evidence showing that minimal invasive approach in lobectomy is associated with lower pain, lower general hospital complications, except prolonged air leak and intraoperative bleeding, a shorter length of stay and early recovery of the patients compared to open surgery without compromising oncological outcomes. However, results in terms of survival, short and long-term survival, are conflicting. The aim of our study was to analyze the impact of surgical approach in both early outcomes, 30-day, 90-day mortality and readmission rate, and long-term results measured by overall survival, cancer-specific survival, and disease-free survival in a prospective national multicenter database of patients with anatomic lung resection. In 2016, more than 30 units of thoracic surgery in Spain recruited patients with anatomic lung resection in a prospective way during 2 years. After that period of time, an internal audit for data accuracy and recruitment rate was performed, and then patients were followed up until the end of 2022. The final cohort was 2,634 patients with a complete follow-up from 4 to 6 years. For the purpose of this study, compare VATS versus open, we excluded patients with second lung cancers, pneumonectomies, and extended resections, chest wall, diaphragm, and sleeve resections. A preliminary analysis showed that both groups of patients were not comparable for many important prognostic factors like gender, dyspnea score, location of the tumor, induction therapy, pathological stage, differentiated histology, or adjuvant therapy. So we performed propensity analysis, and for early outcomes, we included as cover rates those variables associated with the decision to perform an open or a minimal invasive approach, and those variables not equally distributed among groups. We included dyspnea, comorbidities, previous thoracic surgery, the location of the tumor, enlargement of lymph nodes on CT scan, the size of the tumor, induction therapy, respiratory function tests, and gender. So finally, 1,891 patients were matched. And I'm showing you the overlap assumption graph, which is quite acceptable. And on the right side, the balance plot, just in the interest of time, just for tumor size, you see that the cohort is well balanced after matching, and the same behavior was for the rest of the coverage. So early outcomes favored clearly VATS approach with an average treatment effect of 2.3 point and near 5% higher for 30-day, 90-day, and readmission rate respectively for open versus VATS approach. And for long-term outcomes, we used inverse probability weighting, including to the cover rates described for early outcomes and other prognostic factors like pathological stage, pathological and certain lymph node stage after resection, incomplete resection and adjuvant therapy. And for cause-specific mortality and disease-free survival, we use the fine gray model for competing risks. We could not find differences in terms of overall survival, and neither in cause-specific mortality, but we could find a longer disease-free survival for VATS approach with a hazard ratio of 1.3 for open surgery. But after careful consideration of these results and a thoughtful and meaningful reflection, we realized that there was a big elephant in the room, and I'm sure that most of you are also seeing the elephant in front of you on the couch, which is the group of patients that had to be converted from VATS to open surgery for various reasons, but with potential impact on early outcomes. So we decided to exclude those patients from the analysis and redo all the statistical work. And then early outcomes where the differences were diluted. We, again, couldn't find differences in terms of overall survival, but surprisingly, we could find a small difference, but a significant one, a 5% difference in cause-specific mortality favoring VATS approach with a hazard ratio of 1.3 for open surgery, and also, again, for disease-free survival. This is a 10% difference favoring VATS. So maybe the hypothesis is that these patients recover early, and so they are sooner eligible for receiving a full dose of induction of adjuvant therapy compared to their open surgery counterparts. Obviously, this work has several limitations. We could not count for local differences in terms of ERAS protocols, implementations, surveillance of the patients in different units around the country. We could not control also for histologic or differentiation grades of these optional covariates, like factors like lymphatic, vascular invasion, STAS, etc. There's always a sample size reduction when you do propensity score matching, and maybe the size of the sample could not have the power to realize differences. There's also a selection bias because this is a voluntary database, and of course, for long-term survival, there can be unknown confounding factors affecting our results. However, despite all these limitations, we can conclude that although VATS approach may not have shown to improve perioperative mortality after lung cancer anatomic resection in our dataset, it may still have a positive impact on long-term cancer-specific outcomes. Thank you very much for your attention.
Thank you for your presentation, and thank you for keeping in time. We will have another study from the Spanish video VATS group, and it is radicality in lymphadenectomy on lung cancer resections, and presented by my dear co-chairperson, Carmen Ubeols.
Chairman, dear colleagues, good morning. I would like to thank the organizers for their invitation. So I have no conflicts of interest. To introduce the topic, I would like to remind that the type of lymphadenectomy recommended by both American and European guidelines is systematic nodal dissection, which is also a requirement to consider a lung cancer resection as a complete resection. A minor standard of this lymphadenectomy has been accepted by the UICC and at least requires the resection of 6 lymph nodes, that 3 should be from the mediastinum and always including the subcarinal station. This is important to assign with certainty the PN category, which is important in terms of prognosis and also to be able to indicate adjuvant therapy when necessary. But does it have a survival benefit when we perform a systematic nodal dissection? Literature didn't find much differences for early stage lung cancer. Some series found differences, but mainly due to the end-up staging. Some series have found differences regarding the number of lymph nodes resected or even the number of nodal stations resected. So after this brief introduction, the objective of our study was to analyze survival differences according to the type of lymphadenectomy performed, a systematic nodal dissection or not, in the group of patients from the Spanish group of video-assisted thoracic surgery database. As Dr. Gomez Antonio mentioned before, in this database participate 33 hospitals, and the inclusion period was from December 2016 to March 2018, and the follow-up was completed in September 2022. So these are all the recruitment of the patients, but after exclusion criteria, the subgroup that we analyzed were 1,548 patients, and around 60% of them have a systematic nodal dissection and the other didn't. For the purpose of this study, we define a systematic nodal dissection when at least 6 lymph nodes were biopsied or resected, and always has to include the subcarinal station. Regarding statistical analysis, we performed the corresponding test for homogeneity, and overall and cancer-specific survival was analyzed by the Kaplan-Meier and regression analysis. These are the results. These are the cohort characteristics. The majority were men with a median age of 66. And as I said before, around 60% has a systematic nodal dissection with a median of resected lymph node of 10. And the other group has a median of resected lymph node of 4. Here I show you in this table the homogeneity analysis. So with differences in the systematic nodal dissection group, as obviously there were a median of resected nodes that was higher, but also there was a higher percentage of invasive staging. Also it was more likely to have PN1 and PN2 disease. The tumor size also was greater in this group. Squamous cell carcinoma was most frequent in the systematic nodal dissection group, and also the right-sided tumors. And it also was more frequent in open approach. So these variables that will be used by the multivariate analysis. And here we can see the survival curve. We didn't observe any difference in overall and cancer-specific survival according to the type of lymphadenectomy performed. But then when subanalyzing by subgroups, when we subanalyze by PN category, we observed that in PN0 the curves overlap, so there were no differences if you do or not a systematic nodal dissection. But in PN1 and PN2 we find differences. In PN2, indeed, we observe a paradoxical effect because it seems that the group without a systematic nodal dissection do better. But when subanalyzing this group, the PN2 population, in the multivariate analysis, it doesn't get signification, and it does the tumor size. Tumors more than 3 centimeters has this hazard ratio, which is near signification. On the other hand, the PN1 tumors, we observe that systematic nodal dissection curve has better survival, and when doing the multivariate analysis, it doesn't get also the significance. So we stratified more by tumor size. And when stratifying by tumor size 3 centimeters or less, or the group with more than 3 centimeters, we find a subgroup, the subgroup of patients with PN1 and tumor size more than 3 centimeters, in which systematic nodal dissection favors survival with a hazard ratio near 0.5 and a significant P. So in summary, in the cohort of HEVATs, we find that systematic nodal dissection was not associated with a better overall and cancer-specific survival, but that was a subgroup, the patient with PN1 and tumor size more than 3 centimeters, that was associated with better survival. Therefore, the conclusion is that we should do routinely a systematic nodal dissection, especially considering that there is a subgroup who can benefit from this type of lymphadenectomy. Thank you very much for your attention. Let's move to the next speaker. Dr. Ricard Ramos will talk about the radicality of lymphadenectomy in lung cancer resection by bats or by rats. Thank you.
Good morning. Thanks. It's a pleasure for me here. I would like to thanks to the organizing committee, Dr. Molins, Dr. Rami Porta, for the invitation to discuss this paper published last year about the comparison of total thoracoscopic and robotic surgery for lung cancer lymphadenectomy. What was the objective of our study? To assess and compare the quality and safety of lymphadenectomy performed via multiportal rats, 4 ports without assistance, and multiportal bats, total thoracoscopic, full thoracoscopy, as described by Dr. Gossot. Our study includes 85 patients in batch group. We exclude patients operated by 1, 2, or 3 ports, and 161 patients in the rats group. All surgeries were performed by the same surgeons, and we focused on patients in clinical stage 1 and 2. The clinical and pathological characteristics were similar between rats and bat group. Minor differences were noted in diabetes, in COPD, or in status smoking status. In this slide, we can see that there were no differences between the rats and bats group regarding the type of the resection, clinical stage, histology, or pathological state. Lobectomy was the more frequent resection type overall in the bats group. In terms of postoperative complication, no significant differences between bats and rats groups. Regarding the number of nodes, the total number of dissected nodes was significantly higher in the group, in the rats group, sorry. We can see that we remove 14 in the rats group and 10 in the bats group. When we analyze by nodal station in rats group, also we remove more nodes in different ciliar and mediastinal stations, more frequent in the superior mediastinal than inferior mediastinal region. What about the upstaging? When we didn't find significant differences between both techniques, although there is a greater tendency in the rats group. What can we conclude from our study? Rats approach may be more effective than bats in terms of the number of dissected lymph nodes. Well, is rat approach better than bats? Can we answer this question? If we review the literature, we observe that rats is better, or rats is similar to bats. Another paper that bats is better than rats. In more recent studies, seems that rats remove more number of nodes and more stations. In this 2019 meta-analysis, there were no differences between any technique. They compare open, multibats, U-bats, and rats. In 2021, Dr. Abenonesi, the randomized study, rats approach is better than bats, remove more number of nodes. In this other randomized study in 2022, similar results. Robotic approach remove more number of nodes and stations. And the Raval study confirms the same results. And what happened in patients with N1 and N2 disease? In this very recent 2024 in the European Journal of Surgical Oncology, robotic approach appear to be superior to non-robotic approach. Well, is rat approach better than bats? Can we answer this question? In my opinion, it's like comparing a very good car with manual or automatic transmission. The important is to do adequate lymphadenectomy. Here we can see a lymphadenectomy of subcarinal region by bats with endoscopic instruments, or in the right side, a robotic 7-stage lymphadenectomy. Finally, robotic lymphadenectomy seems to be better than bats regarding the number of dissected, and innovation and technology will allow us to perform more adequate lymphadenectomies. Thanks.
Well, thank you for the presentation. And the next paper will be about capnothorax and anesthetic trips in rats, and be presented from Richard Navarro from Barcelona.
Hi everyone, I'm Ricard, I'm a consultant anesthetist in Hospital Clinic, and I've been invited to talk about capnothorax and anesthetic tips. I have no interest to disclose regarding this topic, and this will be the content of the talk. We'll introduce a bit the subject, already it's been done, but we'll talk a bit about robotic and which are the approaches we have, and how can capnothorax probably make a difference, mainly for us, for the anesthetists, and which are the things that we really need to bear in mind so that patients can benefit from this technique or from this approach. It's also been said already that robotic has been widespread used, and it's implemented all over the world. And there is growing evidence regarding that we're probably having less length of stay with this approach. And there is growing evidence probably that we may have also less complications and maybe more mortality. We still don't know. So we are just looking into that. But what we know is that these patients still present complications. And if we have a look at which complications do they get, we know that from the medical point of view, it will be mainly, again, pulmonary and cardiac. So that hasn't changed that much from the other techniques. So what we have to do is which things can we do to try to improve the outcomes, even in these patients, and how can we decrease the rate of postoperative complications. We know that there are different devices, and when we look at different robots approach, well, we can talk about robotic portal lobectomy, we can talk about robotic assisted lobectomy, and the main difference will be depending on the number and location of the ports, if there will be a presence of mini thoracotomy, the number of the arms that we use. But I think that's quite important. Again, I'm saying it's the capnothorax, so the CO2 may make a difference, especially if it's a tension capnothorax, that will make probably a repercussion in the cardiopulmonary function. We know that we can also classify them between multiportal, most of them will use CO2, and then we have different approaches. People may use biportal or uniportal. These ones probably don't have capnothorax, and that may make a difference. But there's still not much evidence regarding that. So when we have a look at which things do we need to consider based on that, so well, we have some challenges. So one will be a limited access to the patient. We know that when the robot is docked, we have less access mainly to the airway, and we need to be sure that the device we use will be separating the lungs during the surgery. We will need immobility and patient moving during the surgery when the robot is docked. That may be harmful, and we need to make sure that we have a proper muscle relaxation. We need to have a plan for reconversion if there is a complication. And then we need to do an intervention directed to modify the repercussion of the capnothorax. We know there will be a mediastinal shift, there will be increased airway pressures, we may have hypercapnia and even hemodynamic disturbances. When we talk about the airway management, you'll probably have seen that most of the anesthetists, we feel maybe more comfortable with a double lumen tube. Even without any of the devices, we can use them, but we have, again, limited access to the airway, so if the device that we have in the airway migrates, it may be a pain. So most of the centers will prefer to do a double lumen tube, but even with that, bronchial blocker can be used, and an alternative that we may have will be this embedded camera double lumen tubes or even single lumen tubes. If you see in here, that's our operating theater, and we have the screen, and we have a constant monitoring with these double lumen tubes with camera, and so we can monitor the airway and see if the device has migrated. We don't systematically use them, but it's an option that we have, and especially if we have also shortage of bronchoscopy, it may be a useful tool. Can we play the video, please? And you can see in here whether a double lumen tube or a single lumen tube with a bronchial blocker. No, that's not working. Oh, fine. Yeah. Okay, so you can see in here that's a video recorded from the camera, and you have the bronchial blocker working. Apart from that, as I said before, we need the patient to not to move at all. And well, how do we do that? Well, ERAS guidelines recommend us to use shorter aging agents so we can extubate and promote a faster recovery. And we may use an infusion, wherever, but it's quite mandatory to have a monitoring because we'll need a proper muscular relaxation until the end of the procedure because the robot will be docked until the end of the procedure. And once we take it out, closing the sutures, it will be quite fast. So we need to monitor that and we need to be able to reverse that in order to extubate promptly the patient and not to have more pulmonary complications. When we talk about how do we ventilate the patient, these are some results you may have seen about our group. It's published by Ferrando this year in Lancet. And what we did is we individualized how do we approach the recruitment maneuvers, PEEP, and low tidal volumes. And also we associated a postoperative intervention that was trying to detect the atelectasis as soon as possible and doing some high flow nasal cannula to avoid these complications. And what we saw is that these patients that received this bundle of measures, PEEP, low tidal volume, recruitment maneuvers, and detection the atelectasis, had much lower pulmonary complications. So what do we have to do then in robotic? Well, we need to do protective ventilation, as said, but we have a capnothorax. In here you have a video we start our lung ventilation and then we apply the capnothorax. And what we see, I'm not sure if you can see, is that from a driving pressure that we have 9 at 12, so plateau-less PEEP, it will script steadily up to 15, 16, so you see now we have 16 of driving pressure, and we know that's harmful for the lung. So what can we do? When we saw these things, we tried to design a small study to see, can we improve this with our mechanical ventilation, and this is the study we designed. So we got 30 patients that were on one lung ventilation. We did a recruitment maneuver, we calculated the ideal PEEP, and then we applied the capnothorax. And when the capnothorax was established, we recorded the respiratory mechanics, and we did a second recruitment maneuver, and we calculated a new PEEP. And it's not really difficult to expect that PEEP were different. So once we established this capnothorax, the PEEP we're required to open the lung is higher. You can see in here some results. So the blue bar is the compliance. We have compliance first with 2 lungs. We apply 1 lung ventilation. Obviously, the compliance decreases. We do a recruitment maneuver. This compliance increases again. Then we do the capnothorax, and you can see how there is a significant difference with a worsened compliance. And what we did then is a newer recruitment maneuver, new calculation of the ideal PEEP, and that improved the respiratory mechanics. You can see also here some data. The PEEP that was needed in most of the patients was around 6 before the capnothorax, but when we established the capnothorax at 5 millimeters of mercury, that PEEP that was needed was 12. So we need to bear in mind that when we apply this capnothorax, probably our respiratory mechanic is changing, and we need to titrate our intervention in order to decrease the possible complications that we may have. Also, we saw that there was a trend of being respiratory acidosis, but once we ventilate both lungs, that will disappear and will back to normal. Apart from that, we also have normally an hemodynamic response. It's mainly on the right side in patients who have hypovolemic. And I think that in areas also it's quite important that they said that we should keep the patient with oral intake and fluids up to 2 hours until surgery. And I think that made a difference, especially with the hemodynamic response they have to general anesthesia and once we establish, the capnothorax. And another thing that happens every now and then is the Da Vinci that we have will be used in different specialties and sometimes is set at a 15 of pressure. So if we go with that pressure on the thorax, will definitely have a significant repercussion. So patients with decreased preload or who have hypovolemic will have a significant repercussion of the capnothorax. And that's it. Thank you very much.
Thank you, Dr. Navarro. Now let's continue with Dr. Herbert de Calouet that will explain the postoperative pain by BATS or by RATS approaches.
Thank you for the invitation. So, Mark, I just found out that you brought your anesthesiologist and I have to talk about pain, so maybe you just can continue with this presentation, but I'll do my best. So, pain is important. This paper from Copenhagen showed that it's the number 3, a reason for length of stay of more than 2 days after air leak and pneumonia. But of course, it also is a reason for complications. And so optimal pain control is key. It gives you the ability of deep breathing and coughing and prevents atelectasis and pneumonia. It's part of our ERAS protocol. It should be multimodal, opioid sparing, is procedure-specific and patient-specific. So what can I talk about concerning pain after RATS and VATS surgery? So first of all, what is causing the pain after minimally invasive lung surgery? Do we need more pain therapy with a specific approach? What therapy can that be? And is there a one-fit-all protocol possible in pain therapy for VATS and RATS? And so I have to say that I have a mixed, okay, say that I do both robotic and VATS cases, so 1/3 of my cases are robotics. Where is the pain coming from? From these intercostal nerves, long thoracic nerve, thoracic trochodorsal nerve, the phrenic nerve. And what is important is also the parietal pleura. This is where the drain is lying against, and that gives a lot of pain. So that's both intercostal nerve as the phrenic nerve can have innervation of that. Stress on the intercostal nerve, where does it come from? Well, you know that below the rib you have the vein, artery, nerve in that sequence, so the nerve is most exposed. When you have narrow intercostal spaces and large trocars, like when you use the standard robotic stapler, you need larger trocar. This can give stress on the nerve. Also, when you have a lot of angulation of your trocar in the intercostal space, like when you use a robotic stapler, you need for the bulk of the stapler, we place our ports now lower. This can give stress on the intercostal nerve. Be very careful with intercostal bleeding. That's where damage of the nerve can happen. And in my opinion, that is a little bit less frequent with uniportal VATS than the classic robotic or multiportal ports. Some people think that the intercostal groove is protective. It's not. This is not more than just two ridges of a muscle attachment of your intercostal muscle. There's not a lot of protection, especially posterior. Like where you see here, we are doing an intercostal block, and you can see that actually the nerve is exactly in between the two ribs, and so not below the rib, but exactly in between the two ribs. So that's the reason why we say that at that level you should not place your port, but a little bit higher where the intercostal muscle, the deepest, starts. So why would people adopt their port technique in rat surgery? That was looked at by this paper. Well, pain can be related by the multiple intercostal spaces that you use. You can use one intercostal space or multiple spaces. The position of the port, so the more posterior position, can be related with pain. The use of multiple ports and the location of your extraction. So let's go over that. And so first of all, there's no single RATS technique. This was a very nice overview of surgeons, high-volume surgeons in the United States. While more than 1/3 try to use a single interspace for all of the trocars, and that can be helpful. What is the role of the posterior port and the posterior branches? You have to know that when you use just an intercostal block, you can miss this posterior division of your intercostal nerve. There's a medial branch and a lateral branch. It's a lateral branch that is important. Not only you can miss it with that type of block, but also that lateral branch goes quite lower than where the root is coming out. So up to 4 ribs lower. And so if you have your posterior port and you want to block it, you have to think about where you place your block. This can innervate much lower than you think. Number of ports, we can have a whole discussion about that, a whole day length. We know there's some articles that 3 hurts less than 4 and 2 hurts less than 3, 1 less than more, but not in the single one randomized controlled trial in uniportal VATS. But there is a trend that indeed with less ports you might have less pain. Interesting article is this. This is uniportal surgery. They extended their incision and didn't make any difference. So the uniportal port in 5th or 6th intercostal or 4th intercostal is an interesting port. At that level, even if you make it a little bit bigger, it seems to have no effect on pain. In Strasbourg, we had some discussions because many robotic surgeons, and they will not openly say it maybe in front, but they have noticed that when you do a lobe retraction of extraction of your lobe, you can have pain in the abdominal wall, even atrophy of the rectus muscle. And so many will advocate that you should place your extraction a little bit higher. I drove it now anterior, but my ideal extraction at this moment is actually where I normally do my uniportal incision. There I cause not a lot of pain. And what is the theoretical concept behind that? We have two types of intercostal nerves. The first one is the typical intercostal nerve, 4 of them, and they stay confined to the thoracic cage. But then you have the lower ones, and they go further. They go into the abdominal wall, bigger nerve, with innervation of muscles and also abdominal wall. If you hurt that nerve, you can have more pain, but also problems of the muscles of the abdominal wall. Drains. We have to talk about drains. No drain is less pain. This was shown in a randomized controlled trial of 2019. And also in 2020, and the Copenhagen group is working on a protocol, or has a protocol to look at that. So less drains, less air leak, less drains is less pain. Can you adopt your type of drain? Yes, you can place a smaller drain, that will help. You can also place, like in this study, 2 pigtails instead of a drain with good results, and also less pain. So you can adopt and maybe go for small drains, but ideally shorter days of drain and no drain at all. Knowing that this is all causing pain, I have to answer now the question, is there more pain therapy necessary with robotic surgery than VET surgery? Well, if you look at most of the articles that directly compare VETs with RETs, then you will find that there's more pain after robotic surgery, but this is at a level that you can say, okay, this is probably not clinically significant. But you can find statistically relevant more pain medication use after robotic surgery. But then when you compare it with open surgery, VETs and RETs, then most articles will say, okay, there's a big difference between open surgery and not so big or none between VETs and robotic surgery. So I have no time to go all over the literature, but expert opinion, review of the existing literature can say, okay, statistically higher use of pain medication might be found after robotic, but that amount is quite low and the clinical significance can be questioned. What therapy can we then give? First of all, in open surgery, the best is still epidural with an optimal pain control, but hypotension, urinary retention, and also sometimes block failures, but also dura function leaks and epidural hematoma, very rare. We like to use the epidural in open surgery. It's very good, but we don't like it for minimally invasive surgery. Another option, which is very good, is the paravertebral block. And even in open surgery, it has a similar pain control, not exactly the same, but similar in less hypotension, less urinary retention, so it's a very good alternative. Using a paravertebral block in VET surgery showed a small difference. Epidural was a little bit better, but again, the clinical significance can be questioned, and so it's a very good alternative to epidural with less problems. Another option is the erector spinae block. I just found out that you do that. My anesthetist doesn't like it. It's, I think, a bit more inconsistent if you don't exactly know how it works or how you have to do it. It's more difficult, I think, to place. And the indications are not well defined, and also how it works is not very clear, probably by an interfacial spread among the posterior rami, but maybe you can comment later. We don't use it in a randomized controlled trial that will be published soon from Leuven. Actually, the intercostal block is doing better. What a very good block is the serratus anterior block. Where is that? There's a location at the axilla fossa where these 4 types of nerves come together in the same compartment, and you can have a good result, but maybe less for the lower ports. If you compare those, then serratus anterior is very, very good, a little bit better even than intercostal nerve block, and better than ESPV. Then we have the, and I'm almost finished, we have the surgical placed paravertebral block of intercostal nerve block. If you go central enough, you have to go quite central, deep to the spine, then you can call this a surgical paravertebral block. This is really liked by the uniportal surgeons, and the question is, yeah, can you do it also with a robot? Of course you can. It goes very fast, it's easy, and you can do multiple shots. The only thing is, you have to discuss it with your anesthetist that you don't overdo, because with this technique, this is the technique where you have the highest blood levels of all techniques. So there is a possibility of toxicity of your local anesthesia. We were using intercostal blocks for a long time for uniportal. We wanted to use that for robotics, and the question was in our center, we did a retrospective study to see if it was adequate, and indeed, well, on the left side you see the pain medication the first day and day after the operation. It's quite low. This is in morphine equivalence of all the medication. We didn't find a difference between robotic and VETS group, and both had intercostal nerve blocks. So my conclusion, what is causing pain after minimal invasive lung surgery? Think about multiple levels that you're using, posterior ports, bleedings of the ports, the trocar size, the angulation of your port, your extraction site, the number of the ports, the drain, and that is connected with an air leak. There's a whole other presentation, but less air leak, less drain, less pain. More need for pain therapy, probably with robotic, but not clinically significant. I like the intercostal nerve block. It goes very fast. In the morning, you can immediately start. You don't have to wait in the first case, so you can do 3 cases a day or more. So is there a one-fit-all protocol? Yes, that's possible. In my case, the intercostal nerve block with a multimodal opioid sparing technique. Thank you very much.
Thank you. And the next topic to be addressed is suction or no suction in sublobar resections, and presented by Johan Fibler from Barcelona.
Thank you very much for the invitation. Postoperative air leaks after pulmonary resection are a major factor in keeping patients in bed and in delaying early hospital discharge. Chest tubes are critical components in postoperative management of air leakage, affecting hospital stay and cost. In recent years, with the advent of the digitally monitored thoracic systems, quantitative and temporal evaluations of postoperative air leakage and pleural fluid have become possible. A digital pleural drainage device connected to a chest tube provides continuous monitoring of any pulmonary parenchymal air leak. This technology is very sensitive and can detect small, clinically insignificant air leaks. The optimal level of suction on digital chest drainage devices after bad lung resections is unknown and varies widely between thoracic centers. The majority of trials rely on data from either traditional drainage devices or after open surgery. A best evidence topic was published in 2021, trying to find out what was the optimal level of suction after pulmonary lobectomy. 367 papers were found using the reported search, of which 4 were randomized controlled trials using digital chest drainage devices. These 4 studies represented the best evidence to answer the question. In 2013, Brunelli and colleagues performed a randomized controlled trial which included 100 patients undergoing thoracotomy and compared -2 centimeters of suction to regulated individualized suction levels ranging from -11 to -20 centimeters corresponding to the different types of lobectomy performed. They used a digital drainage system. The drainage removal criterion was an air leak below 20 milliliters per minute for 6 hours with a fluid threshold of 400 milliliters per day. They found no difference in drainage duration between the groups, and furthermore, no difference in air leak duration was found. Fluid output was reported after 48 hours, and in contrast to other randomized controlled trials, there was a non-significant difference in fluid output. In conclusion, in this study, lowering suction to -2 after lobectomy through thoracotomy did not affect air leak duration, length of stay, fluid output, not persistent air leak. In 2018, Laendic and colleagues performed a randomized controlled trial comparing -5 and -20 centimeters of suction in 106 patients undergoing both thoracotomies and BATS procedures. They also used a digital drainage system. Dural removal criteria were similar to the Brunelli study, with an air leak below 20 milliliters per minute for 6 hours, or in this case, below 50 milliliters minutes for 12 hours, with no fluid threshold, given it was serous. Authors found a significantly lower fluid output after 48 hours in the low suction group, and they concluded that the low suction of -5 significantly reduced fluid production. In 2019, another publication by the same author presented additional data from the same RCT, however, with a different focus. Authors found no difference in drainage duration and no difference in length of stay. Fewer patients with persistent air leak were found in the low suction group, however, non-significant. In conclusion, in their study, reducing suction and digital chest drains to -5 did not reduce drainage duration or length of stay. However, the rate of chest drain reinsertion was significantly increased. In 2019, Holbeck and colleagues performed a randomized controlled trial including 222 patients undergoing BATS lobectomy only and compared -2 to -10 centimeters of suction. This is the most powerful study published to date. They used a digital drainage system. Drainage removal criteria were similar to the previous study, with air leak below 20 milliliters per minute for 12 hours, without an upper fluid criterion given the fluid was serous. They found a significantly shorter drainage duration in the low suction group, also a significantly shorter duration of air leaks in the low suction group, and a significantly lower total fluid output in the low suction group. There was no statistically significant difference in length of stay, and found an increased proportion of drain rate sessions in the low suction group, which was neither statistically nor clinically significant. In conclusion, in this powerful recent study, reduction suction to -2 centimeters after BATS lobectomy significantly shortened chest drain duration and air leak duration, and it was also observed a non-significant reduction in length of stay and persistent air leak. Similarly, the fluid output was reduced in the low suction group without a significant increase in chest drain section, morbidity, or mortality. Inspired by this paper, we started a single-center parallel arm randomized controlled trial in our department focused on wedge resection for diagnosis and/or treatment of peripheral lung nodules. This trial is ongoing and is conducted at our department in Hospital Universitari del Sagrat Cor in Barcelona. Inclusion criteria: patients over 18 years old with lung nodules clinically staged as T1A and 0 consenting to participate. Exclusion criteria are patients with history of pneumothorax on anticoagulation antiaggregation therapy or not consenting to participate. On a first visit, we explained the features of the study to the candidates and the option to participate. Then they are randomized to enter in the low suction group -1 or the standard suction group -15. All BATS procedures are performed by the same team of surgeons, and all the patients have peripheral lung nodules inferior to 2 centimeters in CT scan. Samples are studied intraoperatively to confirm diagnosis and save surgical margins. Mediastinal lymphadenectomy is systematically performed. We employ paravertebral analgesia in all the cases, and after surgery, chest tubes are connected to a digital chest drainage and monitoring system, to -1 or -15, depending on the randomization. test tube removal criteria are air leak under 20 milliliters per minute for 6 hours and pleural fluid under 300 milliliters in 24 hours. In hospital variables registered are pleural fluid, air leak, test tube removal, discharge day, and any event or complication. We do in all the cases a 10 days after surgery visit, where we register pleural effusion in contrast chest X-ray, pneumothorax in contrast chest X-ray, or any event or complication between discharge and the visit. The study is ongoing, and we just got preliminary results with no statistical value, with 30 patients, 15 in the low suction and 15 in the started suction. And we have observed no drain rate cessation in both groups and no significant postoperative morbidity, neither in hospital nor in first control visit 10 days after. We have observed a tendency to a shorter duration of air leaks in the low suction group and also a lower total fluid output in this group. In conclusion, after reviewing literature, it is accepted that the new digital drainage systems enhance early mobilization as it's recommended in the enhanced recovery after surgery programs. However, there is no consensus on the optimal level of suction to apply. Based on data and our preliminary feelings, and according to the current data, a low suction may reduce total fluid drainage and air leak duration compared to higher suction levels using digital drainage devices, although the evidence is not definitive. Surgeon preference will likely continue to guide practice until the evidence gives clear-cut recommendations. Thank you.
Thank you, Dr. Fibla. And now let's continue with the last lecture, Dr. Firas Abu-Ekar, that will address subchiefate approach for combined mediastinal and pulmonary resections.
Thank you so much. Well, it's been more than 120 years since the first reported transcervical thymectomy was done by Schorbach. And in the 1930s, Blalock had a case of a thymoma, and he did a transsternal thymectomy for this case. And at the same time, the patient has myasthenia gravis, and he noticed that the symptoms was improved after the resection. So the hypothesis started then if there is any relation between the non-thymomatous resection and myasthenia gravis. And since then, some paper was published. The first big series was published in 1946, about 50 cases, and they described the technique of partial sternotomy for thymectomy, and described the anatomical variations in this technique. In the 60s, Osserman published a 20 patient or 21 patient who had underwent transcervical thymectomy, and he reported the advantages of this technique. And so it is better cosmetic technique and can give better, less complication and better recovery. A couple of years later, Masaoka criticized the transcervical thymectomy. I claim that this kind of resection is not a complete thymectomy, and it could be a dangerous technique because there is no control for bleeding if it happens or complication during the surgery. So he recommended to go back to transsternal technique and to get to the sternotomy thymectomy as a standard technique. In the 80s, Dr. Cooper came with his famous retractor, and he published a paper about 65 patients who had good result, and and it's very comparable to the transsternal approach. and the debate continues about the approach. Then in the 90s, the game changers appeared on the scene. The video-assisted surgery started to enter our field, and reports about VATS thymectomy started to come up. Many papers described advantages of VATS in thymectomy, which can give less, maybe not inferior mortality and remission rate, and they can even give better results in terms of hospital stay and blood loss and patient satisfaction. So it has been like a near consensus about that. Thymectomy, especially the non-thymomatous thymectomy, should be done minimally invasive and not with open thoracotomy, with open sternotomy. And the debate continues about the approach. Should be from the right side, left side, maybe bilateral. Right side is a good approach for exploring and exposing the innominate vein and the innominal-caval junction, and maybe it will cause less compression on the heart during the surgery. But at the same time, the right side do not expose the aortopulmonary window, which is a very common place for ectopic thymus. So some papers came with a bilateral approach, which could be maybe a solution for this. Then another papers claim that there is no difference in rate of remission between the bilateral or unilateral approach. So the debate continued. Diego Gonzalez published about the uniportal approach for the intercostal uniportal approach at 2015, but it didn't resolve the dilemma of the side. It should be done from the right side, left side. Back to the 90s, some paper was published from Japan and also from Poland by Dr. Zelinsky about the combined transcervical plus subxiphoid approach with the assistance of the thoracoscope. And the first uniportal thymectomy report was in 2015 by Suda from Japan, and he claimed that approaching the thymus through the subxiphoid area could be better because you avoid damage of the intercostal nerve, and it can give a panoramic view, phrenic to phrenic, for all the mediastinum, and you also can do pulmonary procedures through this approach. In Shanghai, where I did my training, we adopt this technique since 2016. We published some paper about this. The initial experience published a couple of years ago, 38 operation of a thymectomy on thymectomy plus lung resection. This is our data. 7 operations were combined, the lung plus thymectomy through the uniportal subxiphoid approach. The outcome was pretty good. About the technique, we do the supine position. We put a small cushion behind the back of the patient just to elevate the mediastinum a little bit. The surgeon stands at the right side of the patient, the assistant on the left side. We can use also the lithotomy position sometimes. I think the patient on the right side of the surgeon on the right side of the patient is more convenient. A double lumen tube is mandatory in this kind of surgeries because we need to switch the ventilation of lungs left and right. Vertical versus transverse incision. At the beginning of the learning curve, we have done the vertical incision when the subcostal angle is narrow, and we did the transverse incision when the subcostal margin is more than 90 degrees. But with the time, we started to do almost every patient with the vertical incision is more convenient and more simple. Many retractors were designed for this kind of techniques. We have tried everything. We install retractors from neurosurgeons, general surgeons, but the simplest is the better. We just bring any retractor and put the Army Navy to hang up the sternum, and it does the work very well. And all the idea here is to get more space to enter the instruments. We don't put CO2. We started to put CO2 at the beginning, but we stopped with this because there is no need. Wound protector is helpful to prevent contamination of the wound and to make the surgery more clean. These instruments, long instruments for a subxiphoid technique, more than 40 centimeter, designed specifically for this technique, but you can also use the simple uniportal instruments and can do the job for most of the patients. Harmonic or Maryland, it's operator preference. Short video about how to do this operation. So we open the skin, we get to xiphoid, we remove the xiphoid process. Then we deflate the right side lung. We enter the right pleural space first. We start with the diaphragmatic fat. Then we do, the next step, we do the retrosternal tissue. We remove it, so to give the mediastinum to go a little bit backward. Then we start the dissection just medial to the right phrenic nerve. After identification of the innominate vein, we continue all the way on the innominate vein until we meet the thymic vein, thymic branches. The thymic vein, if it's a small branch, we can just do it with the energy device. If its diameter is large, so we do a clipping. Then we open the left side. We usually don't open the left pleura until we finish the right side of the innominate, just to prevent lung intervention, left lung intervention to the field. Then we do the left side along the phrenic nerve until we get to the innominate vein again from the left side. We do the horn. Horn could be cut, or it's better maybe to be tracted to get a full resection of the horn. Then we put just single chest tube usually in the space, and we introduce it through the same incision. The next video I will skip. I think we ran out of time. It's about a combined resection of right upper lobectomy and thymectomy, so we will skip it. So to conclude, subxiphoid approach is another approach to use for thymectomy. It can maybe reduce the pain because we are dealing with the nervous area and maybe a less painful approach. It can give us also better visualization. Complex procedure can be done through this approach. And of course, learning curve is crucial in this approach. And thank you so much.
Well, thank you for your presentation, and take a seat. And now the papers are open for discussion, both from the floor and in between people. So, well, first question, Bo Holbæk.
Bo Holbæk from Copenhagen. This is for Juan Fiebler. I think this is very interesting when you are going into the chest drain debate, because it's actually quite difficult to change practice, even with good studies. So good on you for doing the research. And I really like the fact that you went through the different studies on digital chest drainage devices. I want to supply with the 3 different studies that are pointing towards no suction. One is from Robert Sofolio from 2001, another one from Blair Marshall in 2002, and a third one is from Kuwait in 2003. And actually, when you look at the positive studies, they are all pointing towards no suction. And what is no suction on a digital chest drain? That's difficult, because you can talk about physiological pressure, but in the post-resection area, it's more pathophysiology. So what is the right suction? We pointed at 2 centimeters of water, but a lot of people are against using that low levels of suction because they risk, they might think this poses an increased risk. But I don't think we have any studies showing that it does. We only have radiological sort of, you want to improve the X-ray. I want to ask you, how many patients are you going to include in your study?
It's at the present moment it's ongoing, and we try to get at least 100 patients.
Okay, because the majority of the studies, including 100 patients, they showed no difference, and I think it's because they're underpowered. Another reason why you might not show a difference is when you have the maximum tolerated fluid output of 300 milliliters, which by some groups would be considered quite conservative, you will be waiting a long time to reach the 300 limit. And that time is when the air leak has already ceased. So you will probably not show a difference if you only include 100 patients and if you don't liberate the fluid criteria.
Yeah, thank you for your comments.
That's all you're going to say? Thank you for the comment? I mean, we're going backwards here, man. We're going backwards. 2001. You probably weren't born, but unfortunately I did the study. 2001, we showed that low suction water seal is better. And whether water seal is -1 or -2, -3, who the hell cares? Who the hell knows? The device isn't that accurate. Why are we measuring drainage? We've shown 5 years ago you can pull the chest tube out 2 hours after surgery, and 80% of people after lobe, segment, bilobe, pneumonectomy. We just watched the thymectomy with a chest tube. Why are we putting a chest tube in a thymectomy? Pull it out before they leave the OR. I mean, we're going backwards. So we should be getting the chest tube out in the operating room if there's no leak. The drainage doesn't matter. So if you're pulling the chest tube out in the operating room for 2 hours, does it matter if you put it on suction or not? I think the problem is if there's a space. So if you do a bilobe and you put a tube in and there's a giant pneumothorax, if they're asymptomatic, it doesn't matter. But I just got called this morning by a patient I did a bilobe on a week ago. I pulled his tube out in the OR, and now he's back in our ER 8 days later, and he needs a new tube put in. He just put it in 10 minutes ago. So I think it's different for lobe versus bilobe. So I think what you're doing without x-rays, which we don't do because x-rays don't matter unless the patient's symptomatic, and he came back 8 days later because he was out on a walk last night. He went on a long walk and on a bicycle, probably coughed, he had some coughing. So this is complicated. But let's not go backwards. So my point is, we can get tubes out, I think, in the OR or within a few hours. And if they have an air leak, send them home on postoperative day 1. Let's all do this so other patients can be in the hospital, and we're not keeping people in the hospital for no reason. 2 days at the most. Please, 1 day, no more than 2. And let's get them home. Do you agree with that? Can you make a comment?
I'm going to make the comment, because this is Thorfolio's environment. And we all agree that those works 20 years ago were right. But the reality is that how many people live, I mean, the chest tube was out 5 hours, which 5 hours is almost just postoperative. But the reality is that the professionals, the thoracic surgeons, keep the tube inside for more time and applied or not suction. And this is a debate which shouldn't be. But yeah, but it is. So
Give people the change.
We have to get proofs.
You're just studying wedges.
Yeah, it's.
I mean, you're just doing the study on wedges. So that's not going to change our practice with lobes or segments. We got to be bolder.
Okay, thank you for a comment. Other questions? Yeah.
Yes, just one study that Brunelli published in 2005 that not many people knows about that, but alternate suction at night, but off during the day. It was a randomized trial, 100 patients about, and in fact, the alternate suction did better. Maybe it's, you know, of course, when we do different study, sometimes we find different results, but maybe we should revisit that, you know, to alternate. Maybe the fact that you put suction and no suction, it maybe creates some friction inside of the pleural cavity. I don't know, but...
if the patient has a chest tube in, at night you fail. Our goal is to get the tube out. No patient should spend the night with the chest tube in. That's our metric at our hospital, honestly. We consider it a failure. Now 30% fail, because 20% go home the next morning with a tube. But if you're a patient, do you want to sleep with the chest tube in? I don't. I want my surgeon to get it out. So we consider it a failure. And we fail a lot, but that's the reality of it. There's no reason for the tube to be in if there's no air leak. The fluid doesn't matter. We have data on 700 people that they don't come back with effusions. 2 or 3% come back with a fluid that need to get tapped, whether you leave the tube in for 3 months, 2 years, or 2 hours. So long as it's not chyle or blood or CSF, the tube can come out.
No, I agree with you for a patient with no air leak, but there is some patients sometimes that there is air leak, post-op day 1 or 2 that were...
Then send them home, and if you put them on suction when they're home, who the hell cares?
Yes.
Because it doesn't matter then. Let them go on suction. Actually, we send them home, we put them on suction, because it's not a length of stay, and we just leave them on -10, and we pull the tube out when they have less than 20 for a day or 2.
You send them home with a Topaz or the...
We use a Centis, but it doesn't matter, a digital system.
Gentlemen, excuse, I think we have enough about this topic. There was many other papers that we would like to discuss, so questions for any of your other papers? Then, while you're thinking about it, I will ask a question to those who are comparing different approaches. What I'm thinking is, what about the surgeon's factor? Looking, for instance, at the Raval study, there's a conversion rate in VATS of 16%. To me, that tells it's not experienced VATS surgeons. So in all those studies, might actually the surgeon himself not be a major factor influencing the study?
Yeah. Is it? Oh, okay. Thank you for the question. That's a good point. We did an analysis, and we could not find a relationship between the... It's also difficult to define the surgeon expertise. I mean, you put a threshold of a number of surgeries, you put a threshold on the years of practicing. This group of interest of VATS surgery was designed to know the penetration of VATS surgery for anatomic lung resections in the country. So That's a good point. It should be taken into account, but I'm not sure that taking together all important prognostic factors like for the long term, I think the expertise of the surgeon, if you are doing an oncological resection, your expertise will impact the preoperative period, your complications rate. But I'm not sure if it's going to impact, provided you are doing the same surgery you would do in an open approach in the long term.
May I ask Dr. Abu-Ekr also that I like very much the approach, the substitute approach. You couldn't show the other video, but I think you also do a lobectomy by this approach. Are you able to also to do lymphadenectomy by this approach, or do you combine with some other technique when you have to do it?
Very good question. Actually, we have done many subsyphod lobectomies. It's good approach for right upper and middle lobectomy. We stopped doing it for the lower lobes and mainly for the left side because it competes with the heart movement. Lymphadenectomy is challenging. You can get full lymphadenectomy with this approach, but you need to invest half hour more than do it by intercostal approach. So if you have a case that you have to do a thymus with something with the lung, so this is a very good approach. To do a pure subxiphoid lobectomy, it's possible, but I can see a lot of advantages for this.
Thank you. Well, discussing lymph nodes, then I have a question to the papers about lymph nodes. People really counting, and you showed no difference in long-term survival, but what about morbidity in being more aggressive in lymph node dissection? Is there an increased morbidity in being aggressive in lymph node removal?
In VATS or in RATS?
In both.
In both. In VATS, in HVATS groups, we didn't find in a previous article differences between both groups. Maybe I think only in some complication related with pneumonectomy, but not in global in both groups. So I think
so it doesn't decrease the morbidity?
Not in general complications. No.
The same. In our study, there are no differences in the complications.
Well, question from the floor. Yeah.
I would like to come back to the elephant from the first presentation. Did you also do an intention to treat analysis, so including these converted patients, because it's very likely that they have some more morbidity and maybe even lethality, these converted patients. And if we are looking on we are living in a bubble here, I think. So the real broad quality of VATS lobectomy may include a rather high conversion rate. And if we advocate for VATS lobectomy for whatever reason, we must be aware that if others also start on doing that and have a high conversion rate with negative consequences for the outcome, that will be detrimental for the overall outcome. So maybe it could be better to be careful about that in the broad space if you're not so experienced. So did you do this intention to treat analysis, whether with inclusion of these converted cases also the outcome is better with VATS?
Yeah, that's a very good point. We did the intention to treat analysis and results were similar, like as to exclude this group of patients, so no differences, but conceptually we decided to exclude them from the analysis because this is not a prospective clinical trial. So those patients were, the approach was an open approach. So it was the decision. But you're totally right. I mean, the lecture is that it's not the same to convert because you have oncologic issues with the surgery you are doing with a minimal invasive approach, or to convert after 5 hours of a challenging case and then have an accident and the patient receives a polytransfusion and goes to the ICU. So there should be some criteria to select, according to your expertise, which patients should be approached through an open or a minimal invasive approach. Yeah.
I will give only one answer to Dr. Cerfolio regarding the why to put a chest tube after thymectomy. It's for me to, I sleep better when the patient with a chest tube, especially in day one.
Does the patient feel better?
I feel better. I sleep better.
Well, discussing the pain, Herbert.
Yes.
What do you think about the importance of chest tube? Is it really that important that Cerfolio states, or is it? Does it matter?
I started with your paper from Copenhagen.
I know.
It's air leak, pneumonia, pain. And so my question to you is, those patients who stayed longer than 2 days and had pain, why did they have pain?
But the next question is the pain related to the chest tube, or is it other sorts of pain?
Well, that was my question to you. Do you think that the patients...
It's not analyzed in the paper. So.
Well, I think that it would be interesting to know that those patients who stayed longer because of pain, if they still had a chest tube, and I think that those were the patients with the chest tube also, that you had an overlap between air leak and drainage. So for me, when I looked at my results, I have to do something about my air leak.
Well, we did see many years back, we published a paper on avoiding epidurals. It was published in 11 or 12, and doing the paravertebral block and paravertebral catheter. And our initial experience there was that it was not the utility incision that did give pain, it was the tube that did give pain post-operatively.
Absolutely, it's the parietal pleura. That is very, I mean, when you place a chest tube, you know when you hit that pleura, that's what is hurting. So when you have an alien something there rubbing on the pleura, that's causing the pain.
Then next question, and I don't have the answer, even though we have studied this intensively in our clinic. Does the size of the tube matter?
I do think so, and that's always what you want to achieve with your tube. The reason that I place a big tube is not because of fluid, but it's indeed when I expect there will be some mass movement of air, and that's where you have the subcutaneous emphysema. It's a patient with a lot of air because you did a bilobectomy, and that patient is coughing suddenly. The drain cannot capture all the air, and then you have the sudden subcutaneous emphysema, and the only thing you can do is place more drains or place a vac to help it. And so that's, yeah. So in those patients I would still, I mean, bilobectomy, I'll still go to 24, otherwise I go down to 16, yeah.
I think my experience from long volume reduction is sometimes you might have quite a big airflow, and actually the inner diameter of the really small tubes are too thin, and then they get subcutaneous emphysema simply because they are not space enough for the air to slip out.
Yeah, absolutely. And that was another question to you then. With the digital system, TOPA system, when I go to -2 and the patient has a leak, definitely a proven leak, sometimes it goes in alarm. And when I go up to -8, it stops, that alarm. So we are playing a lot with that -2, we go back to -8. Sometimes with some more suction, you pull the lung against the wall, and then there's an adhesions that can form, and the air leak stops sooner. So after the article, right control, we went to -2, but we are playing with it a lot. Go up, go down. And
to be a bit provocative to have a discussion here before lunch, I could also postulate that if you have high suction levels, fibula might participate, but if you have high suction levels, you might keep some fistulation.
Yes, except if you are pulling the chest tube and the lung against the wall, and then it stops, and then suddenly you get an air leak again. But at that moment you can have fibrin or whatever, and sometimes that's the moment it stops. And when you have just -2, you have some pneumothorax and a continuous drain. So it's, for me, we are playing with that when we have an air leak. Yeah.
Can I just come back on the chest tube? Sorry, I know I would prefer to have no chest tube, obviously, at night, but sometimes we don't have choice. And I think, Dr. Fibler, you publish your group in 2011 sending home patients with the digital suction, isn't it? If I'm not mistaken. Have you published in 2011 a report on sending home patients with the digital suction?
Don't understand the question. Tell me.
If you have, or Dr. Mullins did publish a paper on sending home patients with the topaz, with the digital suction.
Yeah, we send them with the topaz if they have a persistent or a leak.
I think you're the first group who published on that. So you're sending still patients. I'm just curious from the crowd, how many of you are sending patients home with the digital suction? Because in Canada, I have a lot of resistance from the hospital administration to send patients home with the digital suction. So I'm just wondering if the majority of you guys are sending patients with the...
Well, here at the end of the day, I just tell a short story. At some point, we did send patients home with topaz, and then one day, one of our nurses, they'd see a patient at an area where there are drug addicts trying to sell the topaz as a radio to get money.
You have to tag them. So
yeah.
Yes.
That's important.
Right.
Should be close.
Okay, thank you. Good presentation.
Thank you. Thank you for attendance here. Now it's time for lunch, and there will be a highly interesting program in the afternoon. Thank you.
Dear colleagues, it's my pleasure to co-chair this session with Dr. Serfolio, who doesn't need any presentation at all. My name is David Gomez from Madrid, Spain. And this will be a session about how masters perform their surgical techniques. So without further delay, please, the first speaker is Carlos Galvez, a thoracic surgeon from Alicante in Spain. Please, the floor is yours, Carlos.
Good afternoon. It's my pleasure to be here. Thanks to the organizers for the invitation to join this amazing meeting. Is it working? Or not working?
Can we put up his slides, please? They have to put them up, then you can hit the button, it'll go. There you go.
Okay. Well, no conflict of interest in regard to this talk. And I have to talk about upper and middle segmentectomies. I won't talk about middle segmentectomies. It's not that common. But there are a lot of combinations, a lot of possibilities. Time is limited to 10 minutes, so I try to focus on the 5 main procedures, S1, S2, and S3 on the right side, and combination of 1 plus 2 on the left side, and 3. So let's start with the first video, apical segmentectomy in the right side, probably the simplest segmentectomy and right upper lobe. So first of all, I think it's important to get the dissection of the superior trunk and try to identify if there is a recurrent artery for segment 2. You know that almost 60% of cases have this recurrent artery, and you have to preserve it. Many surgeons divide it, but you have to preserve it if you want to perform S1. For the vein, the anterior vein, which is the rightmost portion of the superior pulmonary vein, is located on the right side and usually drains both subsegments of segment 1. So here you can see the division is easy. And then you get the dissection just below the stumps of the artery. And here you can see the dissection of B1, you can see B3 directing anteriorly to segment 3. And if you have a recurrent artery, it's important that you, while dissecting the bronchus, try to not to injure the recurrent artery for segment 2. And when you finish this, is the moment for the intersegmental plane. It's simple, it's a linear staple line. You can use techniques as, for example, in this video is indocyanine green. Probably it's most reliable, but most of us use inflation, deflation techniques are available everywhere, so there's no need for indocyanine green. But in this case was operated with this technique. Important where to put the envelope in the stapler, where to leave the proximal stumps and the left stumps, and then starting first dividing from segment 1 from segment 3, and then segment 2 from segment 1. This is posterior segmentectomy. It's probably middle complexity. I usually start first by the superior trunk. Why? Because you have to look for the recurrent artery. I tell you again, it's 60% more or less of the cases that you have recurrent artery, and it's important that you get it individualized. So after you get this, probably most of this procedure can be approached by the fissure. So let's go to the fissure now. And in the fissure, you have to get the dissection in the fissure posterior portion, get the dissection of the central vein, and here you can see this is one of the segmental veins for segment 2, V2A, but you can see also V2B and almost V2C, which is intersegmental vein. Here we are dividing V2A. Below you can see the artery. This is the posterior ascending artery. Many surgeons only look for this artery while performing S2, but you need to look for the recurrent artery in the superior trunk. Here you can see this is the division of the artery. And then below these stumps of the vein and the artery is the moment to dissect the bronchus, the posterior segmental bronchus. No problem because you have already divided the recurrent artery. If not, you can have an injury with the recurrent artery behind. You can check it bronchoscopically, inflation, deflation, wherever, and then it's moment for V2B, which is a little bit more anterior. If you want to really perform anatomical segmentectomy, and V2C, you can see is intersegmental vein between segment 3 and segment 2.
I know you only have a few minutes, but do you dissect out the B1 and the B3 to ensure you're preserving them, but when you take the B2, do you teach this?
Yeah, we can talk later,
okay.
Because if not, I'm going to be out of time. Sorry.
All right.
Sorry for this. This is the intersegmental plane. It's easy. You start by the fissure, first from S3 and S2, then you move posteriorly in order to divide S1 from S2. It's important that you put the embols, leaving the stumps where you have to leave them, proximal and distal. This is, can you play this? Because it's not automatically. This is anterior segmentectomy for me, the most attractive in right upper lobe. And I first start with the vein. Getting the dissection, you can see anterior vein on the right side, central vein in the center, and in this case, there was a segmental vein draining directly to the superior pulmonary vein. So first of all, dividing this vein, and then go to the artery, superior trunk. 70% of the cases, the arteries for segment 3 are located in superior trunk. You can have an inferior trunk, but it's not that common. I started by dividing only one of the segmental arteries. I hesitated about the other one. I divided later, but I wanted to take the dissection more distal. And then it's time to dissect with tunnel technique just above the central vein. Why? Because you have to open the intersegmental vein between 3 and 4, which is the minor fissure. So it's easy in the most superficial part of the intersegmental plane, but then you have to get the dissection really with the tunnel technique above the central vein, because the approach for segment 3 is usually focused on the central vein. And as long as you get the dissection of this intersegmental plane, you can see here B3A, the other segmental vein for segment 3. And continue with the dissection in order to then divide the intersegmental plane later. So keep the dissection, then you can see the cross of the pulmonary artery with the central vein. It's a good view now. Pull the lung inside the endostapler, and here you can see B2C. B2C is intersegmental vein. You can divide it because it's going to be probably easier to dissect than the bronchus later. So here, you're going to see how the central vein remains after dividing the veins for segment 3. You can see the veins for segment 2 at the end, by the end of the view. And now, intersegmental vein between 1 and 3, and that's the moment for taking the dissection of the bronchus for segment 3. You can, for sure, check it again, divide it, and then continue with the intersegmental plane between 1 and 3, and as long as you get more posterior, it's going to be between 2 and 3. And again, take care of where you put the envelope of the endostapler. And now we're going to move to the left side. S1 plus 2 is, I think it's an easy segmentectomy. First, start with the vein, identify lingular, identify the veins for segment 3, and the leftmost portion of the vein is vein draining 1 and 2. Easy to divide it. Let's go for the artery. Usually there are two arteries, but you can have 3, you can have 4 arteries. It's important that you identify artery for segment 3 in order to preserve it. It's important to identify if there is not a pure mediastinal lingular artery, because that could be a problem for you. And then you take first the big trunk, A1 plus 2, A plus B, and then go to the fissure, the posterior aspect of the pulmonary artery, and get A1 plus 2, C. This is the most conventional pattern for segment 1 and 2, but I want to tell that sometimes you can find 2, 3, 4, even 4 arteries. What about the bronchus? The bronchus is located between A3 and the posterior, the pulmonary artery in the fissure. You take the dissection a little bit more distal, and you realize that you have only one possibility, that's B1 plus 2. Time to divide it. And then intersegmental plane, really similar to the intersegmental plane for segment 1 in the right side, which is positioning the embryo, leaving the proximal stance on the left side, preserving the artery for segment 3, and dividing between 1 and 3 at the beginning, and as long as you get deep inside the division, probably you will be dividing between 2 and the most posterior portion of the lingula. So with these maneuvers, you're getting distal and just completing the intersegmental. And this is probably, can you play it, please? This is probably the most attractive segmentectomy in upper lobes for me. Sorry, can you play it? Thank you. Why? Because it's a little bit more challenging. I first start with the vein. It's normal. You identify lingular vein. You identify vein for segments 1 and 2. And in the center, this first branch usually is called B3C. But all the portion, all the central vein that you identify here is usually the vein, the central vein that drains segment 3, but sometimes it drains also the most posterior portion of segment 2. So you have to keep it in mind. You have to take a look on your model or your CAT scan. And here we have divided, because in this case it was not draining the posterior aspect of 2. What about the artery? You can go by the hilum, but in this case it was an artery coming from an artery for segment 1 and 2. It was a common trunk, A3 and A1 plus 2, A plus B. So I kept this frame, you pull the vein for segments 1 and 2, and take the dissection inside this frame. You divide the artery. You have to rule out that there is not a lingular artery, mediastinal, and then you need to get the division of the intersegmental planes before dissecting the bronchus. Why? Because if not, it's going to be really difficult to divide it. So you start dividing between 1 and 3, between 3 and the lingula in a V shape. This is one of the things that makes a little bit more difficult this procedure. And as long as you get a little bit deeper inside the lobe, you realize that you can identify now the bronchus. The bronchus for the lingula, bronchus for 1 and 2, and bronchus for segment 3. Now it's easy to divide it. Why? Because you have already opened the intersegmental planes. If not, it would be really challenging. You check it, you divide it, and after this, you just need to complete the junction of both intersegmental planes with the endostaplers. Take in mind that sometimes if you don't find the artery in the hilum, maybe you can find the artery. It happens to me a couple of times. After, when you divide the bronchus behind the bronchus. But it's not that common, but you should keep it in mind. This is the view after completing the segmentectomy. So in order not to waste more your time, I would take some take-home messages from right upper lobe. I would say that recurrent artery identification is essential if you want to perform S1 or S2. Each segment deserves a different approach. I would say hilar for S1, fissural for S2, and central vein focus for segment 3. If you hesitate about the veins, don't worry, don't get concerned. Wait and go on with the dissection. And what about the left upper lobe? Well, first of all, identify the origin of the lingular artery. It shouldn't be a pure mediastinal lingular artery. Look for the origin of A3, if it's from pulmonary artery or from a common trunk for segment 1 and 2, because it correlates with location. Consider that not always the central vein means V3. Sometimes it drains some posterior portion of 1 and 2. And remember that the V-shaped intersegmental plane stapling makes S3 probably the most difficult procedure in the upper lobes. That's all.
I would just say that was 10 minutes of 17 hours of amazing information. And when I'm operating, there aren't little labels that say 1, 2A, 2AB, 2A. So you got to figure it out and know what the hell you're doing. So congratulations.
Next master is Sergio Bolufer, who will be talking about lower segmentectomies by VATS from Alicante, Spain.
Yeah.
Please, Sergio.
So thank you very much. It's a great honor to be here presenting our experience in sublobar resections, in this case, lower lobe segmentectomies. So our standard approach is uniportal buds, and we first open the fissure. We perform a fissural approach, which is very different from the lower vein approach or the inferior approach. And during the presentation, we will review cases 7.7, 7.8, and 7.9 plus 10, segmentectomies on the right lower lobe, and also segment 8 and 9 plus 10 in the left one. So we will review the main steps, some tips and tricks, and also some relatively common variations. So this is the first one, segment 7, segmentectomy on the right side. So the first thing, open the fissure, and then we identify the first branch in the anterior aspect, A7. Also distalize the dissection to identify A8. And this venous trunk coming, this is a variation coming from the superior vein. So we divide A7 in this case. And then we dissect the bronchus, which is also in the anterior aspect of the fissure. We control this aberrant venous branch for segment 8, and we expose B7. We control it and then divide with the stapler. We also check for ventilation to be sure that we are dividing the right bronchus, and then we go to the vein, in this case B7A, with the energy device. After that, we distalize the stumps to be included in the specimen. While we divide the intersegmental plane, we check for ventilation again. And then we finally divide the segment from the rest of the basal segments. In this step also we identify B7B, and then we divide with the stapler. And finally we detach the segment from the other basal segments. We finish the procedure. So the next segmentectomy is 7.8, also on the right side. So we open the fissure again. We identify B8, in this case, in front of the bronchus. We control B8, and we divide with the energy device. After that, we check a common trunk, A7 plus 8, and we take the control. A8 is our target, so we control it and divide it. And then we look for the bronchus, for B8. So we have to dissect the bronchus. We take control of A7 to apply some traction to improve the exposure. In this case, we see B8 and also B9 plus 10. We control B8, and we check all the other structures. Now we divide it with the stapler. Also with ventilation maneuvers and checking on the anterior aspect of the fissure, the ventilation of segment 7. And then we start with intersegmental planes, in this case separating segment 8 from 7. And then, like a V shape, we continue dividing the segment, separating from segments 9 and 10. We finally finish also the procedure. So next one is segment 9 plus 10, probably one of the most complex segmentectomies we can perform. So again, we start opening the fissure, identifying all the arterial branches in the pulmonary artery. Here you have all the branches. We take the control of A8 just to apply traction to expose A9 plus 10 and also the other structures for segment 7. We divide V6 from basal vein to create the tunnel to divide the first on the main step during this surgery, the intersegmental plane between segments 9 and 10 and also segment 6. So we progress dividing this intersegmental plane, always checking from below that the structures you have to preserve, in this case V and B6, of course A6 and the other structures, and finally we get the step to came out in the posterior mediastinum and complete the division of the intersegmental plane. So after that, we just control A9 plus 10. We divide it with the stapler. Behind the artery, we find a common also bronchus B9 plus 10. We control it and divide it with the stapler. And our recommendation, if you have doubt with the venous branches, the easiest way to control it is pulling up the bronchial stump, and most of the times the vein is just behind and you can control it without any other difficulty. So we start the division of the intersegmental plane, in this case separating segments 7 and 8 from 9 and 10 in the anterior aspect. And finally, we continue with the separation, checking always the venous branches from segments for the remaining segments, 8 and 7. And finally, we separate both segments and complete the procedure. So let's move on the left side. The first procedure is segment 8 segmentectomy. Again, we open the fissure, expose all the arterial branches. And in this case, I'm checking with the 3D model. We check A6 in the posterior aspect of the fissure. We have A8 in the normal position and aberrant A8 artery. As I said, checked with the 3D model. This is this one. It's up in the artery, so we also control it and divide it. So after that, we control A9 just to improve the exposure of the bronchial dissection. We check another aberrant bronchus accompanying this arterial branch. We also check B8. After that, B9 and B10 to be sure that you are dividing the target bronchus for this segmentectomy. This is this aberrant bronchus I told you. It's not so frequent, but sometimes appears. So you have to identify it in the scan and in your models, also in intraoperative bronchoscopy. We divide it also, and then the normal position of B8 in the anterior aspect of the fissure. So we divide it with the stapler. We check the vein, in this case a common trunk, B8 and 9. We divide the 8 portion of the vein, preserving B9. And finally, we distalize all the stumps to be included in the specimen and start with the intersegmental planes, separating the segments, from the other basal segments. We complete it from the fissure and also from the diaphragm. We cross the lines and we finish the procedure. And now the last one, segments 9 and 10 on the left side. We start also from the fissure, and as the same way on the right side, we open the space between V6 and basal vein. We open the fissure, identify all the branches, and start dividing. So this case is different from the right one. We first divide arterial branches. This is, I think, a better maneuver, just to create the tunnel to divide the intersegmental plane between segment 6 and 9 and 10. And also you minimize the risk of vascular tearing. So we are starting now the division of the plane, the same as on the right side. Checking, of course, in this case V6 and B6, we have to preserve it, and to exit between V6 and the basal vein. We complete the plane. And in this case, again, we check for B8 and also for B9 and 10 to be sure that we are dividing the proper bronchus. So we start with B9, and again B10. As I mentioned before, we pull up this stump and you will find the venous branches. So our first branch coming from B6, this is not so common. And after that, we identify V9 plus 10, then we control it and divide it. So finally, I think 20 seconds more, we divide the intersegmental plane between segments 8 and 9+10 from the upper part of the lobe, also from the mediastinal side. We preserve V8 in this case and also place the stamps in the specimen. From the diaphragm part and also from the fissure, and then we cross the lines, and finally we complete the segmentectomy. So in this case, we also use this part to prevent any torsion and to keep the segments on the proper position. So my take-home message is it's essential for me to memorize segmental bronchovascular anatomy on CT, on the 3D reconstruction model, also in the intraoperative bronchoscopy, and correlate these findings with the operative field. So first step, always open the fissure, identify all the segmental arterial branches, distalize to be sure that you will prevent any misunderstanding and you will correlate with the imaging studies. Check also the target segmental bronchus at the remaining segmental bronchi by intraoperative bronchoscopy. For us, it's mandatory, this step. Divide segmental veins after bronchial division, as I mentioned before, and also correlate the 3 dimensions of the segment when dividing the intersegmental plane. Probably this is one, sometimes, of the more difficult steps during the surgery. That's all. Thank you very much.
Now Dr. Cerfolio will tell us about management of complications.
Yeah, I can't help but comment. I liked your second segment. Forget the slides. Let's just go to the video. We don't have time. To do the artery first, as opposed to doing it later, because if you do the artery first, you can then identify the intersegmental plane in 8-9 by giving ICG, using Firefly with or without a robot, or taking the bronchus and then doing it. Take the slides down. We'll just go to the video. Yeah, thank you. So first of all, this is a master session, and there is only one master, and that's a guy on a very different plane than us. The only thing I'm a master at is getting out of trouble and getting in trouble. So, no, we're not doing the slides. Go to the video. I did the slides last time. Just wanted to thank everybody for being here. I have no conflict of interest video. We have very little time. So I have lots of visitors. What I'm saying is take the slides down and put the video up. Thank you. So I have lots, let it run, and I'm going to ask you to forward it. So I have lots of visitors, and the visitors always want to see me get in trouble. They don't say this, but the visitors want to see, look at the smile, and see, she loves it. They want to see me get in trouble. So you're going to see a surgeon here who's hubris, no humility, and in a rush. I had a meeting this day with the dean and with the board that I reported to. It was a case, a patient had immunochemotherapy, forwarded. And we do all of these from the back. So this should be a right upper lobe. Yeah, is this a right upper lobe? No, this is the second video. Okay, we'll show this. This is fine. This is the second video when I got called in the operating room to get control. Don't you have a different video? Go to the next video. Take this one down. I want to show the one where I put the hole. This is where I got called in the OR by my partner. I want to show my mistake. No. Hang on. Nope, not that's the sleeve. Go back. Go back so I can see the name of the videos. Yeah, nope. No, just put the videos up. These are sleeves. Go back to my first video for this session. Stay right there. Hang on. Yeah, no. Control. Go down. Slow down. They're all Spain, my friend. That's where I am. All these are for Spain. Okay, just show this one. This is fine. Okay, different video. I wanted to show a different video where we put a hole in the right upper lobe, but this is where my partner put, let this play. This is where I got called into the operating room, play it. And my partner got in trouble. This is not me. Play. So I think your initial response when you get into trouble has to be pressure, and poise. When you put a hole in an artery, you are a wounded athlete. And we don't type and we don't screen. So our patients are not type and crossed, they're not type and screened. And we have a rule that you then have to call the attending surgeon. Go ahead, proceed. Go forward with this. So this shows when you're stuck, back up, slow down, thank you. Go back a little bit, keep going back. When you get in trouble, leave it right there. Stop and play. When the artery is stuck to the bronchus like this, the main teaching point is to cut the bronchus. Cut the bronchus. Not enough people do this. Turn the oxygen down, go down to room air, and don't try to dissect the pulmonary artery off the bronchus. Just cut it. So I got called in at this case when they were getting into some bleeding. We packed it, and all we had to do here, and we're teaching a little bit, that's us trying to teach some of our surgeons how to cut the airway. Go a little bit forward. Keep going a little bit forward. Also run my clock so I know my time. They didn't start the clock. Keep going. So here's a giant tumor. Stop in the airway. Slow down. Now go ahead forward. Once you cut the bronchus, you then have beautiful control of the pulmonary artery. Okay? So that's trick number one that we wanted to show in this video. All right, let the video go forward a little bit. Now, when you get into trouble, you want to get proximal distal control. This is showing one of my partners getting control of the pulmonary artery, but this is not proximal control. So if you get into control here, it's much easier to open the pericardium to getting control. Yes, this allows you to get control from below the A2 and below the A4, the A5, but not above it. And again, remember what we said the other day. I've only got a few minutes, so I want to make a few points. One is cut the bronchus if you can't get the bronchus off the artery. Two is if you are having difficulty getting proximal control, open up the pericardium. On the left side, it's exceedingly easy. It's not an indication to open. You can do all this robotically, but you can open it up. On the right side, you get around the right upper lobe vein, pull it up, and get around the PA. Okay, let this go forward. Go to the next video now, if you would. There should be a video for this session that's talking about controlling pulmonary artery bleeding. Go ahead. Next video. This is a sleeve that we ended up having to do. But that is how we stayed out of trouble. Wait there. No, nope. No, this is the sleeve. You guys have the wrong session. This is the next talk for the. Go to the very first one. Robert narrated that one. Okay, let this run a little bit. Go forward, please. We're just taking the ligament down. Continue going forward. Again, take all your nodes out first. I think if you take your nodes out first, it allows you to identify all the anatomy. Keep going forward a little bit. Hold it right here. Continue. Yep, let it play. Let it play. So again, if you're having difficulties and the fissure is difficult, get the fissure out of your way. Allow yourself to get structures you can take out of your way. If you're into bleeding, you just pack it and work somewhere else. Almost all of these can be controlled with packing and getting proximal control. Go forward a little bit more now, please. If lymph nodes are stuck to arteries or arteries are stuck to bronchus, just cut the bronchus. Let it go forward. Open up your entry and exit sites. All these people have had radiation, chemo, or immunotherapy. Continue going forward. Stop. So if you have a little problem with a little bleeding, not an indication to open. Again, all this can be controlled and can be sewn intracorporeally. We use 5-O-proline. They can go smaller than that. You break the knot. You can work on your airway second if you get things out of the way. If you have tumor in the airway, make your bronchotomy distal. It's another teaching point. Then you can look inside so you can take out as little airway as possible. Let this video go a little bit forward. On the left side, I want to stop it right here. Here's another important teaching point. Stop for a second. Stop the video for a second. So when you're doing a left upper lobe in a difficult case, that A1, A3 complex is the most common artery that gets injured. It gets injured because the plane between that bronchus and the artery is destroyed. What are we doing here? We're cutting the bronchus. That allows us now to get very easy control of that arterial branch. Let it run. This is a patient that may play it. This is a patient that might require a sleeve, but you're allowing yourself to get control of the A1A3 without getting into trouble. If you get into trouble, you can pack it and do it, but it's much better to stay out of trouble. Okay, let it play a little bit. We're staying distal all the way where the tumor is. This is a giant mass that's had chemo and immuno. Keep going. There's a large bronchial artery back here. When you get into this, don't get worried. There's a big bronchial artery runs behind where the 4L lymph node is. You know that that's coming. Now you can control the A1, A3 complex. Why? And the doctor who called me know where I put a little hole in this because they were trying to get it off the bronchus. If you cut the bronchus and get the bronchus out of the way, even if you cut through tumor, now you control the A1, A3, and then you can go ahead and control the bronchus. Okay, I think we'll stop there. We'll show the sleeves later. All right, thank you.
You talk again about ECMO.
Okay, let's hope we can load. The next one's ECMO. So the video says tracheal resection on ECMO. Should be easy to find. Can you load that video, please? So about 5 or 6 years ago, we started, 7 years ago, we started doing our tracheal resections. It should just be loaded in the session in order. It should be the very next video for me. We said, why are we doing tracheal resections open? And why are we, the hardest part is to ventilate the patient. You got it? Good. Play it. So it made sense to me, let's just get the endotracheal tube out of the way. So we've done 5 of them now. Actually, we've done 6. This is one that I believe is in the mid-trachea, because it's very easy when it's in the distal trachea. So the patient initially gets established on ECMO. The key is to mobilize the airway. Now, we talked about this before in our airway talk. In order to do that, notice I'm working in the back to start. All the videos you saw, all the segments were done from the front. As a robotic surgeon, we do them all from the back. So you have to change your mind perspective of the operative field. The most important thing with airway surgery is releasing the tension and removing all of the subcarinal lymph node, the entire lymph node removed. Let this play a little bit, but I want to show you one of the most important things is freeing up the carina when you're doing tracheal work. Okay, let it run, because now I want to show the 2s and 4s. Forward a little bit. So we do a very aggressive 2s and 4s, as I mentioned before. Yeah, let it run a little bit. Great. This is how you mobilize the trachea. In the old days, we used to do, Lori, remember, we used to do mediastinoscopy first. We don't have to make incisions on people's necks anymore because we're able with the robot to free the entire trachea all the way up above the innominate artery. So to me, sewing the 2 pieces together, that's the easiest part. It's making sure there's no tension and driving your scope way above the innominate artery. Notice our videos are not sped up. This is the speed that we operate on. This is our operative speed. And we free this way above the innominate artery. So we're taking out 4 or 5 centimeters of trachea. We're able to bring the 2 ends together. Okay, speed it up a little bit. Now you have to hold it there for a second. So now you have to freeze it for a minute. Freeze the video, stop it. So now you have to identify where you're going to do your bronchotomy. So there's 3 ways to do it. This video shows all of them. You can put a bronchoscope down. If you have a robot, you turn ICG on. You're not giving ICG. You're just putting on Firefly. Because with the bronchoscope, you see it. And you can import on the bottom screen, as you can see here, the vision the bronchoscope sees. But if you don't have that, you can do what we did in 1995 when I was a resident at Mayo Clinic and stick a needle in the airway, which we're also doing here, and watch the bronchoscope go in. And I think you should do your distal bronchotomy first, although sometimes you don't. Okay, let it play. And then I put a little suture there because I know that's exactly where I want to go. I want to take out as little airway as possible. Here's my proximal, here's my distal bronchotomy, etc. And this one is at 4 or 5 centimeters from the vocal cord, so this is very, very high. All right, let the video play a little bit. Fast forward it. Keep going right there, stop. So then you start cutting the airway. Now, because we're on ECMO, you don't have to turn the airway, you don't have to turn the oxygen down. We do not heparinize. There's no heparinization in the circuit. There's no systemic heparinization. No heparin is needed. That's why things aren't bleeding that bad. We cut this carefully. This is actually a 3rd-year resident doing the cutting here. You can see she's going a little bit extra carefully. That's fine. But we then make sure we're away from the esophagus. We check the margins. Okay, let it go forward. We send those margins in. When you're doing a high tracheal resection, I put a silk on it so it doesn't slip up into the neck so you can pull it down. That is not needed on a distal tracheal resection. Go ahead, let it run forward a little bit. Keep going, stop. Now, the key to the operation is mobilization. This is the single most important part of it. So we now then go to a bipolar, and we're only going to mobilize the part of the airway that we need to try to get the two ends together without tension. People will say the disadvantage with the robot is there's no tactile feel. So what? I'm operating open, and I often say to my assistant, hey, you're pulling too hard. How do I know they're pulling too hard when I'm an open surgeon watching? Because I can see the tension. Same thing robotically. So you use visual cues to assess tension, not a feel to assess tension. Here we are doing a distal resection of a primary tracheal tumor. Let it run a little bit. Again, we mark this. We make sure we get negative margins. We send our margins in. We send in 4 margins proximal, 4 margins distal, so we do 8 frozens. We do not wait. Let it run, and stop it for a second. So we send in the margins, and we start sewing. We don't wait for the pathologist to come back. There was a little bit ooze here, so we put a little bit of the Surgicel powder. Now, we use a running 3/0 Stratific suture. This came up before. This is actually a 6-inch or like a 12 to 14 centimeter, so you don't need an assistant to follow you. This kept coming up in the last session. Oh, you need a hook, it gets tangled. It doesn't get tangled. You don't need a hook, and you don't need an assistant. You do it yourself, and you're assessing tension there. Now, there's a few surgeons who I proctor who say they want to scrub in and feel the two ends come together. This, to me, is silly, but if this is how you want to do it, it's okay. To me, you have the visual cues, and if you freed up the distal trachea and the carina, and when you're doing a right upper lobe sleeve, which we'll show later in the sleeve talk, you free up where the middle lobe comes off the lower lobe between the B6 and the B5. If you mobilize the airway distally and proximally, the two ends will come together, and you can take out up to 5 centimeters of tracheal resection. 1 minute left, thank you. Okay, let it run a little bit. And then you just run this. Now, I use 2 sutures. And again, as I said before, slow it down for a second. This is the easiest thing in the world because we're doing it from the back. And as I said earlier, if you do your right upper lobe sleeves in the back or the trachea from the back, it couldn't get any easier. And slow it down, and you can allow the medical student can put a few sutures in here. Honestly, they can. We've had medical students sew this once you line it up because it's incredibly easy if they've been on the simulator. So this just shows, slow it down for a second, how easy this is to do. These patients then stop the video. So these patients they do not have a chin suture. We don't use a guardian suture. They don't go to the ICU. They go to the floor and they go home in 23 hours like every other patient. No ICU, 1 day length of stay. And I will say, I put this in for Lori. I want to show this. I want you to see. I still make a knot here. I know I don't need to, but I still am a surgeon who likes to see a knot. You know, these barbed sutures, you don't need to tie, but I thought you would like this. So, because this just shows that we still have some dogma and still some crazy things that we do, because you don't need to tie this at all. You can just pull these 2 barbed sutures together. It just makes me feel better if I put a little suture in there, especially since I'm not putting their chin to the chest. So I think if you have a program that has an expertise in ECMO, it's very easy and safe. There is risk, but it's pretty easy and safe to do this. And if you have an expertise in trachea, almost all your tracheal resections can be done this way. They're incredibly simple, and they're outpatient procedures, essentially. All right, thank you.
Our next speaker is Bob Dalla from Marseille, France. We'll talk about robotic segmentectomies. Floor is yours.
Thank you for introduction. Thank you one more time for the invitation of this amazing meeting. Ramon, Lorano, thanks you a lot. I'm going to talk about segmentectomy one more time with another approach. Here is my disclosure. And about segmentectomy, there is different kind of difficulty you will face during this challenging procedure. The first one is a selection, and it's our job as a surgeon to select patient. And just keep in mind, If you can perform a lobectomy, is intentional. If you can't, is compromised. And for the rest of my talk, I will explain only for intentional segmentectomy. So we will have more and more data in the literature. For all of the rest, I think GPS, you know now, as I like it a lot. I think it's a great help. And the robotic platform is always a very good tool for segmental pain and lymph node dissection. So intentional segmentectomy, you have an obligation of result. Keep that in mind. So anytime you can convert to a lobectomy. And you remember, I'm sure, that for the last decade, we heard conversion is not a failure. Conversion is not, lobectomy is not a failure. So who we propose segmentectomy right now. So we have enough data, and we talk about for the previous session about these two beautiful randomized control. And I would love to have some details. Maybe we should avoid some lesion too close to visceral pleura, because we still have many questions. And we see, even yesterday, we still don't know if segment is better or not. But in Marseille, we did some interesting work about the lymphatic drainage, the sub-lymphatic drainage. And if the lesion is too close, you have a high rate of risk of local recurrence. So when we don't know, any doubt should benefit to our patient in case of intentional segmentectomy, always. Maybe we should do more than intentional segmentectomy for more than 2 centimeters. For pure DGO, yes, Japanese colleagues show good results up to 3. And for nodule solid nodule, sorry, we are waiting for this randomized control, the setup trial. So how I do it, I use always these two tools. The robotic is not true because I do a lot of VATS also, but I'm not able to do a segmentectomy without 3D planning, period. Because we need to control one important prognostic factor is the margin and at least 2 centimeters of lateral margin. I don't know to calculate 2 centimeters in the OR, so I prefer to pre-assess that. You know this slide, I already showed you 2 days ago, but here is a lesion inside S10. It's well inside S10, so it's okay. But when you add 2 centimeters of lateral margin, it's crossing the intersegmental plane, so you need to add your, the extent of your resection. Same, you already see this video, but you see it seems to be obvious, the delimitation with inflation-deflation test. And when you add ICG, it's less obvious. It's more medial, so you will face maybe some hair leakage. I don't talk about oncological, I just talk about early outcome, because if you step on the devascularized tissue, I'm not sure about the healing in the early outcome. I think the one big advantage of the robotic platform is that you have optimal vision. And you can arrive with a stepper from the front, from the back, and you never grasp the remaining segment. So you don't injure the remaining segment, no air leakage, and you can leave the patient leave the hospital very early. And more, you will have all the bronchovascular element, as my previous speaker said, on the specimen. It's very important. What about the lymph node? One good supplemental analysis of the GCOG about the lymph node invasion in case of solid nodule. And so keep in mind that for GGO, it's okay, the lymph node, we don't know. But for solid nodule, we need to check the lymph node. And I do always the radical lymph node at the beginning because you're fresh, because you will dissect the bronchovascular element easily. And I also like the idea of the adjacent lymph node from our Japanese colleague. What is it? You have a lesion inside S2 segment, and you have station 12 very close to the lesion. This is the adjacent lymph node. If this one is positive, there is 40% of risk that the other station inside the remaining segment are also positive. Maybe it's another reason why we have such a high rate of local recurrence in case of segmentectomy. We don't know, and doubt should benefit to the patient. So right now, I do frozen section of this lymph node. Maybe in the future we will stop, and we will do, who cares, it's enough with systemic treatment. But right now, we don't know. But what we know is that robotic platform is good for this very distal lymph node. They are quite challenging. I do RATs and VATs, and to be honest, for the N1 lymph node, I really prefer the robotic platform because you work with your two hands and you can grasp easily the lymph node without breaking it. It's an example of a typical segmentectomy. We see a lot of beautiful video from my colleague, and it's very frequent to perform 7, 8, or 9 and 10, but 8 and 9, it's less common. And if I give you a message, who cares about the number of the segment? You just remove anatomical part of the lung. So here you will find a lesion inside the right lower lobe. Here, it's probably a carcinoid lesion, very well delimited. And you have 6, 7, 8, and 9, and 10. So here it's between 8 and 9. At the perfect limit of the both segments, and we plan to remove segment 8 and 9 together, and you see we will have the 100% good lateral margin because we already pre-assess thanks to this 3D planning. So we are very nice fissure, we remove the lymph node, and we will just follow the GPS. So on the 3D planning, there is 2 arteries, 2 bronchi, and 1 vein. Okay, let's take the first one. We are taking A8. So I'm not an expert about the number of the artery of the bronchi. I just cut the blue, the red, and the gray, okay? Make it simple. After the secret is to grasp the previous element. And Sergio told you, you just grasp and pull the previous element you take. Like this, you will have a perfect vision on the next element. So we retract the A9 thanks to the vessel loop, and we have now a better vision on the B8. Here is B8, so we took A8, now it's B8. Thanks to the new robotic stapler, 8 millimeter, it's going to be much more easier in the future because this one is a little bit big. And now, remember, I pull the previous element, so B8 stump, and I grasp it to have a better vision on the next element. The next one is A9. So we need to have the bifurcation between 9 and 10. Here is, you see it's a deep dissection. So we'll at that time use, if I write Hemlock, because it was too big for the 12 robotic stapler. Yes. We did it. So if you use Hemlock, use several Hemlock, not only one, because it can move with a sponge. So we take A9. Can we move forward a little bit? Because I can't from here, and I don't want to run out of time. After it's B9, so A8, A9, sorry, A8, B8, A9, B9. Can you move a little bit forward, please? And you can see already the vein coming. And as Sergio said, it's just behind the bronchus, always here. It's better to take the vein distally, not in the hilum, to be sure you will not injure the remaining segment. So it's impossible to move forward, please. So here's the vein. Can you move a little bit forward? No? You can't? Okay, it doesn't matter. Give me 1 more minute, it's okay? You're nice. So here is the vein. And how I know it's a good one? Because it's 3D planning. I don't even know the name of this vein. So ICG, so you have segment 7, very well flashy, segment 8 and 9, dark. And I put some mark. And I will put some mark in general on the green. Like this, I'm sure I will put my stapler on a very well vascularized tissue and to ensure the good lateral margin. For the next part of the surgery, it's important to keep in mind that it's a cone-shaped resection. And you follow the shape of the 3D planning. You can use some tool when you ask your assistant to clamp the parenchyma to make it thinner, and keep all the bronchovascular stump through the specimen. If you don't do that, it's a wedgectomy. Okay. At the end, I re-inject ICG to be sure I have a good vascularization of the remaining segment. I use some pleural sealant, blah, blah, blah. So intentional segmentectomy, it's a surgery with obligation of results, only if all the criteria are ensured. Good segmentectomy is just anatomy with sufficient margin. And for me, they are all challenging, and you need good exposure. That's why I like the robot, and innovation. Act like a primitive and playing like a strategist. It's a French poet. I keep that in mind also during my surgery. Thank you very much.
Great job. And don't worry, you're not going too fast. We only have 10 minutes, so great job. Excellent. All right, our next speaker is Sohail Boubia, who's going to be talking about
pleural decortication.
Looking forward to hearing how you do it. Thank you.
Hello, everybody. Thank you again for the organizer for the invitation. Thank you to Ramon and to Molins to invite me in this very famous meeting. It will be very difficult to present something after this all presenter who have one of the best video in our field in the world. But I will try with this little contribution of decortication for amphiema. We are a country where we have tuberculosis endemic, and you have a lot of patients for amphiema. It's a 35-year-old patient treated for pleural tuberculosis. I had repeated pleural puncture by the pneumologist, and you see her in the chest X-ray, this pleural pocket, and we did one CT scan when you see this collection, basal collection, and we will try to do decortication by VATS. You can run the video, please. We do it by uniportal VATS. We enter in the infected pleural cavity. We go directly in the infector. It was in the 5th intercostal rib, and you will do a debridement when you say all this to the pathologist and to the bacteriology. And you have here the thick cortex sheeting for the lung, which is formed by fibroblasts with the infection, with repeat infection. And you try to have one plan. It's not easy at the beginning. We are more here in the posterior, and we try it here, and you see a good plan between the lung and the ribs and the pleural, the parietal pleura, and we follow this plan until we have tension, and we come back. We go down or up where we can, and for us we work a lot with the hook, because before we don't have the energy. Now we have, but we have the habit to work with the hook. It's more easy for us, and with the hook you can do elective coagulation like this. It's more easy. And before, when we did it with thoracotomy, we put the hand, we pull, and we wait. We have a lot of red blood who is coming. We put a lot of gases, and we wait. But the elective coagulation, like we had in VATS, I think we prefer this. We begin always with VATS. If you have a big problem, or before having big problem, we convert. But I think the adhesiolysis is better by VATS than thoracotomy. We don't have at now the robot. We will have it. It will be, I think, more easy. And you see here, you have one plan, in extrapleural plan, and we open a little the pleural viscera, and we will have one good plan between the lung and the visceral pleura. We will sew it, and here when you have tension, we open always, and we can change the field. We can go anteriorly or posteriorly, and you have heard a good plan that we can work, and we have less tension. It's question of tension and of adherence. We must go slowly, do good hemostasis, and follow the plan always. You see, here we go more up, And we go little up, little down, little up, little down, and little anterior and little posterior. It depends on the tension. And you have a very good vision. I compare always with thoracotomy. We did a lot before with thoracotomy. We didn't convert now a lot from VATS to thoracotomy. I think it's good things to do it by VATS when we can do it good, and when we can do all the procedure with VATS. Often, if we can do only adhesiolis, it's very good. And you see, we have always, we follow the lung. This is good lung for good quality. When you have lung who is ill, it's more difficult. And here we are in the posterior. We have better lung here. And when you have a better lung, we have better plan, like you see. We can ask the anesthesiologist to do ventilation. Like this, we have a better plan. But I think here we don't need it. And after, when we are here very down, we go to diaphragm, because the diaphragm and anterior part is more easy to have a plan because it's moved with the breath. You will see here the diaphragm, and we have this plan for between the lung and the diaphragm, and you see it's better and more easy than posterior, and we can dissect very good, and we can liberate all this costophrenic angle. It's very important in the post-operative recourse to liberate this, because we have to inflate all the lung. The goal is to inflate all the lung. And you see, after tuberculosis, you have always this kind of pleura. And here we are in the anterior part, and we will liberate all the lung from anterior part. The costomyciacina recess, we must be free. And when it's liberated, we have less tension on the apex. And you see these nodules in the visceral pleura, which is very white, is very pathognomonic for tuberculosis. In the majority of patients have this pleural, have this little granulation. And here we dissect all this anterior part. It's more easy than posterior. We see the phrenic nerve. And we go more up, from down to up, because the cavity, and you see here the vena cava superior with the phrenic, with the good view, and we come back where we have tension to the tens, and we use a lot. Another instrument, you will see it, is the INSEAL, because it's articulate. And in this kind of surgery, it's helped us a lot. And here in the apex, it's less thick because the pocket was down, and we will liberate all the apex, like this. The inflation after will be good, and the post-operative course. This is the instrument that I said. It's INSEAL, and we liberate all the apex. And after, we begin to the pelling. The pelling is to keep out these parts of lung who is engaged by this visceral pleura with fibroblast. And here we ask always the anesthesiologist to do ventilation like this. They help us to have the good plane. The goal is that you liberate this, but you don't have to do a lot of lesion in the lung. Or in postoperative recourse, you will have a lot of airlay. It's not a cancer. We don't have to take out all the pleura here. You get out what is easy. If you let some pleura, it's not a problem. The goal is the re-ventilation of this part of the lung who was encapsulated, trapped by this visceral pleura. And you see here you have a good plan, and with the ventilation it's good. And we try to have now the border of the limit of this part of the pleura, which is very thick. You see here we are near, we go little up in the middle lobe, and we will see the fissura after. And this is the instrument that we use. And we will see that we can't now have the border between the part which is ill and the part which is normal between brackets. And you always ventilation and take care that we don't have a lot of hole. You see here the border. you will see it's here between you see the upper lobe and the middle. We are in the fissura, and we will try to extract all this. And I think with the video we see better than in thoracotomy. You see here, and you have a good plan to do this decortication. Here is we will try to keep all this out, and we reinflate now the lung, and we will see that you have a good ventilation, some air leaks in the fissura, and this is postoperative recourse on the left, and 1 day after, and this 1 week after, and thank you.
Thank you very much. The next speaker is Miguel Congregado from Sevilla, Spain, who will be talking about first rib resection by VATS. Please, Miguel.
Okay, first of all, I want to thank the organization to give me the pleasure and the opportunity to be in this so nice session. Okay, I will talk about the first rib resection by VATS. I think it's the first time I talk about this, but can we play the video? Okay. I will focus on the technique, on my technique, what I have learned about all my failures and what is all the changes I have performed during these years. But just a quick reminder. Do you know that the problem is the compression of the vascular subclavian and the plexus, the brachial plexus under the clavicula and over the first cartilagus? It's very important to remember the scalene triangle and the costoclavicular ligament. This is the position we use. We use just a 3 or 4 centimeters or more incision, and we tie out the rib from that. It's not so important to take all the rib in one only piece. I will first tell you how to do it in the right side. I don't know why, but left side is a little more difficult for me. First is to look for the landmarks. I look for the internal mammalian vein, the artery and the vein. Then you will see the artery just in the ventral side. And then follow back the sympathetic chain, because you have to take care about the ganglion striate if you don't want to have a Horner syndrome. Okay, so let's start. Once you have identified the landmarks, I think the first thing is to have a good exposure of the inner face of the first rib. It's a very short one. I used to do it with electrocautery. You can use the hook or the scissors. Be sure you have a good exposure of all the inner side of the artery of the first rib. Then you look, or you have to perform the dissection of, I call the down edge of the rib. This is what we are doing now with the SEM runge or with any instrument you prefer, but you have to begin to pull down softly the artery, so then you will have a view of the artery, of the vein and the vein over the first rib. You make the dissection. It's very easy. You just only be close to the rib and follow the dissection from the front to the back. I really prefer to go from the front to the back because I think it's easier. Once you have dissected all the outer side of the face, I began to cut the rib. I think the best place is in the cartilage. If you do it in the cartilage, it's not so hard like the rib, like the bone, and then you don't leave a long fragment of rib, but it can be difficult. This is for me, one of the key points, to cut the costoclavicular ligament, because it's so strong and it's very, very close to the subclavian vein. Once you have cut it, you will have a perfect view of the anterior scalene vein. You have to cut it very close to the rib. Again, why? Because you have there the phrenic nerve. But the view is so nice. If you pull, you don't need to pull so hard. Just pulling down, you will see the anterior scalene vein, and then just follow the dissection. It's an easy technique, and then you cut it, the medial scalene vein, so you just, the posterior scalene vein, scalene muscle is really a very, very small muscle, so it doesn't take care. And then continues going in the very deep side. This is point, at the beginning, I try always to disarticulate the rib from the vertebra. I think it's not needed. You can cut here the rib, and then take out the piece, the little piece of the rib. Here, I did the extirpation of all the rib, but I say to you, please don't try so hard, because you can make an injury to the nerve. If it's easy, we can take it all the ribs in one piece, but don't take care about doing it in 2 or 3 pieces. And then you check the artery, the plexus, and the vein. In the left side, it's a little quite difficult for me. I don't know why, because it's similar. Just to check, you have to check the landmarks, the sympathetic chain, the internal mammary vein and artery, and then just go in the same steps. First, show the inner face of the rib. You have to take care. Okay, here is the ganglion, the stellate ganglion. So with good exposition of the face of the artery, of the rib, then you will have too many arteries with these colleagues. So you just have to explore, and with hemostasia. Okay, we have here the rib. This man was a packet writer, thrombosis of the vein. So we have a lot of collateral veins. So you have to take care about this small bleeding. But the bleeding is not so important, but it's so disgusting because you don't have a good view. So you make the dissection, taking care of this bleeding. Do you remember that ligament, the costoclavicular ligament? This was the cause. It was the guilty of this TOS, of this thoracic outlet syndrome. So it was very hard and fibrotic. And in this case, you have to be sure you are cutting all this ligament. And it's really hard. I prefer to cut it after freeing the first rib. Where? In the cartilage. If you cut the cartilage, it's very easy. This is the ligament. Can you see? It's very fibrotic, and it's very close to the subclavian vein. So I want to see the subclavian vein to be sure I have a good plane to dissect. This is the subclavian vein. So now I can cut the ligament. I use here the harmonic scalpel because with the electric coagulation can be difficult or can be dangerous to the vein. And sometimes I use just sharp dissection. But once you have freed this ligament, then you have a nice view of the anterior scalene muscle. Remember, cut it always near the rib to take care about the phrenic nerve. And after that, the rib will move very, very easily. Please go back, go really back, because some people leave a long fragment of the rib, and then will be a problem in the brachial plexus. You say, no, okay, it's only vein, I just free the anterior side of the rib. Now go back, because you have to be sure that the thoracic outlet will be without any injury or any element that can be dangerous for the plexus, for the brachial plexus. In this case, I take the rib in 2 or 3 paces, I don't remember. I just check that is there any sharp piece of bone that it can make any problem in the postoperative period. Okay, it's okay. And then, like, if it's a panchet striator, the problem is the vein. In these cases, I prefer to free and to make the dissection of all this tissue around the vein. It's very easy now. And you are very close. It's very close from your incision. You just make the dissection, take out all this tissue. If not, you will have a scar, and the scar will trap will take the vein. If you see, after cutting all this tissue, you will see the clavicle, the bone. Now I'm sure that the vein will have a good flow. And it's not very difficult. I know it's the vein, to club a vein, it's the scar if we have a bleeding. If a bleeding is about this far, so you can just push it. But a paramount item here is the indication. Please, always have a good indication. This is data from a published paper about prospective quality of life after first RIP, and we have performed a heart-related quality of life test with 36 questions. This is our population. I think it's normal population, 38 years old, more females as usual. But I think this is very, very, very important information. 64% says they are better. So, okay, I do good. But 28 say they are worse after the intervention. What's the problem? We have a lot of data. Complications, okay, I expect that. People who had complication, bleeding, it's okay. I suppose they are worse or not better. But the problem is that the neurogenic dose. This is one of the data, the variables that had a very significant difference with the vascular against neurogenic. So please, vascular is sure, do it for sure, but when you do neurogenic, remember this classification of Wilburn, arterial, vascular, neurogenic with good diagnosis is okay, but there is an amount of patients that is called the disputed thoracic outflow syndromes. It's about 8% of thoracic outflow syndromes that I think we better don't go with them for RIP extraction. Okay, thank you very much.
All right, thank you. I'm glad you showed the venolysis there in that second, because that's a critical part of the operation that the thoracic surgeons are not doing. You can't just take the rib out. You got to do a veno or neurolysis, et cetera. All right, our last speaker is Matthew Bott, talking about VATS resection after neoadjuvant immuno. Matthew, take it away.
Okay, thank you very much. Thanks again to the organizers. Appreciate the opportunity to present to you guys. I think you've seen some wonderful, intricate videos today, so hopefully you find something of what I'm going to show you useful. Can you go ahead and start the video, please? So this is sort of my straightforward approach to a post-induction right upper lobectomy. Patient was 56 years old. She was a former smoker. She had T3, pretty sizable tumor, maybe some PET avid lymph nodes in the hilum. So she was staged outside with an EBUS. Mediastinal nodes were negative, but between the size of the tumor and the hilar involvement. She got 3 cycles of chemoimmunotherapy. She was supposed to get 4. She had a lot of side effects from the chemo-IO, so we went to surgery after those first 3 cycles. You can see from the imaging it went a little bit fast, but she had a pretty nice response, but still had a pretty sizable, at least tumor bed within the lung. You'll see the pathologic response later. But I do this essentially with a sort of a standard 3-port technique, I think, for a post-induction case. And again, I'm operating and teaching residents, so I feel more comfortable with that approach. But speaking about the sort of front, back, anterior, posterior debate, with the multi-port approach, I can sort of do both, right? I start the case from the posterior approach, always do everything really the same way. You saw me take that level 9 lymph node earlier. Here, I'm using 2 instruments through the posterior port, and my resident is assisting from the utility port. I think we do a pretty nice clean out of the subcarinal space. I always try and open this space along the bronchus intermedius, between the bronchus intermedius and the upper lobe bronchus. Usually there's a level 11 node in there that I try and take out. In this case, the node was sort of buried a little bit deeper, and I actually ended up taking it from the front. But at least opening that space allows me to come through a little bit later on, as you'll see, easier. So now, trying to be efficient, I'm done with my posterior portion, turn my attention to the anterior hilum, mobilizing the vein there. You could see some lymph nodes now along that probably A2, A3 branch of the PA here. bigger node sort of stuck to the anterior surface of that right upper lobe bronchus. I think this is what made the case a little more challenging. You can see I have most of that PA branch I was working on before sort of skeletonized. I hear a lot of talk about VATS being one-handed surgery. You can see that we're almost doing everything here two-handed, right, with a grasper in one hand, and I use a lot of monopolar diathermy. I use the ligature, I would say, occasionally, but I tend to be able to do most of the case just with this approach. These are lymph nodes now on the undersurface of the superior vein. We're sort of taking off of the PA behind it. Again, I think lymphadenectomy for these post-induction cases is so important. Coming around the superior vein, I like that sort of Endo-Kittner maneuver to sort of slide the vein over the instrument, dividing that with the stapler. You can see we preserve the mid-lobe vein below us. Okay, now I'm exposing those PA branches from the anterior approach. That's a big middle lobe branch, I think, there, and then you'll see as we sort of come up, now you start to see the upper lobe branches a little bit more clearly. I had done most of that dissection already before. I sort of like this from the posterior incision just to make sure the angle with my stapler is okay. I tend to staple mostly from the posterior side, dividing that PA branch and then exposing now probably the A2 going back. I didn't do a 3D reconstruction on this case because I was prepared for a lobe anyway, but you can see that branch sort of coursing up into the posterior segment there. I tackle that a little bit later. Now I'm sort of connecting my anterior dissection along that PA branch with the posterior dissection that I started in the back. I'm sort of prepping for taking the bronchus later. I don't do it right now. I still have this lymph node sort of plastered along the anterior surface. So I mobilized that a little bit and then turned my attention to the level 10 nodes going up underneath the azygos here again in a locally advanced case. I think the lymph node dissection is so important. I tend to do it in the beginning, as Dr. Ramaporta made the comment about earlier, while we're fresh and sort of ready to go. I'm taking probably that A1 branch of the artery here. Okay, now I have my nodes. My original intent was to actually remove these separately, but they were sort of scarred into the specimen, so I really just used the cautery to mobilize it off the bronchus pretty cleanly and sufficiently, and then end up taking it with the specimen in a little bit. I'm coming around that A2. Depends. In this case, for a right upper lobe, I didn't really dissect the fissure well, and I couldn't see the PA perfectly from the back, so it was just easier to take from the front. But I think on the point of being flexible, I've done it both ways in the past.
I almost always take it from the back after the bronchus.
Okay, now I have basically all that's left is my bronchus, and I had done a good bit of that dissection earlier. Again, sort of teeing up the staple fire with my clamp. Push the azygos down, come on top of it. I had clipped a bronchial artery in the front there, which makes my staple fire a little bit annoying, but I was prepared for it. We managed to get it up out of the staple closure. Sometimes I use vessel loops. I did here just because that undersurface of the bronchus seemed it had a little bit of residual tissue on it, so I just use this to open the space up a little bit more. Purple load on my stapler. Find that same plane. Still a little bit of junk. Maybe the stapler got hung up a little bit. Took us a couple seconds to get it around. There it goes. Take my vessel loop out, and then I really lift that node up just to make sure I don't staple the node into my bronchial closure, get the clip up out of there. You'll see the Vats DeBakey come in here in a second. Divide the bronchus, and then as I look in here, I see that 11 node now sort of plastered along the bronchus intermedius there, so I'm just lifting that out. Do my parenchymal separation, sort of checking on top, making sure I'm in the fissure, and then making sure I'm closely on top of the PA below me. There were some adhesions to the lung because of the induction treatment. I edited that part of the video out. I don't think you really need to watch me lyse adhesions, but bag it. I use a wound protector or a Lexus wound protector in that utility port just to keep it open and clean. That comes out of there, and now I go back to the 2 and the 4 space. I'd cleaned out under the azygos, I think, pretty well when I did the hilar dissection, so now I'm really working on those 4 nodes. Again, I think just a thorough lymph node dissection in a locally advanced case is so important. People say it's easier to do with the robot. Maybe it is. I think you can do it well, VATS. It just takes maybe a little bit longer and is a little more painful, but it's just a matter of patience. Take those nodes out. I come back and grab a couple more of the 2s. Space, I think, looks pretty reasonable. I dunk a little Surgicel in there for good measure. Irrigate and clean everything up. And some intercostal blocks, 1/4% Marcaine. I do them from the inside. I know people write about doing them from the outside so that you don't puncture the pleura. Lady had a 99% treatment response. She did have residual disease, and there was evidence of treatment effect within the N1 lymph nodes, so probably a nodal downstaging as well. So that's it. Thank you very much.
So unfortunately, we only have 2 minutes for discussion unless we go a little bit longer. That'll be up to Lori to tell us. But burning questions in the last 2 minutes, yes.
Is to Dr. Abu Abdallah. I have 2 questions, actually, short questions. The first is when you decide to take the vein, I mean to dissect the vein, where do you decide just to take it with a fissure? Is there any indication for this, or it depends on the difficulty of the operation? The second question is you're using the hemoclip. The hemoclips. It's good, and I think it's sometimes better than the stapler because it can get you to angles that you cannot get with the staplers. But at the end of the surgery, when you do the parenchyma, it interferes with the stapler, in my operation at least. How you overcome this problem?
Thanks a lot. It's right. So for the first question, I do the vein. I take the vein in 99% of the surgery. Like when you remove a lobe, you do the vein, the bronchus, and the artery. Same, just a smaller resection. In case of really, I don't understand because fibrosis or lymph node, you're right, I prefer to take it through the parenchyma, but maybe 1 time per year. So 99% the vein.
And that's almost always in the lower lobes, correct?
Yes.
Because usually in the upper lobe, you'll take the vein. So I do think it depends on the segment. And his second question?
And so I do use also the MRC, and I like it. It's very safe, mostly because I double it. And you're right, when you arrive with your stapler for the parenchymal resection, it can be an issue. So that's why now with the small diameter, either with a robot or, because I do also VATS, I use a Signia 8mm, a very small one from Medtronic. Also, so it's, for segmentectomy, it's very useful, this small stapler. It's only two lines, but it's very efficient and it's enough.
Yeah. 2 robes.
Thank you.
Great question. Yeah, I think in the lower lobes, you need to be careful with the vein, and it's okay. It's still a segment if you take the artery and the bronchus. And if you don't take the vein, and you take it when you staple, it's okay. You don't want to mess the vein up. So if you're unsure, that's a good bailout, and it's still a segment. Other questions?
Well, I'm sure there are many questions, but well, I just wanted to ask, especially for all of you, but VATS segmentectomies, what's your opinion regarding energy bipolar in terms of instead of using these staplers or homologs that sometimes is very troubleshooting afterwards to dissect more structures and get started?
You mean for the
sublobar sections for sealing vessels, sublobar arteries, or?
Yeah, I think it depends on the diameter of the branch. So I prefer to put maybe a seal, can tie it proximally, and then I seal distally because it prevents bleeding and everything. See if the branch is so minimum, just go with the sealing and that's it. I don't like really homologs because you can mobilize it during the dissection and with the stapler also, and that's the issue.
I would say that I use a lot of homologs, and I have had no problem with the homologs. And I would say that for me, sometimes it's comfortable. Sometimes I use only in the proximal side, and the other side with the energy. But sometimes I prefer to put in both sides, not because a problem of bleeding, but you are still keeping the dissection in the distal specimen. So sometimes with the section, if you have just make coagulation of the vessel, sometimes you get a small bleeding, oozing, and it's uncomfortable for you, and I prefer to take... the thing is that you have to be careful when you put the envelope in the stapler, that the stamps are on the right side.
On the right side, that's what's coming out, especially the bronchus. And I would put a plug in for our segmentectomy course, which is in Paris. I don't know the month, it's in January, sometime in January?
It's January, 9 and 10.
January 9 and 10 in Paris. It's a great, because each one of these 10-minute talks are really 3-hour talks to get the segments right. So we invite you to come to Paris in January. Okay, Mr. Chairman, are we done?
No, well, I think that we are completely run out of time, so we close the session. Thank you very much for your attention.
Barcelona?
In Hospital Clinic with Dr. Molins. Yes, yes.
Very good. And you're a thoracic surgeon as
Yes.
well. How
yes.
long have you been in practice?
I did actually 5 years in Hospital Clinic, then I finished and I stayed there for 2 years. Then after I changed and I went to another hospital here in Barcelona also for 3 years, and then I came back.
Okay.
Yeah. So
and
now it's.
You've been here now for how long? With him?
With him, I would say like 10 years.
Oh, really?
Yeah, yeah, yeah.
Oh.
This is my actually this is my 10th year.
Really?
Yeah.
Oh, wow.
Yeah, yeah.
Wow, very good.
And you're in Europe, right?
The U.S., New York.
Yeah. And how is it there? It's good?
It's great.
Yeah.
Busy and stressful.
Yeah, I can imagine.
But
yeah.
It's good. A lot of good opportunities.
Yeah.
So get to come places like this and do fun things.
Yes. And are you going to stay up for the weekend, or are you leaving?
No, I have to leave tomorrow morning.
Are you leave tomorrow?
Are you going to the dinner tonight?
No, because yeah.
Very timely. Okay.
Okay. Okay. Should I wait the photo there, or?
Yeah, probably. Although she might be mad at you.
But the mic
It's
is
very
on.
bright up here.
Yeah.
Well, I don't think so yet. Otherwise, they would be hearing us. Okay, now I think you're pretty good. The mics are on.
Okay, good afternoon, everyone. It's a pleasure to welcome you to this session on lung transplantation and miscellaneous. I am Rudy Guzman, currently working at the Hospital Clinic, and my co-chair, Matthew Boat, working in New York City.
Great. Okay, so we're going to jump right into talks. Our first talk is by Ricardo Terra from Sao Paulo, Brazil, who's speaking about robotic thoracic surgery program in an emerging country.
So good afternoon, everyone. First, I'd like to thank the organizing committee for the opportunity to participate in such a prestigious meeting. And I'm going to talk about robotic thoracic surgery program in emerging country. And basically, I will be focusing on the challenges we have when we are implementing this technology in countries like Brazil. First, we have problems and we have challenges in how to access the platform. It's quite expensive, and basically private hospitals start buying it when the program starts in a country. Second, we have problems with accessing training and proctorship because we have to go abroad and we have to bring proctors from abroad, which is something that is expensive as well and also is a challenge for those who are starting their programs. Third, winning the learning curve can be quite challenging because in these private hospitals, usually the volume of patients is low and patients have to pay out of the pocket for the robotic procedures. And so it's very difficult for surgeons to really have the patients to win their learning curve. And finally, even when they do that in public hospitals, it's very difficult to keep the program alive because usually the government gives a budget and then the budget ends and then you don't have money to buy supplies and keep the program alive. And finally, we have to prepare to increase in complexity and then we have to add new technologies. This is an example of what happened in Brazil, even though we had the first thoracic robotic procedure in 2010. Until 2015, less than 50 cases were done a year. And the reason for that is because most of the cases, the platforms, actually a few of the platforms, were in private hospitals, and so it was very difficult to have patients. Then some public hospitals had the platform, and some networks of hospitals, and so it was possible to have more patients eligible and with money to really participate in these robotic programs. But the big break was when we had education in Brazil, and then the numbers increased a lot because we had the opportunity to train our own surgeons and to proctor, and the proctors were Brazilians, and it was easy to have this around. I've been in many of these countries, like Mexico, Ecuador, Peru, Argentina, Chile, and I must say that in all these countries, I saw exactly the same picture. So programs starting in private hospitals, difficulty to begin the program because they couldn't really win the learning curve, and I think that it's very similar in all these countries, at least in the countries I participate in the beginning of the programs. In Brazil, after starting these programs in private hospitals, we had this opportunity in the private sector, in the public sector. Our Ministry of Health decided that it would be interesting to have a clinical trial, a small clinical trial just to get an idea on how the outcomes of robotic surgery would be, and also to have an understanding of the costs. And then we started this in the Cancer Institute in São Paulo. And we had to go abroad to have the certification, case observation. And the first cases we had, they were actually proctored by a general surgeon. Even though he knew everything about robotic surgery, it was very difficult for him to understand where the pulmonary artery was and what we should actually do during the procedure. We finished the trial, and when we finished the trial, we showed that the costs weren't that different, but then we finished the trial and the money also was gone, because then we didn't have money to continue the program because of the supplies. The supplies were for this specific project, and so that was one of the difficulties we had. But in the private sector, this first cases allowed us to really be to really win the learning curve, and so you were able to push the program in private hospitals like in Albert Einstein, and then it was very interesting because after this first impulse, we were able to change the practice, and we started to have a bigger proportion of robotic cases, and now 95% of the cases we operate on are actually robotic, as you see here, and the numbers increase. This is my personal experience. Every year I have around 160 cases of robotic procedures. But another big break for my institution was initiating the learning process. So teaching is extremely important to really make the program bigger. So we partnered with Intuitive, and then we have this training center at Albert Einstein. We have 3 platforms dedicated to wet labs, and so we give Intuitive certification. And we also have this international program in which we train 24 Brazilian and 18 Latin Americans a year. We have now 120 alumni. And this is a 1-year course when we give online lectures, virtual simulation. This is our simulation park. We have around 10 Symbionics simulators. And also we have these opportunities to have dry lab and realistic simulation to practice crisis, and also, of course, case observation at our center. We also have this fellowship in robotic thoracic surgery. Our fellows are exposed to around 200 procedures each. We have 2 a year. And then we move to more complex procedures. And then I think this is another challenge, because we have to add other technologies like 3D reconstruction, fluorescence, and this was also something that we had to work on so that we could really move forward with the program. And complexity is also very difficult to acquire, because we need both experience, connections with other groups, and also technology. And so, for instance, when we did our first coronectomy, it was very difficult because we had to also use ECMO, as Dr. Cerfolio just presented. Our group has experience with ECMO, but that was actually, the first case was quite challenging. And also the possibility of having students and cases and expertise allowed us also to develop like arterioplasties and other surgeries that I personally wasn't doing VATS, even though we had a good experience with VATS, but I had no arterioplasty done VATS, neither a carinectomy VATS. So add all these technologies is very challenging, but it's of course possible. And I finish with my first slide. So every country, like emerging country that is starting its program, will face this 5 actually challenges: access to the platform, access to training and proctorship, winning the learning curve because the numbers are low, and keeping the program alive when they finally have this in the public sector. And of course, preparing for increasing complexity is a challenge, but it's when we really have the advantage, in my opinion, of the robotic procedures, is when you are really doing complex stuff, because then it's when I see the big advantages of such a technology. Thank you.
Thank you. Next, we have Íñigo Rollo, who will present what does clinical management contribute to daily life of thoracic surgery.
Good afternoon. First of all, I would like to thank to the organization for the kind invitation to talk about a topic that is not very usual in our conferences, that is about the clinical management and how can help us in our daily life as thoracic surgeons. Firstly, I will try to define what is clinical management. We have a lot of definitions, but we can use one of them in which the clinical management is the organization of human and technological resources in order to comprehensively improve the care provided to all patients treated at each health center. It includes all these activities that we can perform to try to improve the quality of care of our patients, considering the costs. There are some keystones in clinical management, but in my opinion, one of the most important is to have a very well-developed strategic plan to improve this quality of care and base it in three important aspects. The first one is to do the activities with the best clinical evidence. The second one is to have the indicators based in the smart definition for controlling our results, and to try to have some patient report outcome and patient report experience measures in our patients. This is an example of a strategic parameter that we can use. It includes the purpose, the strategy, and the execution. But in my view, the most important thing is to try to transfer it to our own reality. There are some aspects in clinical management that are important, for example, the technical quality and to do the activities with appropriateness, effectiveness, safety, and efficiency. It's important to know the customer satisfaction. It includes the external and the internal customers. The external, the citizens, should have a very good access to our health systems and to our departments, and it's important to know their satisfaction, and it's important to motivate to our professionals in their job. And the third aspect is to know the sustainability of our activities. It's important to know what are our economic results, and of course we can or we should know what is our productivity. Quality of care was defined by the World Health Organization in several dimensions. Quality of care should be effective, should be safe, and people-centered, and of course must be timely, equitable, integrated, and efficient. How can we get the best clinical evidence? We can use protocols. An example is the ERAS protocol. We can use clinical practice guidelines. Here in Spain, nowadays, we have the diagnosis and treatment thoracic trauma clinical practice guideline, and we can use care pathways. An example in our department, we have the pneumonectomy and the lobectomy care pathways. But it's important that all of these protocols and all of these clinical guidelines should be in relation with the core dimensions of healthcare quality. The more important are effectiveness, safety, and responsiveness. Another important aspect is to have indicators for controlling our data and base it in the smart definition. The indicators should be specific, measurable, attainable, relevant, and time-based. We can use business intelligence platforms for try to control our results. And nowadays, these business intelligence platforms are used in wide areas in healthcare, like in clinical trials, in clinical decision support, in personalized medicine, and of course in hospital management. This is an example of the use of the business intelligence platform in a balanced scorecard that is very useful in our institutions to know our indicators and to control our data. And lastly, it's important to know our outcomes, not only the objective outcomes. It's important to know the experience of the patients. It's important to know what is the quality of life, the functional capacity, the humanity, or the empathy that the patient perceives before and after our intervention. And this is an area that is not very developed in our specialty. After what I have mentioned, how clinical management can we help us in our daily job? Clinical management is a useful tool for ensure that our attitudes toward our patients are the most appropriate, based on the best scientific evidence and on the specific patient who is in front of us and who must be involved in clinical decisions that will affect him or her. And I would like to finish my presentation with this sentence of Edward Deming. He was one of the fathers of total quality, and he focused on the importance to have data for controlling the results, because without them, we are just only another person with an opinion. Thank you very much for your attention.
Okay, excellent, thank you. So the next talk will be Update in Exhaled Breath in Detection of Lung Cancer by Angela Garau.
Good afternoon. I would like to thank the organization for giving me the chance to share with you a possible future alternative for the diagnosis of lung cancer. We all know the great public health problem lung cancer represents, and there is no doubt that the basic and the main pillar of its diagnosis is CT, but this diagnosis strategy must be improved because due to the large number of benign lesions that are identified by radiology. And our proposal is to do so through a smell. And why smell? Because it's terrific specificity. Given the large number of potential interest molecules, olfactory systems present in nature are not based on the development of a specific sensor for each odor, for each molecule, but rather in the combination of a limited number of receptors that are not specific. In this way, it's not a single receptor that identifies a specific odor, but the collective response of many of them that provides a unique signature for each odor. This strategy, it's called combinatorial selectivity, and it's common in all animals, including human beings. This strategy is canine olfaction uses this strategy, and this is how they are used to identify variations in the volatile organic compounds pattern related to each disease, including, in our case, lung cancer. And we prove this in our previous studies, where we demonstrate that the exhaled gases of patients with lung cancer has a specific odor that can be detected by canine olfaction. And how we did it? Just by training a dog. This is a little video where we can see all the procedure. We train the dog by using positive reinforcement. It's running, the video. Okay, we ask the volunteers to blow inside this crystal tube, so we get samples with lung cancer and samples without lung cancer. By the general knowledge of dog behaviorists, they know that after 10 or 12 sessions, the dog is able to identify the odor that we want him to detect. So when the trainer said that the dog was prepared, we exposed the dog to 4 samples without lung cancer and 1 sample with lung cancer, and he has to identify which was the sample with lung cancer. Neither the dog or the trainer knows where was the sample, only the technician that takes care of the sample and move the samples is the one who knows where the sample is. So now we repeat. And after this proof of principle that lung cancer has a specific odor, the challenge now is to develop the proper technology to transfer this knowledge to clinical practice. So since 2018, we have working on this. We started by using mass spectrometry and gases chromatography, and because we wanted to detect volatile organic compounds, the separation of them must be done by gases chromatography. The problem was that the resolution capacity of mass spectrometry and gases chromatography is not developed enough to detect such a small amount of volatile organic compounds as present in Excel breath. So the only that we got was a specific chromatograms. So we get in contact with the physics faculty of our university, from our University of Barcelona, and we began to work with them in the design of an electronic nose. Electronic noses are artificial devices built with a set of sensors to detect gases and volatile organic compounds. Most of the electronic nose consists on various micro hot plate metal oxide sensors with different surface properties. And well, after a lot of work, the problems appear again. The resolution capacity and the technology that we had was not good enough, and also COVID arrived, so we have to stop all the investigation, and due to all the difficulties at late 2021, we decided to give up with this line of investigation. So in 2022, we started to test a new technology developed by Breath of Health, a company from Israel. This technology was based on gases chromatography, mass spectrometry, and artificial intelligence. The data generated by the infrared spectrometer was processed by an algorithm that ran an iterative modeling of linear regression based on the date of the clinical data of the patients. That means that we match the profiling of the volatile organic compounds with this artificial intelligence. So we have to feed the machine to identify and to match that this profile belonged to lung cancer. We started working with the machine, we were feeding the machine, but in October 2023, the war started. We continue feeding the machine. We give the machine around 100 more or less samples. But in May 2024, the corporation asked us to stop temporarily the investigation, but we have had no news from them since August. So after so many months without completely no contact with the corporation, we are lost in the faith in this way. So we have started to explore new options and new corporations. But in what we will never lose the faith is in the volatile organic compounds and smell approach, because this is the natural technology and nature never fails. Thank you very much.
Thank you, Angela and Vlad, for this amazing update. Next, we have Dr. Henry Hansen to talk about the relevance of rationalization of thoracic surgery departments results in Denmark.
Well, thank you for the invitation. The short version of my presentation will be, you're going to have lung cancer surgery. Do you prefer a surgeon who do 10 cases a year or one who do 100 cases a year? And should it be done on an institution that performs 50 resections or 500 resections a year? The answer is probably quite easy for you, but that's not real life. So in Denmark, back in the 90s, we had really poor survival of lung cancer, very few resections. And that led to creation of the Danish Lung Cancer Group, initiative of the surgeons, and it was approved by the National Board of Health. And for my whole lecture, you should be aware of, in Denmark, we have a pure public healthcare system paid by taxes, so there are no private business at all, at least not in thoracic surgery. And then in the 90s, the Ministry of Health looked at the quality of treatment in Denmark, and there was far too many hospitals, and there were far too low volume in many places. That ended up in recommendations published in 2004, saying that for the number of hospitals in internal medicine, you should have one hospital, the hospital should have at least 100 inhabitants to serve. For general surgery, 250,000, that means for colorectal cancer and so on, and for a specialized surgery like thoracic and neuro and so on, 1 million to 1.5 million inhabitants per unit. And that to a reduction to half of the number of hospitals during that 10-year period in Denmark. Denmark is 6 million people. And then the second step in this is it was decided by law that cancer as cardiac conditions is an acute disease and should be treated like an acute disease. And that means that from you go to a family doctor with any complaint that might be cancer, you should have a diagnosis and a treatment plan within 4 weeks, and the treatment for surgery, the surgery should be no later than 2 weeks after, so not a monthly delay. Actually, that released a new position as consultant in one of the thoracic departments, and I got that position. And in the surgeons group in the National Board of Health, there was a review, a national audit of high-risk procedures and looking at survival and length of stay and in the hospital stay. And they concluded, not just in thoracic, but in many surgical areas, that there was too many low-volume departments and probably too many low-volume surgeons. And that was also endorsing the centralization. In the same time, we had the first paper about structure of general thoracic surgery in Europe by the 2 European societies, outlining recommendations for institutions, and we used this paper in our recommendations of how it should be organized in Denmark. I'll not run through the different things. You all know the paper, and else you can read it. And it was revised in 2014, where I was part of the group revising this paper, giving European guidelines to how general thoracic surgery should be organized as an independent department with own budget and all the other things, facilities allocated to the department. We had the Danish Society of Cardiothoracic Surgery and the Danish Lung Cancer Group made their first edition of national guidelines back in 2001. And since the millennium, we are all dedicated in a specialty. So in Denmark, you are educated and certified as a cardiothoracic surgeon, but you only work in one subspecialty. And we have a national audit on all patients that die in the first months after surgery are going to a national audit, and we try to learn from the results. And the Danish Lung Cancer Registry was built in the 19th, and from 2001 it has a 100% fulfillment of thoracic of surgical patients, and from 2010 also for oncological patients. And we are obliged to report to this registry. Gives an annual report where it is also specified per region you live in and per hospital, not by surgeon. In the same time, on the political care, we had a centralization of healthcare in cutting down to 1/3 of municipalities, and for the administration of hospitals going down to 5 regions, like this. And for thoracic surgery in '96, there were 11 departments doing some sort of thoracic surgery. And 12 years later, we were down to 4 departments at 4 university clinics. Did it have an impact on lung cancer survival? For sure, the 5-year survival is now what we accept internationally, and if you look at the different regions and the curve for 1-year survival there, you see it improved immensely in the last 15 years. The resection rate is now national-wide 26%, and in our area, it's the second one, we have a resection rate about 35% of lung cancers now. The mortality for different procedures have went down, and all units do at least 150 lobectomies a year for lung cancer, and the vast majority is done by VATS. And this is 5 years, 1, 2, and 5 year survival curves for surgical patients showing a quite good improvement, and now we are on a good international level. The length of stay postoperatively have also been reduced by the centralization, going down to median 3 days postoperative stay after a lung cancer resection. So in conclusion, for this centralization, we had a set up in the 90s with inferior results in patient care, in outcome, in resection rate, and there was a political demand of effectiveness and robust care and proper support to all inhabitants. And this was supported by the academic societies, by the scientific societies, and there was a huge education going on. And we can conclude that centralization of thoracic surgery in Denmark to 4 high-volume university clinics during the last 20 years have improved the quality of lung cancer treatment in Denmark to a proper international level. And then we have to look at the future. How will it be in the future? There will be screening, other workup modalities, surgical to marginal patients, and advanced technology. So for us as surgeons, we do also do EBOS, we do navigation bronchoscopy. This is part of the surgical pathway. And for us, the whole thing is, in the future, we will have ablation and other modalities to offer, and we want as surgeons to be part of this, so we don't end up in a situation with many cardiac surgeons. They don't have anything to do because the cardiologists will do everything. In the next years, we will have surgery to more marginal patients, more advanced surgery like segments, and we need to fight the SBRT. We have lessons for long volume reduction. That means you need qualified high volume surgeons to do this proper. Next, the modality, multimodality treatment. This is a program slide from the meeting here 3 years ago, and we have had discussion in the last 3 days about N2 disease, downstage patient, immunotherapy. This is the future that again put demands on the surgeon and the number of cases you do. So therefore, I strongly advocate for centralization, and as a surgeon myself, it's really nice to have high volume and exposure to advanced cases. Thank you.
Okay, our next talk will be Jose Luis Campo Cañaveral, talking about extension of cold static donor lung preservation.
Thank you very much. Good afternoon to everyone. I would like to start thanking the organizers of this outstanding meeting. And also, I would like to thank for giving to lung transplantation a little space in this huge meeting. Usually, the lung transplantation is the little mouse in contrast to the big elephant that we have in a presentation before, and we are very grateful for these minutes in the meeting. So, My topic today would be the extension of the cholestatic donor lung preservation. I don't have any disclosures to make, and this would be the agenda, the outline of the entire presentation. I would start with the introduction by saying that our current gold standard for lung preservation is ice. Is cold storage on ice, which allows for a temperature between 0 to 4. It's really undetermined, which is the exact temperature that we reach when we store the lungs on ice. This temperature, 0 to 4, allow us for a window for implantation, which means the cold ischemia time for 6 to 8 hours. As you can see in the graph, this is a paper from 2017. We consider this already an old evidence. In this paper from this year, as you can see here, the longer the ischemia time, the poorer the graph, the early graph function. So we kind of agree that longer than 6 to 8 hours of cholestatic preservation is bad for our recipients. Of course, we have evolved from that, and we have now in 2021 papers that show that more than 8 hours using ice cold preservation, but a very refined technique in that preservation, we have equal results for the lung survival and also for overall survival. So we have evolved a little bit. But how can we significantly or meaningfully prolong the cold ischemia time? Well, we think that the improvements in the static cold preservation focus on the search for the optimal temperature can give us some answers to this question. Of course, analyzing the temperature, looking for the best or the optimal temperature for lung preservation is not new. This idea came from the late 80s or the early 90s, in which these transplant groups designed experimental research in which they saw that 10 degrees preservation allows for a better function in terms of PF ratio when they put the lungs into rabbits in one experiment and dogs in another experiment. And we somehow forgot about this. It was in 2021 when the Toronto Lung Transplant Group, as usually, retook the idea of exploring which one is the optimal temperature for lung preservation. And this is the paper they published showing first preclinical evidence and also clinical cases using this preservation. I think this paper is the first one to change everything in the last few years in lung preservation. As I said, there is a preclinical part of this study, and they designed the experimental research randomizing two groups of lungs. One group went to ice cold preservation for 36 hours, and the other group was to storage and at 10 degrees in a fridge for 36 preservation as well. So after this time, they perform for all the lungs an EVLP and ex vivo lung perfusion analysis for the next 12 hours. And not surprisingly, they found that both the function of the lung in the EVLP was better when the lungs were preserved 36 hours at 10 degrees, but also the pro-inflammatory profile and the metabolic performance of the mitochondria of those grafts was really better when the lungs were preserved at 10 degrees. They went farther in this idea of in the preclinical setting still, and they used lungs coming from pigs with lung injury using gastric juice. And they, again, divide those pig lungs into three groups. One group for ice preservation, another group for 10 degrees preservation, another group straight to transplant without any time of preservation. And then they perform a left lung transplantation in a recipient pig. Again, they found better performance of the lung preserved at 10 degrees. After these preclinical results, they decided to go for a clinical scenario, and using the protocol, the strategy of preservation at 10 degrees, they performed 5 clinical cases. The And as you can see in the chest rays, and also if you go in the paper, you will see the functioning of the lungs. They found that the outcomes were very favorable using the lungs, having a median time for first and lung preservation times more than 10 for the first and more than 12 for the second lung. After this safety trial, they designed a multi-center, non-randomized international trial using cases from Toronto, Vienna, and also from Madrid, with the idea of using the 10 degrees preservation to safely prolong the cold ischemia time and avoid overnight transplantation. In this clinical trial, as you can see in the table at the bottom, the mean time for the first and the second lung preservation was almost double than in the study, that the results that we found in the match control, which was 6 or 7 hours. But most importantly, as you can see in the bottom of the slide, the range of the cold preservation time was more than 17 and more than 19 hours for the second lung of total preservation time. You can see here the outcomes of this study, the early outcomes, the incidence of PGD grade 3 at 72 hours, which was the primary endpoint of this trial, and others with no difference between 10 degrees preservation with sustained cold ischemia time versus the match control with ice preservation. This is the survival curve, no difference at all. We used this protocol in Madrid, in Puerto Rico. We prolonged the study, and we found essentially the same. We used the very same protocol, as I said, and we found the same outcomes that we had in the multi-center trial. The beauty of this paper is that we wanted to show that this strategy can be implemented in a medium-sized hospital with a medium-sized lung transplant program, which is really important, is really what we have here in Spain. So the cold ischemia time for 10 degrees preservation was almost double of the time that the ice cooler, and the outcomes, as you can see, are resembling the same results of the multi-center trial was essentially the same. This is also a inflammatory profile that we analyzed, showing that the protective cytokines such as IL-T is much higher, is higher in the 10 degrees preservation. This is the survival curve, no difference at all. But what are the limits? How far can we go with the extension of the cold ischemia time using a 10 degrees preservation? Well, Dr. Hotzenecker just submitted this analysis for publication. We collected cases from Toronto, Vienna, and Madrid, and we divided the cases to compare between each other with the preservation less than 12 hours, 12 to 18 hours, and more than 18 hours. And with using 10 degrees preservation strategy. And we found no difference in the primary graft dysfunction grade 3 at 72 hours, and more importantly, other outcomes, including the airway complications, are the same between all the sub-cohorts, even in those lungs transplanted with more than 18 hours of cold static preservation at 10 degrees. This is the survival curve between the three cohorts. So, but if we want to really challenge the paradigm of lung preservation, I think we thought at that time that it was really a good idea to go a little bit farther with this. And again, Dr. Hotzenecker from Vienna and also in Toronto, they designed a randomized control trial for non-inferiority, in which we compare the group for 10 degree preservation with the idea to extend the cold ischemia time, and compared with another group using ice-cold preservation with the idea of doing normal transplants with normal cold ischemia times. So the primary outcomes was the same: primary graft dysfunction, grade 3 at 72 hours, and another important early variables. This is the centers that they actively recruiting patients, and this is really, which is really important from this slide. This is a report from the third DCMB, the safety analysis that they have in the interim analysis. As you can see here, the need for ECMO of the number of primary graft dysfunction is the same between the two groups, and also the 30 days survival rate. Just finalizing, we have now a new method, a new strategy for preserving the lungs for more time, which is preservation using 8 to 10 degrees. So what it does mean, it has clinical and logistical important impact in the lung transplant program. We can think about overcome geographical barriers. We can think in better selection of the recipient. We can give some treatments if they need before the transplant. And we can use that time that the 10 degrees is giving us, this time flexibility for avoiding overnight transplantation or go for a semi-elective procedure more than an urgent procedure that we have now. It has benefits for institution and also for human resources, which is really important. We have to take care of the work of the working people doing the transplant as well. And also it acknowledges for the patient safety. Just a couple of more ideas. We can go further in the utilization of the 10 degrees, and we can accept 2 or more donors simultaneously, because as you know, it's not easy to run 2 ORs for 2 simultaneous lung transplantations. So this 10 degrees preservation allow us to do the second transplant after one after another. This is another, yes, I'm just finishing. This is another example with from the Toronto group. They use 1 donor, 2 consecutive single lung transplantation, and they use the 10 degrees preservation for doing the second one. So as a conclusion, we have now a minimum, we can meaningfully and safely extend the cold ischemia time now using the preservation at the cholestatic preservation at 10 degrees. We can prolong this cold ischemia time, which means a major change in the lung transplant setting, because we are introducing flexibility in such a rigid and complex program in the hospital. And this improvement in preservation will, if not already did, change the paradigm in lung transplantation from ice to 10 degrees. Thank you very much for your attention.
Thank you, Jose Luis. We now welcome Irene Bello to present the lung transplantation, the newest therapies of ex vivo lung perfusion. Are we in the future?
Hi, I like to say the same of my colleagues. Thank you to the organization to think on me to talk about this, for me, amazing topic about the EVLP. This is my disclosure, and of course you're welcome to share if you want in social media. First of all, why we need an EVLP? So this is the numbers of Spain. Last year we had more than 2,000 organ donors. So okay, we are the best. We can perform a lot of lung transplantation, but only a bit more than 800 could be for consider to a lung donor. I mean that only the 35% of all donors could be considered as a lung donor, and only less than 60% could be transplanted at the end. So we have a shortage of lung donor. What can we do with that? We have a lot of new strategies, DCD, extended criteria, the better treatment of the donors in ICU, but we have the EVLP. The EVLP, we start to know about that in 2021. And this is Professor Stikestein. He's the person who developed, who invented the EVLP. And the EVLP is a machine who allows us maintain the lung outside of the body in like of physiological conditions. I mean, with ventilation and with perfusion. So what are we now? This is the last European consensus. They published, I think that yesterday or 2 days ago. Okay, so unfortunately, I think that in EVLP we agree that in the things that we don't agree. there are a lot of things, a lot of light and shadows about EVLP. So we agree that it's not the EVLP is not for perfusion and standard lung donors, and it's nothing related to the recipient to choose EVLP, but we can use for assess the lungs and for improve the lungs. So one of the shadows of EVLP. Okay, in 2015, they published the international this report, okay, about controlled DCD, and international they are a lot of differences in the management of EVL of these donors. Some centers use EVLP for all of controlled DCD, another not. There are some countries like in French that is mandatory perform EVLP for every controlled DCD donors. And this is a paper published this year, but this is a national results. They have amazing results, amazing survival, and the 83% of all controlled DCD donors could be transplanted after EVLP. So, okay, we need EVLP for all DCD donors, but this is the report from Spain. In Spain, it's not mandatory EVLP, and none of these results were none of these lungs was EVLP didn't was performing this in these lungs. Sorry, and here you can see that more than 75% of all controlled DCD donors could be transplanted without EVLP. So, what could we do with that? It's mandatory. It's not mandatory. But what happens with uncontrolled DCD is totally different scenario. With uncontrolled DCD in 2016, this group, they said that EVLP could be a good option for uncontrolled DCD. And last year, the Puerto Hierro group published the results for uncontrolled DCD donors, and amazing results, it's with the same results that DVD uncontrolled DCD, but they say that they use EVLP for this lung. So maybe EVLP should be mandatory for these donors, but it's a personal opinion. So for the assessment, which parameters we can use for the assessment? But this is again the consensus that we reach a consensus, and that not only we cannot use only one parameter, we need more than one to decide if the lung is suitable or not for transplantation. And we should look for more parameters than the clinical and physiological parameters to decide it. But what can we do with this? So the Toronto group helped us with the machine learning. They published that they perform a machine learning study with different criteria, not only physiological criteria, to decide if the lungs could be suitable for transplantation or not. So it seems that we are in the future. The machines help us to decide which lungs we could transplant or not. So now this presentation will be more basic research. For me, the four most amazing studies about EVLP. The genetic engineering, again, the Toronto group designed in animal model, treated these lungs to increase the interleukin-10, anti-inflammatory interleukin, with the mesenchymal stroma cells. So the results was much better with these cells, and the research in just after EVLP and during all the study. The mitochondrial therapy is a good option for primary graft dysfunction. In this study, they transplant mitochondrial in the perfusion, and they really improve the results in the interventional group. Again, an animal model. And why? Because the mitochondrial transplant, they active the ERK via, and they could enter in the cell. So again, we can change the the blood type of these lungs. This is a study from Toronto. They performed this study in human lungs, and they changed AB lungs, human lungs to 0 lungs. And the lung microbiome, 2 years ago, an American, this group, they published that there are some microbiome type that is more suitable that the recipient develop primary graft dysfunction. So this is a paper from our group that this is a protocol paper when we could change the lung microbiome of the lungs with EVLP. So this, unfortunately, I cannot show the results yet. I hope to show you in the SHLT. So as Inigo said, I'm only a person with an opinion at this moment. So I like to show another maybe the future is to have centers dedicated to improve the lungs. In United States, they perform, and it seems that it's a good results. And Europe, in the north of Europe, they are performing as well with excellent results at this moment. So I like to present our EVLP lab. We could do it thanks to the support of the department, of the hospital. This is the group. The group is performed by thoracic surgeons, from nurses, from transplant coordinators, from anesthesiologists, from bioengineers. And this is the one particularity of our group is we perform all the studies only in a research way with discharged human lungs. Okay. And this is some of the studies that we have actually. It's a European with one from with uncontrolled DCD donors with Leuven and Policlinico de Milan, and another about mitochondrial transplantation with the University of Lung. So we are in the future. It seems that we know that EVLP is safe, that we should define the indications, and we could change the lungs. At this moment, only in the research way, but I'm sure that in the future we could change all the lungs, and after we could transplant them. Maybe an option is a center specialized to recover the lungs and after send to the other centers. And something that we cannot forget, that it's very useful for research, not only for transplantation, not only for donation. It's very useful for pulmonology research, for oncology research. We can use this device for different research. Okay. Thank you so much. I'd like to thank you all the group. And
okay, excellent. So our next talk will be Lung Transplantation in War Times by Vitaly Sokolov.
Dear chairpersons, dear colleagues, thank you very much to the organizing committee for the possibility to present our recent work. I don't have any disclosures related to this presentation. Lung transplantation is a viable option for the patients suffering of end-stage lung disease, and according to ISLT registry, in prominent centers, the 1-year survival approaches 100%, and 5-year survival is roughly 60%. Unfortunately, until recently, no lung transplantation were done in Ukraine, and in cumulative charts, statistical charts, it was not mentioned as a country where lung transplantation was not done. Those people who were needed in lungs to be transplanted were sent by our Ministry of Health to nearby country Belarus or to India with a cumulative net of $100 million annually spent to those patients. But during 2019 through 2022, major changes happened in our system of healthcare. And to the Ministry of Healthcare, the new and young team of administrators came with the Ministry of Health. The task force groups were created, including Ukrainian centralized Center for Transplant Coordination. We had support from Parliament with major changes in legislation, Also media support. We developed and copied some concept of brain death, which translated into national guidelines. We spread this information through the staff in small hospitals, rural hospitals and major cities and ICU. And the most important that we had protected article for expenditure as a reimbursement for any transplant center up to 50,000 euro per case transplanted, which was something, not too big, but probably enough. Surely we were not so wise, and we went to prominent centers, including Vienna, as we had long-term established contacts with Professor Klepetko and Professor Hutzenegger. We were there for a couple of months with the whole team and the whole team of Vienna, and we continuing our contacts until recently with the current chief of the department, Professor Agner. We spent some time in 2022 in Boston with the native Ukrainian, but now he's a leading cardiac surgeon on the left side, Sergei Melnichuk, and the Thoracic department. At that time, we thought we were ready for the first case, but our neighbor thought otherwise with the military invasion to our country in 2022. Then and now, it doesn't really matter which city you're living in, because either in a small residential area even in western part of Ukraine, or in the major city as Kharkiv, as you see on the screen, which is the eastern part of Ukraine, or even in the capital in Kiev. It's one of the recent rocket attacks on Kiev. You may be killed by a drone or a rocket directly, and this was the attack to the biggest children's hospital in Kiev, with the pictures of volunteers and bystanders who helped to evacuate personnel from the building and from the nearby areas. Of course, we have other major drawbacks of any war, as any other country who is in the war condition. 75% of our electricity generation is lost now due to rocket attacks, and we need to export some electricity in spite of the fact that previously we export too much, and right now the gap from 8 to 12 hours daily in our electricity supply is a normal situation. Our sky is closed for civil aviation, so we are unable to fly throughout the country because any flying object is considered as a military target by our air defense system. Also, many people, roughly 15% of our population, moved out of the country and finding the shelter in Poland, Germany, throughout Europe, in the States and Canada, and we thank you for that you adopted those people, but we lose many qualified personnel, including doctors, nurses, physician assistants, and so on. Once again, in spite of the fact we're still enthusiastic, we construct our waiting list, small waiting list of 16 patients, mostly with ILD. We decided to use only in-house donors, so donors who are located up to 1 kilometer distance to reduce the cold ischemic time. We create a spare for supplies, and we were still contacts with our mentors. We decided to use only standard selection criteria for recipient, because I want to remind that 50,000 euros, it's just enough for the uneventful postoperative course, and we avoid extended criteria as for donor organs. As for example, for donors with long-term ICU state, with older donors, we do not have a VLP machine, so we could not evaluate those lungs who were in doubt of the availability. The same for recipient status, we decided to propose the transplantation only for younger recipient with less or no comorbidities, and not for those who are on ECMO or mechanical ventilation. And we were advised by our teachers that first case, if you wanted to be successful, should be the easiest case with a patient, with a recipient with COPD. But unfortunately, the first case was a patient with combined ILD plus emphysema. with very high pulmonary artery hypertension and who contracted COVID 18 days before the transplantation. The second patient was as well a young woman with a tuberous sclerosis complex and the lymphangioliomyomatosis as a part of the complex with the left-sided talc pleurodesis. So not the best cases to start. In spite of that fact, we use this standard technique that we were taught with clamshell incision with central ECMO cannulation, with as fast as possible extubation on the second and the third day, and early rehabilitation and mobilization of both patients. And in spite of all the difficulties, both patients were successfully discharged from the hospital within the months of the operation. If you take a look at the number of transplants in Ukraine since 2019, in spite of the wartime, the number is increasing. And if we take a look at the number of procedures done, up to now we've done 4 pairs of lungs, and the first pair of lungs was transplanted in Lviv. It's a big city on the western border of Ukraine, with the help of our colleagues from Zabrze from Poland. But unfortunately, the program now is closing because of its technical limitations. We are trying to stay in touch with other major cities, major programs, including Toronto. We visited them, and we hope to extend and increase the number of our transplantation. However, right now it's the typical intensive care unit in virtually any hospital when most of the beds are occupied by wounded soldiers with very limited number of personnel who can take care of them, and that's our major limitation for now. To sum up, there is not too much science in this presentation. However, there was too much job and effort to succeed, and the program can be established even in wartime. But we need the solid foundation and prerequisites like legislation, budget, media support, and surely the help of the teachers, of the friends, of the members. Most of them are members of ESTS and the American Association of Thoracic Surgery, and surely we need a dedicated, enthusiastic team. I want to conclude with them to thank you very much, not only for your attention, but also for the help that every country that you are presented here is helping to Ukraine in these difficult times. Thank you.
Perfect. Lastly, we will hear from Matthew Bolt how to combine surgical practice with basic research.
Gosh, another hard talk for me to follow. One of the themes of this talk was going to be that combining research and clinical practice is difficult, but clearly nowhere near as difficult as what Dr. Sokolov and his colleagues are dealing with, so thank you for sharing your experience with us. Wow. Okay, so we'll switch gears. So I'm going to talk a little bit about combining research and clinical practice. Just as far as my background, I'm a thoracic surgeon at Sloan Kettering. I spend about half of my time doing basic scientific research in lung cancer, and my disclosures are not relevant, and I'll try and move quickly so we have a few minutes for questions. But I think this is a difficult talk to give in 8 minutes, and it's also difficult in an international audience because I think every country and every health system is a little bit different. So I'm going to stick to very vague sort of general ideas, and hopefully, particularly for trainees, maybe some of this is useful. So I do think a career combining surgery and scientific research can be very rewarding. Physician scientists act as sort of a bridge between the clinic and the lab. You can see the George Washington Bridge that connects New Jersey and New York that I drive over every day in traffic. And the advantage, I think, is that pure clinicians may not necessarily be familiar with the most up-to-date science, and then PhD scientists don't always really appreciate the clinical applications of the science that they're doing. So I think that role as a bridge is really important. In the US, there are a lot of challenges in this type of position for surgeons. So while funding to surgeons has increased, proportionately funding to PhD scientists has increased even more. So the gap between PhDs and surgical scientists has increased over time. And despite surgical diseases making up about 30% of the global disease burden, surgeons really only make up about 2% of NIH-funded investigators in the US, so definitely not adequately represented. And why is that? Well, there's a lot of reasons, right? But one of the main ones is that from a hospital perspective, surgeons' work is very lucrative for the hospital, right? And having surgeons take time away from their clinic schedules to do research sometimes doesn't fit with the hospital's financial incentives. And despite this, I think the research can be very rewarding. If you look at some of the major discoveries that were made over time, many of them were actually made by surgeons. Discovery of insulin, for instance, was made by Frederick Banting, who was a military and orthopedic surgeon from Canada who won the Nobel Prize for Medicine at the age of 32. William Coley, you probably may be familiar with, was one of the first to sort of investigate the idea of tumor immunotherapy. And then obviously in a transplant session, Dr. Tom Starzl is very important for really pioneering the field of solid organ transplant. So how can we do this successfully? I think there are several models that you may find helpful. Probably the easiest from a time and resources perspective is the surgeon as a collaborator. So pairing up with, let's say, a dedicated lab researcher, working in parallel with them to provide specimens, look at data, write grants together. I think one of the challenges there is that your direct ability to contribute to the project may be somewhat limited, but still it's a very efficient way to work that arrangement. For younger surgeons like myself, maybe research under a mentor might be a good way to establish that. We'll talk about mentorship in a second. And then obviously the most high risk, high reward would be running an independent laboratory, and there are several folks that have been successful in doing that. Training, I think, just depends on your background and what sort of approach you've taken. So obviously having a PhD is helpful, but not entirely necessary. Doing a dedicated time of research as a fellowship is very important, or taking whatever time you can get to devote to small research projects. Obviously, the earlier you start, the better. And this serves several purposes: to establish a publication record, so that when you apply for grants and funding, people seeing that you've been successful, obtaining experimental skills, learning about grant writing and the science behind the ideas, and also making connections with colleagues. It's hard to really overstate the importance of mentorship, and that goes the same for clinical work versus research. It's really critical for success. Mentors provide financial support, they help you with research directions, provide equipment, space, and also feedback. Picking a mentor is difficult, right? So sometimes there's a trade-off between picking somebody who's really well-known in the field, who may not have a lot of time, and one who may not be as well-known, who has a little bit more time and motivation perhaps to help you. And depending on your project, multiple mentors may be necessary. In regard to resources, especially for surgeons, I think time is probably the most important one, right? And it's really critical, if you're going to do this successfully, to have dedicated time to allot for your research program. And you have to realize, I think, that's time away from clinical care, and maybe you may not be the world's expert in every aspect of clinical surgery, but you are doing something that you feel like is important, and I think that prioritization really sort of requires honesty with yourself and what you're looking for. And then in addition to those demands, right, we have to balance things like resident education, administrative responsibility, and family responsibilities all within a 24-hour day. So really only so much, I think, that can be done there. Not to mention the fact that some funding mechanisms, particularly in the U.S., actually require a certain level of research commitment in order to award you the grant. Other things are straightforward: equipment, space, personnel, just understanding how your institution works and how you can explore these things. Again, a mentor is really important here. And if you have core facilities that you can sort of outsource some of the technical science to, sometimes that's really helpful. Money obviously is important in any research project. If you're starting your career, perhaps you can negotiate startup funds into your contract. You can get awards from foundations. AATS, for instance, has some, STS as well. Extramural funding from government and things obviously is ideal, but sometimes, as we talked about earlier, difficult to come by. As far as picking an area of study, I think this is really important because we're competing really with pure research folks who do science 100% of their time, right? So we have to find things that really make us unique. And there are several ways, I think, to do that. One would be to investigate a clinical problem that's not really appreciated by PhD scientists. Perhaps we can leverage our access to samples, patient samples, cancer, lung transplant, these sort of things are really unique opportunities for surgeons. And also to take advantage of our surgical skills. Maybe we can do animal models, transplants in animals or other technically demanding experiments that other folks may have a hard time with. So I'll just finish up by saying that I think surgical research can be a rewarding and productive career. However, it can involve substantial challenges. Institutional buy-in, so support from your institution and your seniors in your department is really critical to protect your time and provide resources. Surgeons should identify an area of inquiry that gives them a unique advantage relative to other scientists. I think that's really important. And then once you have the idea, then being familiar with the opportunities and resources within your institution and your country, I think, are really important. Mentorship, again, is also important. And hopefully by combining all those things, you can create the career that you want. So with that, I'll stop, and let's have a few time for questions.
Thank you, Matthew. I think we now have a few minutes for general questions or reflection from the audience.
Question for Ricardo. In a research-constrained environment, how do you view, I guess, the way to, make wise decisions about investment, whether to invest in a high end to kind of bring up the peak of things versus, kind of investing in an educational program or something else that, maybe shores up some of the bigger disparities that, exist?
Well, this is a big question, Frank, and thank you for that. We have different programs in Brazil, and so it's very difficult to decide where to invest. This is for sure one of the main points. And now we've been investing a lot in things like diagnosis, and things like robotic surgery are actually more into private sectors where they also have a profit with that. So our program, our government has been investing more in diagnosis and basic stuff. So it is what it is, and at least we have also some funding from international companies that are investing money. They have also some benefits with that. And also some institutions have like taxes reductions because of investing money in, let's say, social programs. So this is the way it's been done there.
Melek Akoç from Istanbul. I would like to ask a question about dog intelligence. Congratulations on your results. It is very exciting area. I think these are, and also cute. And did you do any external validation with the study? External validation, for example, in another batch of samples, or another dog breed or something? And what do you think about its replicability? Thank you.
Yeah, in fact, we started with one dog, and now we have two trained dogs. So the second dog is able to do the same. The only thing that it's very important to reach this resolution capacity is that the train has to be very, very constant and all in the same way. So dogs are habit animals, and you can't change anything in the development of the training. So if you do always the same, you will reach good results. It's very reproducible because we are just working with the smell that it's nature ability, so it's completely reproducible. In fact, there are many dogs trained by detecting different illnesses.
I was actually curious, can dog be used to diagnose stars?
Maybe. In fact, in our second study, we realized that for the dog was much more easier to detect early stages of lung cancer than not advanced lung cancer.
Angela, how many samples do you train the dogs with? And do you try and use,
I
thought this was working, but
Uh,
how many samples do you use to train the dogs? And do you do adenocarcinoma and squamous and different histologies, or what's the strategy there?
Now, I can't say you how many samples we have used because we started with this project in 2015, so we have been working all this time. We have to stop because of the pandemic, obviously because we were working just with Excel breath, but we have been working all these years without a stop, so we have used a lot of samples. From during the first study that we published, we used around 200,000 samples, and in the second study, we used 30 samples of people that were supposed to have lung cancer. Then the doc said that only 27 of these people had lung cancer, and the other 3 were just benign lesions. And the final report after the surgery said that the doc was right. So more or less, in the 2 studies, we used around 250 samples of lung cancer, more or less.
Maybe one more minute.
Konrad Senker from Vienna. Jose, congratulations for this excellent presentation. Thank you for bringing up, the data showing that now we can preserve donor lungs for a whole day, 24 hours, which means that lung transplant is a completely elective operation. How do you convince your hospital management to give you daytime OR for every one of your cases?
Thank you, Conrad. I think it's the toughest question for, in this case. As long as you present data to the hospital by telling them that you can organize the whole lung transplant program, they will use that for, organize the OR schedule in a way that you don't want. So I think that one of the advantages of the extending the cold ischemia time lung transplantation is to make an urgent procedure to plan or pre-established procedure, right? So, but it's not the only benefit. I mean, we buy time with tender risk preservation by extending the cold ischemia time, but it's not only because we can wait 24 hours. I think we preserve much better the lungs, and we can play with the time a little bit more. We can do scheduled cancer cases first and then lung transplant, and we can do the other way around. How to convince the managers to give us more ORs, I don't know. But I still think that it's their problem. Our problem is to find clinical solutions, as we are doing, and the problem is to organize the schedule. And now they have the possibility to organize much better the lung transplant. Not having many people overnight in the hospital, not having recipients coming back and forth from their houses at, in the middle of the night. So we have reached some improvements in lung transplant programs. So the problem of the organizations, the institution, is to find a way to give us the resources. How to convince them, I don't know.
Can I take a swing at that? Because I am them.
Oh, you are them.
Yeah, so, we have 197 operating rooms, and it's not their problem, it's our problem. Administrators and surgeons, I happen to be both, but most administrators aren't. And the reality is, you, if you want to put it that way, create an enormous amount of problems for the surgeons that do regular schedules. Have you ever had a patient bumped because of a transplant? So the surgeons get very upset. So I think this is a solution that we've spent a lot of time thinking about. I think we actually need to have shared responsibility where multiple hospitals that compete against each other, which they shouldn't, because Sloan Kettering's not my competition, Columbia is not my competition, Cornell is not my competition, cancer is my competition, inequity of care and diabetes is the competition. So if all of us took resources and created a in or outpatient center with just 16 beds or ORs that then shared all of the harvesting and all of the putting in of organs for all transplantations. I think that's what we need to do. And the government can't do it because in the United States, everything the government touches, it ruins everything. But we can do it with capitalized funds. So I think it's our problem. It's not theirs.
Thank you
and
for
we
your
can
comment.
solve it.
I agree with that. So it's our responsibility. But what I meant is we are giving the scientific reasons to a better organization. So it's the manager's responsibility to have all the data and somehow organize the activity. So it's just, of course, it's our responsibility because they are our patients. But what I meant is we are giving the data, and then we now to work with the organization.
But we need to think out of the box. That's all.
Yeah, we're going to have to wrap up just because we have to start the next session. But thanks, everybody. It was a great session. Appreciate all the speakers and the audience engagement. Thank you so much.
Sound? Yes. Okay. Hey, thank you. Good afternoon, everybody. Thank you for being here. 5:30 p.m. in Barcelona in this joint meeting, and thank you for being here, because I think that this last but not least session regarding, let's see, where is my here, is session 13, a debate of robotic extended and sleeve resections, and well, we call what is the North American view and the more the Japanese view, and with a critical appraisal. So, Bob Surf is around. He wants to talk every time, and once he can talk, then he does.
If not, we can start.
Well, let's just start with. No, we can call him.
Ah, you can call him?
Yeah, we can call him.
Live?
Oh no, no, perhaps he's with a patient with the bilobectomy and the chest. So, Dr. Suzuki.
We can all call him because everybody has his phone number.
Yeah, that's right.
No, if not, we can start with the second speaker, and then we'll find out if we find Dr. Serfolio. So the second speaker is Dr. Suzuki from Tokyo, and he will give the Japanese view on the robotic extended sleeve resections.
Thank you.
Shall I call him?
Okay, thank you very much for giving me opportunity to talk on robotic extended sleeve resection for lung cancer.
Sorry.
So extended, Saf, first? No, okay. Yeah. So extended sleeve lobectomy is defined as resection of more than one lobe with a bronchoplastic procedure for lung cancer. So this paper comes from Barcelona. Professor Molins published this paper. This is a very good mode of surgery to avoid a pneumonectomy. We also published the data from our Juntendo University. We performed 255 bronchoplastic procedure between 2008 and 2022. Among them, we performed 43 extended sleeve resection. Our data is a very number of patients is very small, but our data suggests the right side is extended sleeve lobectomy is much better than a pneumonectomy. So I want to show the one of the case in our institute. This patient have 83-year-old man with a squamous cell carcinoma in the left hilum. So this is a preoperative CT scan, tumor invade number 11 lymph node, and also second carina, tumor invade second carina. So maybe pneumonectomy is indicated for this patient. So we try to avoid a pneumonectomy by the mode of surgery called extended sleeve resection type C. Type C means resection of the lingular segment and the left lower lobe. So that means we have to have an anastomosis between left main bronchs and left superior segment bronchs. This is a motion picture of this patient. We started to dissect the hilar lesion. Fortunately, this patient has a good lobulation, so it was relatively easy to insert the area of pulmonary artery. Our institute, I studied robotic surgery after observation of Dr. Sarforio's practice in the Alabama University. So almost way of surgical resection by robotic is very similar to Dr. Sarforio. But however, I like to use a monopolar electrocautery instead of the bipolar Merian. So this is the back side of the patient. We dissect the posterior mediastinal pleura by electrocautery. And for performing sleeve resection, we have to perform lymph node dissection at first, because dissecting subcranial lymph node is really important. This is a scene of dissection of the subcranial lymph node dissection for left side. You can see this is a right main bronch, intermedius bronch. So this is meticulously we have to dissect the lymph node. So we should avoid rupture, a crash of the lymph node, because all of these lymph nodes is a swollen lymph node. So there might be a cancer cell in the lymph node. But the final pathology, this patient have just only tumor cell in the higher N1 nodes. But however, we have to perform a meticulous operation for this area. So then I try to manage pulmonary artery in the hilar lesion. I like to use a stapler and a Penrose drain beneath the pulmonary artery. And then this is a hilar lesion, dissection of the hilar lesion. So you can see this is station 11 lymph node. This is station 11 lymph node, and the stump of the pulmonary artery. And I'm dissecting left superior bronch, which should be preserved for this patient. So even for hilar lesion, lymph node dissection is really important for such advanced lung cancer. So you can see this is a V3B. So we should dissect the below caudal side of the B3B. Then we can go through to the anterior side. This is the anterior side of the, I'm dissecting a pulmonary vein, a superior pulmonary vein with electrocautery and cut the lingular vein. So again, this is a hilar lesion from the backward. And caudal side of the left V3B, I could find the way to go with a stapler to divide superior segment and the lingular segment. Of course, I like to use ICZ for identify intersegmental plane when I perform a segmentectomy for lung cancer. So Firefly system clearly showed a boundary between the lingular segment and the superior segment. So then we could isolate the superior segment, which should be preserved for this patient. So now we are starting to dissect bronchs. This is a management of the distal side of bronchs, superior segmental bronchs. And then we cut proximal side, that means left main bronchs. As you can see, all lymph nodes in the subcranial area should be removed for isolating left main bronchs. This preparation is needed always when we perform bronchoplastic procedure. So now we reject the tumor cell with the lung. So now we start to anastomosis. I do not like to use telescope manner of anastomosis. So this kind of trim is really important. So especially for distal side, not too long, not too short, is really important. So you can see distal bronchs should be, I like to make the distal side of the bronchs very short distance from the lung parenchyma, because this portion is blood flow for this portion is comes from the lung in the bronchoplastic procedure. So we like to use 3-O-prolene. On thoracotomy, we like to use 4-0-prolene. In robotic procedure, I like to use 3-0-prolene. Double-armed, we make 28 centimeter double-armed prolene. We made it by ligating the two prolene. So anastomosis using a 28 centimeter long 3-0 prolene double-armed suture created by ligation. So we perform a running suture for the anastomosis, this kind of operation. And we rarely perform adjustment of the difference of the orifice. So because distal side of the bronchs have a scattered cartilage, so distal side of the bronchs is can enough broad to be anastomosis for the bigger proximal bronchs. So it is important to have enough tension to continue to this kind of anastomosis by robotic procedure. As Professor Saforia said in the morning session, if we have enough space, such kind of anastomosis is very easy by a robotic procedure. So I think this kind of type C and type D, that means the resection of the lingular and the left lower lobe, or right side, middle lobe and the lower lobe. Then anastomosis between left main bronchs and left superior segmental bronchs, or right side main bronchs and right upper lobe bronchs is really easy by a robotic procedure. I think for sleeve resection for right upper lobe is relatively difficult by performing robotic procedure, I think. So we confirmed no air leakage at all. So this is anastomotic side. So we used such kind of prolene. We made it. So this is the post-operative findings. Because this tumor was very huge, big, so that's why incision is relatively big, but the patient was very, post-operative course was uneventful. So I think modern thoracic surgery, characteristics of modern thoracic surgery is not only minimally invasive surgery for early lung cancer, but also very safe, complex surgery such as cranial reconstruction, autotransplantation, pericardial conduit by using robotic technology. So salvage surgical resection sometimes performed after definitive chemoradiotherapy. The firstly, this kind of report was made by Professor Joshua in 2004. They reported a very good result even after surgery, even after very high dose chemoradiotherapy. And a similar result was reported by Professor Dagwood, and also Frank also reported as a similar very good result. So this is a case. Patient underwent 60 gray chemoradiotherapy for lung cancer, resulting tracheoesophageal fistula. So this patient have referred to our institute. So we discussed with the patient, and we decided to perform operation for this patient. Now, of course, we found a very severe fibrosis in the hilar region because of the high-dose radiotherapy, and also inflammation due to tracheoesophageal fistula. So we had to perform 3 right-side sleeve pneumonectomy and the total esophagectomy for this patient. This scene, the esophagus was already removed, dissected, and cutting left main bronchs. And then cross-field ventilation was established. And this is a cut of the proximal side. And we performed anastomosis. Could you proceed a little bit ahead? Go ahead. So it was very difficult to mobilize in the proximal side and also distal side. But finally, we made anastomosis for this patient. So after 1 month after this operation, I requested esophageal surgeon to reconstruct esophagus with a gastric tube. So such kind of operation can be performed in the recently. Some of the reason there may be surgical skill and the surgical mode of surgery is improved, but also I think especially radiation modality is much sophisticated. So such kind of operation was impossible in the 1980, but now is we can do it, I think. So a lot of reports confirmed similar result. Almost surgery after high-dose chemoradiotherapy can be performed safely. And also recently, we had a patient, 73 years old man, which had a squamous cell carcinoma in the left hilum. And 60 gray radiation was selected for the treatment for this patient in the previous hospital. But unfortunately, patient got local recurrence after 60 gray radiation. So this is a salvage surgery after 60 gray radiation. Though we performed 3 left upper lobectomy with a robotic system. This operator is a young thoracic surgeon, 12 years after graduation with the medical school. So as Professor Taforio said, if we have enough space, such kind of anastomosis is really easily performed by a young thoracic surgeon. Okay, this is my last slide. Robotic extended sleeve resection was presented. Robotic salvage surgery was also presented. The role of robotic surgery for complex operations should be evaluated in modern thoracic oncology. Thank you for your attention.
Bob, that's your time.
Well, it was great to go second. Would have rather just sat there and watched more of you. Would have learned a lot more watching than me talking. You learn nothing when you're talking. So again, I'm honored to be here. I want to start the way I finished, and I really want to say what makes these meetings great is the people. Yes, the science is great, but I've been friends with Laurie since he was a little boy, and watched him grow and everyone, and it's the relationships that we have with one another and how we make each other better. And that's what it's about. You know, I woke up today, I want to be better. I watched that last video of yours, and I know you said you learned robotic surgery from me. Well, I just learned some tricks from you, so thank you so much. And when you started this in Japan, there was a lot of pressure. So, congratulations for what you've accomplished there. You changed the entire paradigm. Conflicts of interest, I don't have any since I've served as an administrator. I had to get rid of all of that, which was just fine. And I have none now at this system role thing. And again, I started off saying, everyone in this room got up early today. You got up, you showered, you got dressed. Why? Why do we do all this? Well, yes, we have to support our families, but we do it because we get to help patients. And I work with so many people that make so much money that don't get to do what we do, and they can have the money because we're on the right side of it. As long as we're doing it to give patients better care, which is why I push chest tubes and length of stay, as long as it's for patients to get better care, the money comes. If you do the right thing, the money will come. So we're on the side of doing things that take care of patients. We're lucky. These are my conflicts of my books. And then I would say it goes back to these 4 things. And as an administrator, I want to make sure that my doctors and my nurses and the 57,000 people that work at NYU are getting more money and a better life. I work for them. They're my boss, and everyone in this auditorium is my boss. We work for you. If we're not doing these things, giving patients better care, improving patient better experience, improving provider better experience, if the doctors aren't happy, or if you need another robot, I'll buy you one. I got 36 at our hospitals. I'll get you a 37th if you're going to need it, and it's going to help patients. We're happy to do it. But I'm going to make you send them home on post-op day 1. I don't want to hear about a stupid chest tube being left in because you put 300 cc's out. Who cares? Take the tube out and send them home. So we're going to give you what you want, but we're not going to let you sit in there and feed them for 3 days, hot dogs and hamburgers, when they could have been home 2 days earlier. So we're going to push you to get better, and we're going to push you to actually not just provide better patient care, but not be so dogmatic. And finally, I put this up because 20 people, please just take your phone out and take a picture. Please do that. Again, I work for you. I'm not going to show 12 videos in the next 8 minutes. I'm going to just show 1 or 2. There are 90 videos on my YouTube channel. You go to just put in Surfolio surgery or Surfolio videos or some damn thing. It comes up. You can watch them. But we'd rather have you come to New York. I used to be in Alabama, as you mentioned. Now we're in New York City. The restaurants are just as good in New York as they are in Birmingham. Happy to have you. So can you put my 1 slide up? Now, God in heaven, I hope it's a left upper lobe sleeve. We just put the 1 video. We took out the other 6 so there wouldn't be any confusion. Can you run that video for me? Hopefully. So good, just let it run. Let's try to make it simple. When you're going, and I think our perspective is the same, it's play it. Thank you. Be organized. Take the lymph nodes out first. So start in the inferior pulmonary ligament. How do you want to reduce tension on an anastomosis? Take the ligament down. Free up the pleural all the way around the lung. Notice when we use a bipolar, we don't use a monopolar here because we're teaching. So we think you have less risk with a bipolar, especially with young residents. So we use this. Notice when we pull away from trouble. We don't pull into trouble. If that's where the current laryngeal nerves, I'm pulling away from it here. We're going to free this up off the phrenic. This patient had chemo and immuno, like all of our patients, was told at another hospital in New York they needed a pneumonectomy, and we said we think we can do a sleeve. Just because you had radiation and chemo and immuno doesn't mean that you don't. And the key is to get in there quickly. So if you can get in an immunotherapized field, I don't know if that's a word, I made it up. Sam, I hope that's okay, immunotherapized. If you can get in a patient within 2 or 3 weeks, it is not that bad. So, and again, dry everything up. If you need to get proximal and distal control of the pulmonary artery, the distal control is there, the vein. That's your distal PA control, all right? Let it run, let it run. So you're going to complete your fissure. You're going to take your lymph nodes out. You're going to do what you need to do. We usually don't use clips on the PA, but we had a visitor there that day said they use clips. I said, okay, I'll try one. I didn't like it, but they were doing it. So when I have visitors, we try to do things a little bit differently. We're going to, try again to get around structures. If they're stuck, If there's cancer in it, you do not need to dissect the PA off the bronchus. Just cut the bronchus. Someone was just asking me out there, does that mean I staple part of the bronchus on the PA? No. Cut the airway on one spot, get inside the lumen, take a robotic knife or a robotic scissors and cut the back of it and allow the airway to come away from the artery, and everything is going to free up. I see more videos of surgeons who get in trouble because they didn't just stop and cut the airway. Cut the airway if you can't get around the artery. Don't even waste more than a minute or two. All right, so this is going to be a left upper lobe. Here you can see we got into a little bit of bleeding. We're just going to control this. Grab it with your left hand. I didn't feel like I needed to get proximal or distal control here, but this is very, very stuck. So we'll let this play and you can sew. Now, you're using Proline on the airway, and I think we should have a debate on this because I don't like a non-absorbable suture in the airway. I feel strongly, maybe not without data, that you should use absorbable sutures in the airway. They get less problems. I see some people's head nodding. But in any event, so we're going to use a Stratifix. It's faster. I don't have to tie any knots. And someone like me, I've made every mistake in the world. My suture gets tangled. I break the suture. My knot comes off. So with a Stratifix, it becomes less errors. So here, what we're doing is dissecting out distally onto the airway. We're going to clear all this up so we can get to the A1, A3, which in the United States, some people call the widowmaker because it makes patients widows. It's a bad problem. So if you're going to do a left, even a straightforward left upper lobe, I will make our junior attendings cut a regular, easy left upper lobe bronchus. I'll have them practice and cut this, cut the B4, B5, come back and cut the B1, B2, so they know this trick, so when they get in trouble, they can cut the bronchus first. Now look how easy it is to get to the trunk. The truncus, the A1, A3, is wide open. So if there's nothing there, you should practice these techniques. Practice getting inside the pericardium and around the main pulmonary artery, which is, we have many videos of that, okay? So now we're going to finally take the A1, and let's be honest. When this happens, most of you relax. You take a nice, big, deep sigh, like, okay, great. I don't have to worry about the big artery. But now I've got to go ahead and do a sleeve. So there's a few tricks. Every operation has 6 or 7 tricks. Right-sided sleeves are incredibly easy. They're really PGY3 or PGY4 cases. Right upper lobe sleeves are just routine cases. But if you're doing a left upper lobe sleeve and you're doing it from the left chest, you have to protect the recurrent laryngeal nerve. And one of the things you want to do is get the pulmonary artery or aorta out of the way. I mentioned to put a large loop. Now, they couldn't get my usual loop here. There it is. Now they brought it in. It was blue. It's the white one. Thank you. So it shows the mistake we made. Typical Cerfolio had the wrong loop. But there is a nice giant loop around the pulmonary artery. And watch what happens when you get structures out of the way. So, yes, we guided where to do the bronchus. We put a bronchoscope in. We used Firefly. As I mentioned before, when I'm taking the trachea at the innominate artery, I put a silk in it so it doesn't go up in the neck. When I'm cutting the left mainstem bronchus right by the main PA, I'm going to put a silk in it so it doesn't retract underneath. And we're going to get negative margin, ensure the margins are negative. It's okay to cut into the tumor. It's actually faster. You can do these operations 2.5, 3 hours, skin to skin on the console time, under 2 hours, actually, if you just cut the airway in half. Now you trim this up exactly as you were showing. Kenji would do the same thing. We send these all in for frozen. I'm now going to take a 3.0 Stratifix. They're 30 centimeters or 12 inches. This is what we like. It's a nice needle. It's easy to work with. And look what happens when you set the anastomosis up. We freed up the left mainstem proximally. We freed it up distally. I used to put a single lumen tube in and do a bronch at the end 12 years ago. That adds 30 minutes. I don't do it. I wash the airway out now. So at the end of the case, I don't have to put a single lumen in bronch. I can just bronch as we're going, okay? And now it's just really a chip shot. And if you want to do it, you'll see on our YouTube channel, we do a couple. We do the cartilage first, usually. This one has absolutely no tension. It's just a straightforward sleeve. And you're just going to do the posterior membrane first. And actually, I had a visitor who says, you know, you never do the membrane first. I said, okay, we'll do the membrane first today because it was something new for me. I want to get better, so we tried something different. Usually we don't do this first, but it shows you how you can set it up. The key to this operation is, why is it so easy? It's easy because of how we have set it up. Pulmonary artery out of the way, all the lymph nodes out of the way, the ligament taken down, the left mainstem completely freed up. The two ends literally fall together. You know, if surgery isn't simply awful, it's awfully simple. So it should be awfully simple, or it's going to be simply awful. The way you make it simple is by mobilizing things and exposing them. And getting around the aorta and pulling that out of the way. If you're very proximal left mainstem, or here pulling the pulmonary artery out of the way, you see all the room you have. You don't have to worry about your needle hitting the pulmonary artery here, because all I'm doing is pulling the PA out of the way with robotic arm number 4, as you can see on the screen. A couple of other tricks. As I said before, we don't want to tell the anesthesiologist we're going to take the double lumen out and put a single lumen in bronch. We put the bronchoscope in. There we are using Firefly, but no ICG. We suck all the blood out. We put a sucker in the airway as we're going and wash everything out, again, to save us time, because these patients are going home tomorrow, post-op day 1 at 8 o'clock in the morning. I'm not even giving them breakfast. I want them out before breakfast. There's no reason to even feed them. In fact, maybe our next speaker will talk about how he puts food downstairs and makes them get out of bed and go downstairs to eat, and then just locks the hospital room behind them. That's what we probably should do. You want to do a leak test? Great. I think they have false negatives, but we all do it. We usually don't irrigate. Irrigating just costs money and wastes time, but in these cases we do, to make sure there's no leak. The chest tube goes in, and if there's no leak, the patient wakes up without a chest tube in. There's your remaining part of a margin or a specimen if you have. Please make sure you get those out. Don't forget those. And these patients should wake up without a chest tube. Just because they had a sleeve doesn't mean they need a chest tube. So I think I'm out of time, but with that, that's my 2 cents. Thank you.
Thank you.
So I would like to invite Elias from Marseille to give his view on the two speakers.
Thank you. Thanks again. It's a privilege, even if it's going to be... okay, it works. It works? Okay, great. It's going to be difficult because my main disclosure is this guy, because I learned from him. So to be honest, a critical appraisal for sleeve resection, not sure to be the most experimental guy. In our mind, when we think about complex and sleeve in thoracic surgery, we think more about that guy. So my hypothesis, me, with this, could be like him. No, unfortunately, it's definitely not. He's a genius. So for a normal guy, is there some hope? So I went to Barcelona, as you, and I go to the church, and we have some answer from our colleague in Barcelona. In 6 months, you can do a wedge to a sleeve resection when you use the robot. And let's see if in my hands I'm able to do that also, so in your hands either. Some difficulties were well explained by my colleagues. It's challenging procedure, so I will not let you know that it's easy in my opinion, but it's not easy also with open thoracotomy. I think we should never compromise our technique, our resection, regardless the approach. So I do exactly the same with a robot than I do in the past with open thoracotomy. And the best way to learn sleeve resection is to do lung transplantation, I think. Is the robot a good solution? In the literature, it seems to be good. The beautiful paper from our colleague in China compare VATS, open, and rats, and it seems to be a good approach for this kind of complex procedure. So this is some of my tips and tricks I learned from him, and I will try to show you just one video. As he said, it's the easier one on the right upper lobe to summarize all of these tips and tricks. So here is a a big mass with endoluminal and extraluminal development. Here it was at the beginning, then the interventional pneumologists remove it, and it's not complete because the posterior part, and we decide to go for right upper sleeve lobectomy, and that's the beginning of the surgery. You already see the local recurrence of the lesion inside the bronchus, and very close to the carina. So we knew that we need to have very extended resection on the right main bronchus. We start with the fissure, with adhesiolysis. I always take the pulmonary ligament, but for sleeve, with open thoracotomy, I also open the pericardium, like a U shape. So I do the same. I don't know if it's necessary, but for sleeve, I do it in order to release totally the tension, to have a tension-free anastomosis. Because I learn like this with open, I do the same with the robot, but maybe it's not necessary. You are more experienced than me. And we continue with the lymph node dissection. Here is the mass from the posterior part of the right main bronchus. We dissect the subcarinal lymph node, and we remove the azygos growth in order to have the best exposure as possible. We now liberate station 11 to at the level of the secondary carina, because I think it's always better to remove first the parenchyma. So I remove the parenchymal resection, the tumor, and finish with the reconstruction part. So we open the posterior part of the fissure, ascending A2. It's an old video, so that's why we have the assistant stapling. We can do now by ourselves with the robotic stapler. We now take the vein. We are able to see our posterior dissection. We go ahead with superior truncus. All this lymph node should be removed to clear the bronchus for the reconstruction part. So now we remove the azygos growth, finish some lymph node removal, also 2 and 4 station zone. Like this, you liberate the proximal and distal part of the anastomosis. Okay, we now take the fissure and ready to finish with the bronchus. So once again, I think in my mind, the multi-port approach is very nice to always have a good exposure for your stapler or your camera. So we now liberate the distal part of the future anastomosis. I like to turn around the intermediate bronchus to really push the artery far away from the anastomosis. You can use vessel loop or a lot of elements to have a clear field and enough room for your next part of the surgery, meaning the reconstruction part, where you definitely need enough space. So here we remove the proximal part, so very closely to the tumor, but we decide to go here to have a better exposure once we will remove the specimen. Because with the specimen, sometimes it's difficult to see exactly where you cut, so we decide to remove first the specimen. I choose this video, you will see, because it's, as you said, easy sleeve, but we face some issue even for this kind of less challenging sleeve bronchoplasty surgery. So this is the distal part. We finish the resection, and we're gonna now check for margin with frozen section. And here is the beginning, I think, of our trouble, because we clear the left main bronchus for oncological reason. We remove all the lymph node, but we use maybe too much diathermy. We remove the proximal part in order to check for margin in frozen section. So one more ring. Very proximal now from the carina.
Is this a carcinoid?
Yes.
Typical carcinoid?
We don't know at that time.
Looked like a typical.
Yes, at the end. And here is the beginning. Look at the beginning of the next trouble. Too deep. So you see the blue, it's the balloon of the double lumen tube on the left main bronchus. So now we are in danger because we need first to stop the problem, and then we will do the reconstruction part. So we ask the anesthesiologist to deflate the balloon. You be sure to not take it. And I like also the Absorbal PDS 3.0 for, in general, it's not the case here, but it was, in general, I prefer Absorbal suture for the bronchus. And I put some interrupt suture, some stitch, to first repair my previous accident. So I close the left main bronchus, and I check with the anesthesiologist, okay, your double lumen tube is moving. Okay, now I'm gonna lift up the lung with a gauze. I did it in open, so I do it the same with the robot, to release the tension and to make the anastomosis much more easier. It's like VLOC is not Stratifix, but it's the same. It's a VLOC 3.0. And we do two running suture. We start from the posterior part, 3 o'clock to 9 o'clock. And I agree, it's the easiest moment of the surgery, but the most difficult was to come here. We now do first the posterior part of the anastomosis. And you have always two hands to do your anastomosis. I'm not able to do that by VATS. I'm not good enough, but with the robot, as you said, it's easy. But I don't say this is the easiest procedure, because the most difficult was to come here. And now we do the anterior part, 3 o'clock to 9 o'clock.
forehead? Why not just go forehead?
I don't know.
Show off your skills.
Yes. Okay, it's the end. Like you, I don't know why, just a better, the clip. We don't need it. And because it's not a common procedure in my hands, I use a drain. We check at the end of surgery if everything is okay with endoscope, and that's it. In the future, is it possible to go in routine in this kind of very challenging case? It seems to be, especially in China, but honestly, keep in mind that I think it's complex procedure for experienced surgeon with high volume center. And I like Paula about this commentary. The approach should not be the matter of debate. Thank you so much.
Okay, so this is open for debate. I have some technical comments. We saw some videos with burning on the bronchus. So in my early experience, I had 2 cases of severe stenosis that I attributed to too much burning on the bronchus value. So we have the scissors, and it's a monopolar, and it's very easy to burn and cut, but I would say if you don't do a recut, don't burn.
So you saw that we burn in the tumor and then cut outside with it off. And I would have said, as of 3 weeks ago, we've got 53 of these with no strictures. I got one now. Got a woman from Boston who we did 3-4 months ago, and she has a stricture. But we just went back. Yeah, well, she was very smart. She wanted to come to a place where she would go home in a day and have no chest tube. Isn't that interesting? And actually, she had no money, so you didn't want her. She was on Medicare, or excuse me, Medicaid. But in any event, I don't know, we went back and looked at the video. We actually didn't burn it at all. It was a very easy But she also has some inflammatory other disease. But in any event, besides her, we've had no strictures or problems. But I think your point is well taken, that we kind of burn where the tumor is, and then we just turn the scissors. We actually unplug the scissors when we give it to the resident, or even myself, and then just cut to get that last circle to get a margin. I don't like to do a prophylactic pericardial release because of the AFib rate. Now, you may say, who cares? They go home in a day. We don't know if they have AFib, but if they're symptomatic, they come back. So we do not do a pericardial release. I think in that series on the right side, we only did 3 where we needed to do it. So we rarely need it. And we take the 2s and 4s and go a little higher up on the trachea, go under the innominate, and release the trachea to come down on the right side and really mobilize it. And mobilize the right middle, right lower lobe junction. And we have that on our YouTube channel. That's a very important part to bring the bronchus intermedius up and the trachea down.
Okay. Another problem that I saw in the beginning with our experience is that we had some air leak between the stitches. And so what I do now is that always, before I make my knot, I take a needle and I just, like a nerve hook, I pull on each wire. And since then, we never had these air leaks that can be sometimes troublesome. And you
use a barb suture?
Yes, I did. Yeah, but even then we had some. Yeah. Okay, some questions from the
Frank. Yeah, Surf. Question for you. So I'm just a little bit unclear. Can you clarify how many days post-op you leave the chest tube in?
Let me make it very clear. 0 hours is the goal. Unfortunately, we fail in 30%, but yes. Thank you, Frank.
Okay, I think we have to wrap up.
That's good.
There's a question there.
Oh, yeah. Micro there, please. She has another one in the other corridor.
Hi.
Next, Paula.
2 questions for Dr. Suzuki. First thing, you showed a material 3-O-proline double-ended. So do you get that in market or it is a custom made? Second thing, you have shown a video of salvage resection with sleeve resection. What is your suggestion about putting a vascularized flap over the anastomosis or any sealant? So do you routinely advocate or use, or it's okay without any?
Now I do not use coverage for sleeve resection. I always cover bronchial stump with the right side pneumonectomy or sleeve cranial pneumonectomy. So because I have one case after insertion of the pericardial fat pad between the pulmonary artery and the bronchs, and when we perform a right upper sleeve resection, postoperative atelectasis of the middle lobe, resulting in necrosis of the bronchs. So I think in case of sleeve resection, we have usually we have not so enough space to insert something. So I do not usually insert anything.
I don't cover after radiation either anymore.
Not
Except
even
for right pneumonectomy.
not even in salvage.
I use a thymus. It's fast. I think the muscles die. You know, I'm insufflating CO2. We do an intercostal. They blow up. So on the right pneumonectomy, we put a thymus if they've been rated. Otherwise, we don't cover anything.
Okay.
Yeah, just a comment on a question. One of the things that I do love to add to complex sleeve resections is the video mediastinoscopy to mobilize the upper airway. It really releases everything. I know you guys, robotic surgeons, probably can do that better than us using the VATS technique, but I really find it beneficial both in the right and left upper sleeves if you need to do. The other point that I was going to ask is PDS versus Proline. So, you know, I have had more cases of PDS being spit out by the patients, and I've never had cases, I've had more cases of Proline being spit out by the patient.
Yeah, that made me feel better because I've never had PDS. It dissolves.
Yeah, none of the PDS. So I really like the PDS also for those issues.
So I'd comment on I've said it a few times. I used to do mediastinoscopy all the time since 2008 when I started doing the robot. I wasn't as brave going up high, but now we go way up on the innominate artery with the robot. We don't do media. And who wants an incision on their neck? And in some cultures, that has some real significant negative outcomes. So we don't do that anymore.
Yeah.
But
in the left side is a little bit different, right? The mediastinum is right there. There's a limit to mobilizing.
It is, but if you cut it and pull it out, and you watch a couple of our videos, you can dissect it all the way back pretty well. But you're right, it's not.
I think
as
that
easy.
if at least me, I'm very focused on training my fellows. I like to make the procedure very safe. If you need to go at the beginning of the left main bronchus for whatever reason or close to the carina, I find it much safer and easier actually to do.
So I guess I would say I want to make it safe and I want to train too, but I also want to train them how to be efficient. And you don't need to do a mediastinoscopy.
We're never going to win your efficient argument.
Okay.
I don't have that goal.
I have also a question for Professor Suzuki. So I was impressed by your video. You leave some segments behind. What is the minimum volume of lung that you have to leave in a chest? Well, if I think about it, I would never think of just leaving the middle lobe in the right lung. So what is the minimum that you have to leave and where you would do a sleeve resection?
So I have no definition, but after type C extended to sleeve resection, superior segment is very small, but after 1 month and 6 months later, lung expand very big. So I almost always try to preserve some amount of lung. But for example, I don't want to preserve just a segment 3, segment 1, no. So maybe left side, the superior segment, right side it should be right upper lobe.
Three segments.
Yeah.
Well,
yeah.
but Herbert, I think it also depends on the time. So if a patient's had a bilobe 15 years ago on the right side, and now let's just say they have a right upper lobe left, that space is so small you could leave one segment. So I think the answer to that is it depends on the patient's history. I've had a few of those where you would leave one or two segments in a chest that you would never do on a virginal chest. So I think your answer depends a little on the patient's history as well.
Let's begin. Regarding the protection of the suture, I would like to know if you SERF is not going to protect anymore.
No.
Stop doing. But I would like to know your opinion about that, the vascular or the bronchial one.
Coverage?
Yeah. Protection with coverage.
Yeah, I usually use a pericardial fat pad.
Used to do.
Yeah, but now I do not use a coverage at all, even after radiation, high dose radiation.
Good, the same.
I try to put only some fatty tissue if I find it easily, but I will not take some muscle or some pleura and never perform any salvage surgery with a robot, so I don't have this experience. But I try to simplify as possible, keeping in mind the same principle than the open.
Then I think I'm going to send you my next case because I think it'd be a great experience for you. So the next salvage case we have, Kenji, we're going to send it to Ilias.
So, any other question from the floor? 6:30. So, thank you. Thank you very much.
Thank you very much.
Hello? No. Sergi? Juanjo, Juan Carlos, Mark, Pepe? Yeah? Okay. Ramon, go ahead. Yeah, on behalf.
Well, thank you for staying so late today after 3 very intensive days of full immersion in thoracic surgery and thoracic oncology. It's very nice to see the room almost full at this time of the day. I think that speaks for the quality of the scientific program, the quality of the speakers. Most of you didn't want to miss any lecture during these 3 days. So as I mentioned before in the previous editions, your presence here is very stimulating. I think that talking in the coffee breaks, you have given us new ideas to prepare a scientific program in 3 years from now. And I really appreciate, we really appreciate the fact that you have come from many more countries than in the previous editions. So the message that we want to give to the thoracic surgery community around the world is that this is open to everybody. So we really appreciate coming from all those countries far and near from here. No Zoom meeting can beat a face-to-face meeting. Zoom meetings is like a palliative therapy, right? I mean, it's not what we want. And as I mentioned the other day, a very trivial conversation in a coffee break may save a patient's life years later, because those messages that we get from our colleagues stay in our mind and they pop up at the right moment when we need extra information to save a patient's life. So thank you, enjoy the rest of your stay in Barcelona, and I hope to see you next time.
No, I just want to, I mean, we began with Ramon, this joint meeting with the international workshop joining to our meeting on general thoracic surgery. Then Pepe in São Paulo came and Mutua Terrassa joined us. And well, here are the new generation. I mean, we are happy, we are in good shape. We want to follow and to continue giving this because it's so nice to be in the corridor and many people came and say, look, this is perfect. We enjoy it very much. Even the place. I mean, we found each other during the meeting. But the future is here. Juan Carlos, Mark, Juanjo, and Sergi. We want you to follow, and we will be there, and we try to do our best. So if one of you wants to say something in behalf of the other three, or Carlos.
No, thank you to all of you, because it's an honor to celebrate this meeting with all of you. I think it's crucial to have to maintain the quality of this meeting, to have these speakers, this audience, and I think I speak for my colleagues. It's an honor to organize the meeting with these three people, Ramon, Giuseppe, and Lore. And we will try to continue the quality, but the quality it's not possible to continue without you. Thank you.
Okay.
Just 1 minute. Once again, to thanks our technical secretariat, that is Acto Survey, Luna, and Uriol, that are there. And also to thank the generous support and commitment of the sponsors that are not here now. Because without their support, probably this meeting would be more difficult to celebrate. And in the end, we work all together to a better life, to a better and healthy future for our patients. Thank you very much.
People from upstairs. Running the video,
yes,
up, down, stop, go,
upstairs.
go.
Yeah.
Thank you for the technical people there. Okay, so let's go.